별로 안 좋아요.
많이 없으세요?
진호가 잠깐 활동 운동량 많이 없어.
쉬면서 계속 드셔야 되는데.
진호가 이게 어느 순간 되면 이게 탁
네.
넘어가면
네.
근데 괜찮았어. 저기 어디 갔나? 저기 어디 있어? 그 CV가
CV 여기.
있을까? Good morning, ladies and gentlemen. My name is Myung Chanjo from Chungbuk National University, and my co-chairman is Kwang Il-kim from Seoul National University Bundang Hospital. It's a great honor to chair this very important session during the Hypertension Seoul 2024. We have four eminent speakers and four panelists. We'll discuss at the end of the lectures. It's a great honor to introduce the first speaker, Professor Kei Kamide from Japan, Osaka. He is the current Dean, Division of Health Science, Osaka University Graduate School of Medicine. He is a specialist, especially in hypertension and geriatric medicine. The title of his talk this morning is Hypertension and Geriatric Syndrome in the Older Adults. Professor Kamide, please.
Good morning. Thank you, Chairman, ladies and gentlemen. First of all, congratulations for 30th anniversary Korean Society of Hypertension. I'm very honored to be invited in this wonderful Hypertension Seoul 2024 meeting. I really appreciate for Professor Jin-Fo Singh, President of KSH, Professor Jeng-Fong Singh, Chair Scientific Committee, and Professor Seung-Hwa Park, it's my good friend. So it's my pleasure to present about hypertension and geriatric syndrome in older adults in Symposium for Hypertension and Frailty. I'm Professor Kamide in Division of Health Science, Osaka University Graduate School of Medicine. I'm a specialist for geriatric medicine and hypertension. Currently, I'm teaching and doing research for under and postgraduate students of public community health nurse and home medical care as a full professor. And I am also have geriatrics and hypertension outpatient clinic in Osaka University Hospital. Japan is one of the countries with the highest life expectancy in the world. In Japan, we have already faced the situation we concerned its super aging society. In 2023, as you see, the mean age of male is 81.1, female 87.1 years old. And we expected that our life expectancy in 2060 will like 84.2 for men and 91 years for women in Japan. People age higher, 65 years old, will be about 40% of total population in 2060. So we can say one support, one elderly era is coming soon. In Japan, we are faced with Japan's 2025 burden. This year, 2025, next year, is when baby boomer generation becomes over 75 years. Estimated number of very elderly population aged 75 years and older, more than about 20 million 2025. And percentage of a very elderly population will increase more and more due to falling birth rate. The percentage of the elderly over 65 years is about 29% now, and will reach about 30% at 2025. The biggest factor in Japan, the becoming a country with long life expectancy, is the enhancement of its social security system, including medical and long-term care insurance. But cost for medical and long-term care insurance services are increasing very much. This will be a serious problem in Japan. Thus, the extension of healthy life expectancy, so-called as healthy longevity, is desired in Japan. There is a gap about between healthy and average life expectancy, but 10 years. So it's supposed to be very important to clarify the factors contributing to the healthy life expectancy. 3 pillars for healthy longevity are supposed to be exercise, good nutrition, and social participation, classified by our study and some previous studies. They are also recommended in the elderly health promotion by Japan's government strategy. And we think that medical care, especially management of lifestyle-related diseases, including hypertension, is very important for accomplish healthy aging. Today, I will talk about this topic, focusing on the appropriate blood pressure management. To establish the way of healthy aging and longevity, we are investigating factors influencing on the healthy aging in SONIC study. SONIC study is septuagenarian, octogenarian, nonagenarian investigation with centenarian. It started from 2010 by medical, dental, psychosocial researchers in Osaka University, Keio University, and Tokyo Metropolitan Institute of Gerontology. Until now, there are over 100 publications from SONIC study, which is one of representative cohort study for older population in Japan. Today, I introduce some findings from SONIC about blood pressure research. Method of SONIC, we analyze the subject of SONIC study who participated in the survey for the both baseline and follow-up study every 3 years later. Participants are community-dwelling older peoples in age 70 plus minus 1, 80 plus minus 1, 90 plus minus 1, who were randomly recruited from general population through the local residential registries from 4 areas in Japan. Today, I introduce some findings from SONIC study about blood pressure research. This figure shows the causes of long-term care insurance certification. 1/3 is related to the diseases such as CVD, cancer, and COPD. About half is dementia, falling, frailty, bone and joint diseases, so-called geriatric syndromes. Thus, to prolong the healthy life expectancy, prevention and cure for cancer and CVD, and prevention and care for geriatric syndromes are important. What is the most important medical factor contributing to healthy life expectancy? We believe that appropriate blood pressure management could be the strong candidate. This study from Framingham study indicated a very important result. There was 5 years in life expectancy and 7 years in healthy life expectancy between hypertension and normal tension in men. This means the hypertension prevention and appropriate management is very effective for both life expectancy and healthy life expectancy. Hypertension is the most common lifestyle-related diseases. More than 43 million people are suffering from hypertension in Japan. Until recently, control for hypertension and other lifestyle-related diseases is aiming to prevent atherosclerotic diseases. However, blood pressure status and would be contributing on the progression with geriatric syndromes, including dementia and frailty. So the appropriate management for blood pressure is very important to maintaining healthy aging. This study is from SONIC. Age 70 plus minus 1, sample size at 1,000. 80 plus minus 1, sample size of 973 showed the difference. High systolic blood pressure resulted low cognitive function at age 70, but not at age 80. Diabetes and BMI also show the same result. In contrast, serum albumin level is significantly influenced on the cognitive function at age 80. Frequency of going out is influencing on the cognitive function both 70 and 80. Therefore, control and prevention of hypertension, diabetes could prevent cognitive decline and future dementia at age 70. At age 80, nutrition is more important than controlling of lifestyle-related diseases. According to the systolic blood pressure category at baseline, the MOCA-J total score at the following up was not significantly different after adjusting confounding factor in the model at age 70 plus minus 1. However, we can see the trend that high blood pressure stage showed low cognitive function. This figure shows the longitudinal result of 3 years later at age 70. MOCA-J total score at follow-up was not significantly different from the baseline, but this figure showed people with hypertension, especially combined with diabetes at baseline, had a significantly lower MOCA-J total score at follow-up after adjusting for the sex and dyslipidemia in the model. This slide indicates that high level of blood pressure is not good for cognitive function at age 70, but low systolic blood pressure is associated with cognitive decline at age 90 in the subject with hypertension taking drugs. These results suggest that tight control of blood pressure in the young old population is important, and mild control for the maintaining appropriate blood pressure level at age 90 to maintain the cognitive function. We should think about these age generation difference of blood pressure management for healthy aging. I will show this another topic about blood pressure variation at home. Upper panel data shows daily home blood pressure level and cognitive function in oldest old participant. It's not significant correlation. However, daily home blood pressure variation and cognitive function in oldest old participants showed significant negative correlation. We should pay attention not only for blood pressure level, but also for blood pressure variation in home blood pressure measuring. This finding was telling that home self-measuring blood pressure might be very important to prevent dementia, even in older adults. So we started a study to prove the importance of home blood pressure measuring to prevent geriatric syndromes such as dementia, which is NOCE study. NOCE study is a whole town cohort to assess the effect on prolonging healthy life expectancy by self-home blood pressure monitoring. It started from 2020. Firstly, our hypothesis is that home blood pressure measurement could accelerate prolonging healthy life expectancy. Therefore, aims of NOCE study are mainly to examine the effect of long-term home blood pressure self-measurement on blood pressure level, cognitive function, as well as incidence of cardiovascular event, development of dementia, long-term care insurance certification, and all-cause mortality as long-term outcomes. I introduced Nose Town. Nose Town is a small town. So this town is located in the north reach of the Osaka prefecture, rural area. The main industry is the agriculture. There is a strong social network among residents. This is a study of method of study of Nose study. So it's a study 2020 for 5 years, and over 80 year age over 40. It's recruited in a subject. This figure shows the study design. Now we are planning to perform the final survey from summer of 2024 until summer of 2025. Today I will present the achievement of the study, first published paper using the data in early intervention area, study 1, and I will present the relationship between blood pressure and frailty at baseline survey in Nose study, study 2, and some additional data. Home blood pressure and outcome values of Nose study as shown, including cognitive function and geriatric syndrome. So we collected the participant blood pressure data from blood pressure notebook approximately every half year. We input those blood pressure data into database and provide feedback to every participant. 1,153 community-dwelling peoples participated in the Nose study. About 10% participants dropped out of the study right now. But the rest of them are still continuing the study in the present period. I will present first study, so factors influencing the continuation of home blood pressure measurement in the community-dwelling older adult. This study has just published in Journal of Hypertension this year. Objective is to clarify the factor associated with continuating and discontinued home blood pressure measurement after distributing home blood pressure measuring machine with encouraging in community-dwelling older adult. This figure shows the trend in home blood pressure measuring continuation rate during the follow-up period, median about 2 years. 27.5% participants discontinued home blood pressure measuring as this study definition. Cox proportional hazard regression analysis of discontinued home blood pressure measuring indicated that male, smoking history, less exercise, and low cognitive function and physical function, independent factor of discontinued home blood pressure measurement. So we have to be careful about those peoples to stop home blood pressure measuring. Next, I'm going to present study 2. It's titled Home Blood Pressure Level and Variability by Frailty Classification in Community-Dwelling Older Adults. To clarify the home blood pressure level and the day-by-day, daily, and seasonal variation by frailty classification in community-dwelling older adults. This is the definition of the blood pressure and the definition of the frailty category. So this is a office of the survey place blood pressure level. It's no significant difference in the frailty classification. But home blood pressure level were compared between frailty groups. As you can see, overall and with hypertension, systolic blood pressure level was significantly higher in frailty group. So we compared the difference between office and home blood pressure. The results showed that office blood pressure was lower in frailty group. From these findings, home measuring blood pressure is very important for people with frailty in older adults. Study 3 is a long-term effect of measuring home blood pressure. As shown this figure, measuring home blood pressure is gradually lowering after adjusting these factors. Self-measurement home blood pressure for long term could be useful to reduce blood pressure both in subject with or without hypertension. Next study is the main analysis of NOCE study, which is the effect of measuring home blood pressure on cognitive function. Here are the results of univariate covariance analysis using age, smoking, and basic baseline Mokage score as covariate. Among female subjects with mild cognitive decline group, scores increased significantly higher in intervention group than in non-intervention group. No difference was observed for other groups. This finding suggests that home blood pressure measuring intervention may be useful for maintaining cognitive function, especially in old women with mild cognitive decline. This is take-home message from my presentation. Appropriate management for hypertension is leading to prevent geriatric syndrome such as dementia and frailty in older adults. It will be key factor of prolonging healthy life expectancy. But we have to think about age group differences. Management for appropriate blood pressure level according to their age is necessary. And we have to pay attention to blood pressure variation. Self-measuring home blood pressure is very useful to control the geriatric syndrome in older adults. Exercise, good nutrition, and social participation are important for each individual to be a healthy longevity, clarified our SONIC and NOCE study. Medical care should contribute on the management of lifestyle-related diseases, especially blood pressure management. Thank you very much for your attention.
Thank you very much for your excellent lecture. Thank you. We'll move on to the next speaker, Professor Eugene Yang from Seattle, USA. He is a professor of medicine and cardiology at the University of Washington School of Medicine, and now he is at the Carl and Renee Benke Endowed Chair of Asian Health. He holds many positions in the ACC and AHA on cardiovascular epidemiology and prevention science. The title of his talk is Orthostatic Intolerance, Frailty, and Outcomes in Hypertensive Patients. Eugene, please.
Thank you very much. Good morning, everybody. And I want to congratulate KSH on the 30th anniversary. So I've been asked to talk about orthostatic intolerance, frailty, and outcomes in hypertensive patients. And this follows Dr. Kamede's excellent talk about the importance of blood pressure management in especially older and frail patients. These are my disclosures. So what I hope to do in the next 20 minutes is first to talk about what is orthostatic intolerance by defining it, and then specifically focus on orthostatic hypotension, which is something that we deal with in clinical practice, and then talk about some of the clinical outcomes associated with this diagnosis, and then talk a little bit about frailty and its association with cardiovascular events, as well as how do we manage hypertension, especially in the frail population, and then a few key takeaways. So what is orthostatic intolerance? So orthostatic intolerance is usually a syndrome that refers to symptoms when patients are going from either a supine to sitting position or sitting to standing position, where there are symptomatic changes associated with a decrease in blood pressure. And these changes occur from both lying and sitting and standing positions, and are often associated with autonomic dysfunction as well as volume depletion, which I'll talk a little bit more. Orthostatic hypotension is usually a form of orthostatic intolerance. And I think in clinical practice, we often use these terms interchangeably, even though they may not necessarily be the same thing. And orthostatic hypotension is really multifactorial and can be related to impairments in autonomic function, volume depletion, or a response to adverse medication effects. So if we think about one of the major causes of patients who develop orthostatic intolerance, or in particular orthostatic hypotension, There are different forms of autonomic failure. So primary autonomic failure are related typically to degenerative diseases of the nervous system. So pure autonomic failure, multiple system atrophy, Parkinson's disease are all associated with a primary autonomic failure. Secondary causes of autonomic failure are related to things that damage the autonomic nervous system that are not primarily due to CNS types of causes. So diabetes, both kidney and liver failure, or alcohol consumption are all secondary causes of autonomic failure. And then finally, probably the most common cause of orthostatic intolerance are related to medication. So as clinicians who take care of hypertension, diuretics, vasodilators, and then antidepressant medications, as well as other medications that are used often to treat things like Parkinson's disease. So let's talk more specifically about orthostatic hypotension. So if we look at the classic definition of this, it's typically defined as a drop in systolic blood pressure of more than 20 millimeters of mercury, or diastolic blood pressure more than 10 millimeters of mercury within 3 minutes of either active standing or doing tilt table testing. There are, of course, other variants. So people can have a very different response to changes in position with respect to the drop in blood pressure. So some can have very rapid onset of change in blood pressure. Others have a delayed response, meaning that the response typically occurs after the 3-minute period of time. And then postprandial is when it often occurs in older people who have primary autonomic failure. Those individuals often will develop orthostatic symptoms after they can eat a larger meal. So recommendations are often to tell those individuals to eat smaller meals at more frequent intervals. And we know that the prevalence of orthostatic hypotension is really strongly correlated with age. And so you can see that individuals below 50, the prevalence is probably less than 5%, but those individuals over 70, that prevalence can exceed 20%. And as we'll talk about shortly, it's clearly associated with increased cardiovascular morbidity and mortality. And then it is really common also in patients who have uncontrolled hypertension and can be associated with treatment for hypertension disorders. So what is a mechanism of specifically orthostatic hypotension? So essentially when people go from a sitting to standing position, there's a significant shift in blood from the intravascular compartment to the peripheral venous vasculature, so the lower extremities and the splanchnic bed. And under normal conditions, physiologically, there's typically an increase in heart rate associated with venoconstriction or arterial constriction to preserve the systolic blood pressure, as well as a slight increase in diastolic blood pressure to maintain venous return and cardiac output. In orthostatic hypotension, there's failure of some of these mechanisms that are related to these postural changes. And so, as you can see, there are many different systems that are affected, both baroreceptors, autonomic, afferent, and efferent pathways, and peripheral sympathetic receptors can be dysregulated and cause individuals to be more susceptible to developing orthostatic hypotension. We have Dr. Jurashik here in the audience, so I'm going to highlight this excellent statement that recently came out specifically around orthostatic hypotension in adults. This was a great table sort of to define the different clinical presentations of orthostatic hypotension. So the classic orthostatic hypotension is related to the autonomic dysfunction that I mentioned to you. Patients are often symptomatic and experience these symptoms typically from going from a sitting to standing position or even from a lying to sitting position. And you can see that it's also related to the Parkinson's disease and primary autonomic failure in particular. Then there's hypertensive orthostatic hypotension. And you can see here the mechanism is due to patients likely having a very thick ventricle from management or from high blood pressure that reduces diastolic filling due to decreased compliance of the ventricle. And that can also cause patients to experience orthostatic symptoms. And so typically we see this in patients who have pre-existing hypertension and evidence of ventricular hypertrophy related to long-standing or poorly controlled hypertension. And interestingly, these concepts of pseudo-orthostatic hypotension are interesting. So at least in the second example, clearly one of the major issues is around measurement. So you can imagine if you have a measurement that is incorrect at baseline from a supine position that's maybe 10 millimeters higher than what the actual reading is, and then you have a corresponding standing measurement that is actually 10 millimeters lower, then that could result in a 20 millimeter difference in blood pressure, and this individual might be classified as having orthostatic hypotension. So again, it highlights the importance of actually accurate measurement. Otherwise, we may end up diagnosing individuals with orthostatic hypotension who actually don't have it. So what about clinical outcomes, right? So orthostatic hypotension is clearly an independent risk factor for both overall mortality as well as cardiovascular comorbidities, and has been associated with an increased risk of heart failure, atrial fibrillation, coronary artery disease, but also associated with non-cardiovascular adverse outcomes, such as falls, fractures, cognitive decline, and dementia, as Dr. Kamide pointed out, premature death, and frailty. So this study was published a few years ago looking at the association between orthostatic hypotension and the risk of other cardiovascular diseases. And you can see in this panel on the left that the association between orthostatic hypotension and heart failure, there was an over 30% increased risk of heart failure in individuals who had a history of orthostatic hypotension. If we look at patients who have atrial fibrillation, there was over a 50% increased risk of atrial fibrillation. And then finally, if we look at coronary heart disease, you can see there's also a significant increased risk of having coronary heart disease associated with individuals with a diagnosis of orthostatic hypotension. So clearly impacts clinical outcomes. And then when we look overall at how does orthostatic hypotension affect the different organ systems, you can see here that it has harmful effects in the brain, the heart, the lungs, circulation, the kidneys, and the bones. So clearly the association of orthostatic hypotension extends beyond cardiovascular conditions and really relates to many of the major organ systems of our body. So what about clinical trials? So the problem is, as we all know, that in general, clinical trials will exclude patients who have evidence of orthostatic hypotension. So for example, in the SPRINT trial, it was a requirement for orthostatic measurements to be made, and individuals who demonstrated orthostatic hypotension were excluded from the study. However, interestingly, if you look at studies, there doesn't seem to be a clear association that intensive treatment of blood pressure actually increases the risk of orthostatic hypotension, and that in fact, more intensive blood pressure lowering might actually be associated with a lower risk of orthostatic hypotension during follow-up. So it's a little bit strange to see this type of finding, but I'll show you the data here shortly. So again, Dr. Jurczyk is in fact, I'm wondering why he's not giving this talk since he's really the expert in this. So this paper just came out a year ago, and basically they looked at a meta-analysis of 9 large clinical trials of hypertension, including SPRINT, ACCORD, SYSTUR, SHEP, HIVET. So many of the largest hypertension trials, and what they found was that individuals who had orthostatic hypotension had about a 15% increased risk of cardiovascular events with this diagnosis. However, what was really interesting, I think, in this study is that when you look at the sort of association between those who had orthostatic hypotension and were treated more aggressively to their blood pressure targets, there was clearly a better outcome. So both cardiovascular disease and all-cause mortality. So in the dark line are those individuals where they received standard treatment for blood pressure, and those in the lighter green line are those who were more intensively treated. And you can see that there was a lower cardiovascular mortality associated with actually more aggressive treatment of the blood pressure. And in addition, in those individuals who had no orthostatic symptoms but had more intensive treatment, there's also improved outcomes overall. So irrespective of the diagnosis of orthostatic hypotension, more intensive treatment was associated with lower cardiovascular mortality as well as all-cause mortality. So a finding is a little bit, I would say, not something that we would assume would happen. So the question is, do we really need to screen these patients, right? So if we have clinical trials and we have evidence that patients do better with more aggressive treatment, so should we even be excluding these patients from the clinical trial? So I just pose this question because the data would suggest that perhaps we don't need to do that. But we look at all the guidelines. So the ACC AHA guideline from 2017 indicates that we should be measuring or looking for orthostatic hypotension based on the definition. We look at the KSH guideline from 2022, very similar recommendations to assess patients for orthostatic symptoms. And then when we look at the 2023 ESH guideline, again, all the guidelines have very similar screening strategies to rule out that individuals have orthostatic hypotension. So I'm going to move into frailty. So I think frailty is an interesting, I would say, state, because we recognize it and acknowledge it, but I think the question is then how do we manage patients who have hypertension? As Dr. Kamade pointed out, frailty is associated with potentially worse clinical outcomes, and treatment of blood pressure is very important. So how do we balance the issue of frailty in the context that treatment of hypertension potentially results in better clinical outcomes? So frailty here is defined as a state of vulnerability that is caused by dysregulation among various physiological systems, and obviously it's multifactorial and can cause obviously lots of sort of extensive overall morbidity and mortality for individuals. And we know that it's strongly associated with an increased risk of cardiovascular disease, definitely more common in older adults who have a concomitant diagnosis of underlying cardiovascular disease. And you can see that up to 30% of patients who have coronary artery disease, over 80% of patients with the diagnosis of heart failure may have frailty associated with these comorbidities. And in addition, we know that individuals with established cardiovascular disease are more predisposed to developing frailty. Additionally, they're at increased risk for earlier onset of cardiovascular disease if they have a diagnosis of frailty. And we know that there's a higher incidence of major cardiovascular events as well as mortality. So there have been two sort of conceptual frameworks to sort of try to measure frailty. So one is looking at physical frailty, a phenotype, based on the presence of 3 out of these 5 components that you can see here. So weight loss, exhaustion based on response to questionnaires, weakness, so decreased grip strength, slowness, so reduced sort of exercise tolerance, and low physical activity are 5 specific components that when asked if you would have more than 3 of these can be associated with a frailty phenotype. And then there's a second sort of accumulation index that tries to quantify the total burden of age-related health deficits, not just cardiovascular sort of assessment, but multiple domains, including cognitive function, mobility, morbidity, social, as well as psychological aspects, doing a very comprehensive geriatric assessment. And there are more than 60 tools that have been used to try to measure frailty in different clinical scenarios. So this comes from a very nice review that was also recently published looking at frailty. And these are just examples of some of the different types of measurements that are used to assess frailty of individuals and are often used in clinical trials when trying to find associations between frailty and cardiovascular morbidity and mortality, as well as the association with hypertension in clinical outcomes. I think this review really nicely summarized some of the interesting associations, the intersection between frailty and cardiovascular disease. So you see frailty and cardiovascular disease, and sort of at the intersection, you see how it has effects on inflammation, immune activation, metabolic dysregulation, and environmental factors that are really associated with cardiovascular disease. So this really nicely summarizes sort of this interaction. And they also talk about the risk factor of frailty with cardiovascular disease. And if you look at these different types of studies, some use that frailty phenotype that I mentioned, others use different criteria. But what was clear, at least from this table, is that there's strong association between individuals with frailty phenotypes and increased rates of cardiovascular events, of more than 2-fold increased risk of cardiovascular events overall when you look at the summary of these different trials. So let's step aside and look at the, I think, very important SPRINT trial, because I think we learned a lot of lessons from this study. So as I mentioned earlier, patients who were enrolled in this study, in general, had to be screened out for orthostatic intolerance or orthostatic hypotension. But when we look at the outcomes, we all know that there was a significant benefit over on the primary outcome, 25% reduction in the primary outcome, as well as a 38% reduction in heart failure, and death from cardiovascular causes was reduced by 43%. As a result, this study was terminated early. So clearly, more aggressive intervention of blood pressure had a very positive effect on reducing clinical outcomes. But I think more importantly, when we look at the subgroup analysis, you can see that the individuals that benefited the most were those who were over 75. So there was a 20% relative risk reduction in the primary outcome for people below 75, and those above 75, there was a 33% relative risk reduction. So again, benefit is clearly magnified in individuals who are older, and we have seen other studies subsequently that have also showed that more intensive blood pressure lowering in older populations has a positive effect in terms of reducing cardiovascular events. So they did a sub-analysis of the SPRINT trial, the SPRINT senior study that was published shortly after the original paper was published in New England Journal of Medicine. And in this study, they looked at frailty specifically. So if you look at the primary outcome, what you learn or see is that there's clearly an association between frailty and increased rates of cardiovascular events. So the more frail you are, corresponds to higher rates of events for all of these different situations, both the primary outcome, all-cause mortality, and primary outcome plus all-cause mortality. However, interestingly, when you look at the outcomes in terms of the hazard ratios, you can see, for example, that all-cause mortality really wasn't changed significantly in those who were fit. But you can see that there was definitely a change associated with those who had frailty or were less fit. So there was clearly, potentially, at least in some situations, more benefit to intensive treatment in those who were frail compared to those who were fit. So again, sort of paradoxically showing that there is potentially more benefit in those who are frail. So how do we manage this in clinical practice when clearly there may be a trend towards more benefit in individuals who are frail, yet we are concerned about the potential side effects or consequences of more active or intensive treatment? This is another study that looked at blood pressure in frail older adults and the associations with cardiovascular outcomes and all-cause mortality. And I think it's important. So this is a study that was done in the UK, and you can see a very large number of individuals who went through a frailty index that was done sort of electronically through gathering data from the electronic health record. But it's important to note that you can see that the number of individuals who were categorized as being moderate or severely frail was very, very low, 0.2% for severe frailty and only 4% with moderate frailty. So the majority were mildly frail or non-frail. So again, we have to sort of look at this with a little bit of a grain of salt. But what they found, which is similar to what I've already mentioned, so this sort of this gray triangle represents those who had severe frailty, and you can see that using 130 millimeters of mercury systolic blood pressure as the reference, that there's improvement in terms of clinical outcomes and change in mortality related to the degree of blood pressure elevation. And you can see overall that at 130, there seems to be really no difference in terms of overall event rates. That doesn't really occur until you get to above 180 millimeters of mercury, and then clearly associated with increased mortality and morbidity in those with blood pressure targets that are less than that. But the key thing is that if you look at how it correlates with the degree of frailty, there really aren't that significant of a difference in terms of the rates of cardiovascular events. If anything, there seemed to be lower rates of cardiovascular events in those who had more frailty compared to those who were more fit. And this was also looked at in individuals who were over 85 years of age, showing clearly that there's an association with those and benefit potentially to those who are more frail in terms of cardiovascular outcomes. So again, raising the question about, should we be less intensive in terms of our treatment for people who are frail, at least based on this index. And that's reflected, I think, in clinical guidelines. So you can see in the European Society of Hypertension guidelines, they nicely characterize people who are fit versus severely dependent and suggested using different thresholds for treatment or even deprescribing of medications for people who are very severely dependent. And that's also, I think, highlighted here in the European Society of Cardiology guidelines that just came out a few months ago, also requiring an examination of frailty to determine intensification or deprescribing of medications based on the level of frailty of the individual. So again, I think that raises the question, should we be looking at biological age versus chronological age? And I think that, in my opinion, we need to individualize the treatment for the patient, not use these very strict criteria. I don't know, I think I just got timed out. So anyway, my conclusions are orthostatic hypotension is very important and clearly a risk factor for cardiovascular disease. Patients who have frailty, I think it's a balance between intensive treatment versus the potential side effects associated with, but the evidence would suggest that even in those who have orthostatic hypotension or intolerance, or those who have more frailty, that there's strong evidence that patients may have more benefits in terms of intensive treatment. So thank you very much.
Thank you very much for your excellent and very comprehensive lecture on frailty and orthostatic intolerance. The next two topics will be chaired by Professor Kim.
Hello, this is Kwang-il Kim, and it is great honor for me to chair this session. I will introduce the next speaker. Next speaker is Professor Jung-yeon Choi from Seoul National University. And she graduated Seoul National University, and now she is working at the Seoul National University Bundang Hospital. And she is a geriatrician, and the title that she will going to speak today is Digital Technology and Frailty Assessment. Professor Choi, would you please start?
Thank you for the introduction. It's an honor to have the opportunity to present about the digital technology and frailty assessment at the Hypertension Seoul 2024. The contents of today's presentation are as follows. First, we will review about what is the frailty. First of all, in July 2024, the older population surpassed 10 million in Korea. Korea is expected to enter the super age society in 2025, the next year, taking only 8 years to progress from an age society. Older people have very special characteristics. They have many chronic and acute diseases, and they have to take many medications also. Because of the aging processes, older people suffer from the functional decline in multiple domains, and the type of the family becomes nuclear families nowadays. So maintaining physical and cognitive functional capacity becomes even more very important for continued life there at their own home. And as people age, the diversity in health status is very widens. So I think that evaluate and managing various health conditions in this older population group is becoming increasingly important. The geriatric syndrome is a multifactorial health condition that occurs when the accumulated effect of impairment in multiple organ systems changes on older people's susceptibilities at situational challenges. Geriatric syndromes occurs due to the many identified and unidentified causes and the interactions between them. Therefore, the etiology or the pathophysiology is not clear in this case of geriatric syndrome. Geriatric syndromes such as delirium, falls, incontinence, frailty, and sarcopenia are very highly prevalent, multifactorial, and associated with substantial morbidity, quality of life, and poor health-related outcomes. Frailty is, I think, is the most important concept in geriatric field. Frailty is decline of physiological functions and resolve capacity in multiple systems that make that individual susceptible to health issues. Frail older adults worsen more significantly and sometimes could not recover to the baseline under the same level of stress compared to the robust older adult. The prevalence of frailty among Koreans is very high. About frail and pre-frail status are estimated over 50%. Second, we will look into how frailty could be measured. It is a little bit overlap with Professor Yang's lecture. The most classic and the golden standard way to define frailty is a phenotypic of frailty, which investigate weight loss, self-reported exhaustion, low energy expenditure, slow gait speed, and weak grip stance. Points more than 3 could be defined as frail, and points 1 or 2 could be defined as pre-frail. There is a frailty index if a minimum of 40 items related to the symptoms of age-related diseases or health conditions are investigated. The number of relevant items was expressed as a proportion, allowing the assessment of the degree of frailty. It depends on which components were evaluated, but mostly 0.20 to 0.25 could define to be the frail. And there are some simple self-reported questionnaire translated into Korea could be alternated to define frailty. This scale is similar to the phenotypic of frailty, which investigate fatigue, resistance, ambulation, illness, and weight loss. Next, we will explore the main topic of this presentation, this digital technology and frailty. Before exploring digital healthcare technology for assessment and intervention in frailty, it is essential to first identify whether frail older individuals can effectively use digital technology. According to the surveys recently conducted in Korea, it is known that a frail or pre-frail older people tend to have relatively low familiarity with using mobile applications and awareness of wearable devices. So I think it is very essential to incorporate customized user interface, user experience, and services which meet unique needs of frail older people. The most basic method for measuring frailty involving digital technology is web-based tools that calculate frailty index automatically and visualize with assessed indicator. In scoping review about the web-based frailty assessment tool, there are 12 web-based frailty assessment applications, and these web-based tools focused on frailty grading and outcome prediction. This graph comparing the total scores of each frailty assessment tools, the scores were based on cost, remote conductance, total number of items, health domains included, instructions and training, results interpretation, data saving, and user interface. And we will look for the highest score rating, senior health calculator. This senior health calculator calculate that and display the frailty index based on comprehensive geriatric assessment, allowing user to check each measurements, medical history, functional status, physical test, cognitive test, and nutritional test should be entered. When measured value were entered, this web-based tool showed potential risk of specific health-related domains and allows users to identify frailty index. And for the result page, this tool provides the spider chart visualization for an intuitive outcome across the various domains. Along with the graph, which you can see at the right side, allows comparing with the frailty index of peers in the same age and sex group. There are some self-reported web-based tools available for assessing frailty. This tool is Vulnerable Elder Survey 13. It takes about 5 minutes to complete and includes recording age, self-reported health, physical function, activity of daily living. Report represent total scores and patient frailty status. Highly vulnerable elder survey 13 scores is associated with increased 2-year all-cause mortality in dose response relationship. Research on digital health technologies to measuring frailty itself has predominantly focused on using sensors to collect data on locomotion, posture, energy expenditure, and gait analysis, which are then analyzed using sometimes for a machine learning method. Necklace type sensor was used on the left side, and the wearable sensors attached to the waist and legs were used in the right side to collect digital biomarker for frailty. Necklace type sensor can be worn during daily activity, allowing for the collection of wide range of information over extended period. In contrast, Wearable sensors are designed to collect on more subtle changes while performing several predetermined tasks like single task walking and dual task walking. Some method that involves having participants perform predetermined course of physical actions and gather data with camera could be used to identify digital biomarkers of frailty. Making the participant walk while and turning 90 degrees to right can help assess their gait stability and the balance. Assessing frailty through digital technology is not easy because I think the concept of frailty is not simple. Therefore, most approaches focused on more precise collecting and analyzing physical parameters to evaluate frailty. Recently, assess frailty by recording and analyzing a participant's voice is attempted. In this study, participants counted from 1 to 10 and backward and recorded using smartphone application. The frail group had a higher peak voice volume to average volume ratio and greater variance in the length of pause between the speech segments. These results indicate that there was greater speech irregularity in the more frail group than the less frail group. An example of digital technology for measuring frailty includes touchscreen assessment tool, Tattoo. This software, which evaluates performance components of the use of touchscreen in comprehensive and objective manner. These Tattoo tools consist of the 6 tasks, and it measured the time including start time, reaction time, test time, movement range and pressure measurement, mode of operation, and numerical and graphical accuracy. The response speed and task accuracy gathered by this application on smartphones or tablets was statistically different from the middle-aged and older group. Since this approach assessed both physical and cognitive functions, it could also be extended to evaluate frailty. There are also studies that have applied home IoT technology for frail to pre-frail older individuals. When 5 IoT services were provided for 1 year, the usability of pre-frail participants showed higher than frail older adults. Service-specific system usability scale was analyzed by frailty status. When there was a difference in usability, the frail group showed a pattern of lower usability than pre-frail group. In particular, the frail group had lower usability than in using the wall switch sensor, motion sensing, SOS calls by remote control, and automatic gas circuit breaker. And there are comprehensive self-management solution to intervention in frailty is also being attempted for patient transitioning from pre-frail to frail status. This digital coaching for frailty is web-based platforms offering tailored clinical advice and support and give self-management resources for the management of COPD, asthma, cardiovascular disease, and type 2 diabetes. These platforms can be accessed by any electronic devices including smartphone, tablet, and television that has an active internet connection. Intervention ingredients of digital platform is specific education and guidance for long-term conditions, exercise video, and nutritional guidelines. This digitalized multi-component intervention is expected to improve physical function, activity of daily living, quality of life, frailty status, and self-reported outcomes. And research also being conducted using smartwatches and augmented reality glasses to carry out and monitor prescribed exercise programs as an intervention for frailty. According to the scoping review about the digital health intervention among frail older people, in 1990s, digital health technology being to appear along with computerized balance system, robotics, and games. After 2000 and beyond, real-time teleconferencing and multimedia program appears, followed by sensor technology. After 2010 and beyond, the most important tool that emerged was the use of smartphones and more recently, vocal biomarkers. Purpose of digital health technology was frailty detection, monitoring, care and support, communication, and assessing health status. For the intervention purpose, fall prevention and rehabilitation also delivered by digital technology. And most frequently used mode of delivery is sensor-based technology, and mobile application is recently emerging. Contents were the feedback and education, self-reporting, and goal setting. The United States conducted the most research on frailty-related digital technology on a single country basis. However, most studies have been published in Europe, where population aging is more advanced. Recently, many countries, including those on digital therapeutics, have also been conducted in Korea to prepare for super-age society. Lastly, for the conclusion, recently, various chronic disease guidelines have emphasized that importance of assessing frailty as a way to evaluate the health diversity among the older patient. Particularly in a super-age society, measuring frailty is essential for making appropriate medical decisions for older people. Traditional methods for measuring frailty include the phenotypic frailty approach and the frailty index. Web-based tools aid that help that calculation and visualization of measuring data of self-reported data for frailty. More advanced frailty assessment, digital technology used sensors to collect various data on gait, mobility, voice, and touch screen manipulation. Digital technology is also being used for frailty intervention through education, remote monitoring, self-assessment, and goal setting. Previous studies focused on computer game and robotic-based approaches, and recent studies utilize sensors, smartphones, and voice biomarker for identifying and intervention frailty. And to prepare for a super-age society, we should actively research on digital technology for the prevention, diagnosis, and management of frailty. This is end of my presentation. Thank you for your attention.
Thank you, Professor Che, for your very timely presentation. Let's move on to the next final speaker. The final speaker of this session is Joo-hee Lee from Chungbuk National University. And Professor Lee graduated the Chungbuk National University and now working as a professor at the Chungbuk National University Hospital. The title of the talk is Hypertension Management Strategy Based on Frailty. Professor Lee, would you please start?
Thank you very much for your kind introduction. Good morning, everyone. My name is Joo-hee Lee from Chungbuk National University Hospital. Today, I'm honored to discuss about hypertension management strategies based on frailty, a holistic approach. We'll begin with the special considerations for elderly hypertension patients, followed by a look at frailty and its impact on hypertension. Next, I will present key evidence for managing hypertension in frail older adults. Finally, we will go over expert recommendations for a holistic management approach. There are several special considerations when treating elderly hypertension patients, but frailty is especially important. The number of hypertension population in Korea has exceeded 12 million, and importantly, more than 5 million of them are elderly individuals aged 65 or older. Elderly hypertension patients have the unique characteristics such as isolated systolic hypertension and increases BP variability, and domestic hypertension more prevalent in this population, and we should consider about the side effect and safety of the drugs. The older adults often face multiple issues such as frailty, multiple comorbidity, polypharmacy, cognitive impairment, depression, disability, falls, and dizziness and syncope. These various factors interact with each other and can pose significant barriers to blood pressure control. When assessing an elderly patient, it is essential to check for these problems. However, it is important to remember that the chronological age does not necessarily equate to biological age. They are 83 years old, very healthy, elderly, and he is only a 70 years old man who is bedridden state with multiple comorbidities. These people have very different appearance and different functional status. Medical decision making should take these characteristics into account. Frailty is a state of diminished physiological reserve closely linked to biological age. However, being old does not necessarily mean being frail, and being frail does not necessarily mean being old. Now let's take a look at frailty and its impact on hypertension. In this meta-analysis, the pooled prevalence of hypertension among frail individuals was found to be 72%, while the prevalence of frailty among individuals with hypertension was 14%. In this analysis from Korean database, the hypertension prevalence was higher in frail elderly individuals than pre-frail or robust elderly. The frail elderly individuals were more likely to receive treatment than pre-frail or robust elderly. However, among treated patients, the proportion of those whose blood pressure was controlled under the 150 and 90 millimeter mercury was significantly lower in the frail elderly group. There was a U-shaped relationship between the frailty index and both systolic and diastolic blood pressure. In other words, the mean frailty index was higher in patients with either higher or low blood pressure. In patients with hypertension, frailty is also associated with poorer prognosis. In this study, the frailty was assessed using gait speed. Among both faster and slow walking participants, those with normal SBP had a higher survival rate compared to those with high SBP. However, in participants who could not complete the walk test, those with elevated SBP had a lower mortality rate. This observational study included 500 ambulatory older hypertension patients, also demonstrated that the mortality was lowest in non-frail participants with lower SBP, whereas it was highest in frail participants with low SBP. Also in this cohort, we can see the lowest risk of mortality among non-frail participants was observed at SBP of approximately 130 millimeter mercury. That is consistent with many guideline recommendations. In contrast, among frail older adults, the risk of death decreased as SBP increased, with the lowest risk observed in those with SBP of 160 millimeter mercury or higher. Furthermore, in a study enrolled nursing home residents aged older than 80, the participants with an SBP of less than 130 millimeter mercury who were receiving multiple BP medications demonstrated higher mortality compared to the other groups that SBP more than 130 millimeter mercury or receiving less than 2 antihypertension medications. The finding of this study lies a cautionary note regarding the safety of using combination antihypertensive therapy in frail elderly patients, especially in the patients have the SBP less than 130 millimeter mercury. So, can frail older adults benefit from the antihypertensive treatment? Currently, there is a significant lack of evidence specifically focused on frail elderly patients. However, some insight can be gained from the post-hoc analysis, which offer the preliminary evidence on the effect of hypertension management in this population. The HYBET study, originally designed to compare the active treatment and placebo in the patient with 80 years or older. In the original paper, the active treatment showed the significant benefit compared with the placebo group. In the post-hoc analysis of HYBET study, the frailty index was retrospectively calculated based on 60 deficits from quality of life sub-study population. The distribution of frailty index was skewed to left, and the mean frailty index was 0.19, and median frailty index was 0.17, which was similar to that seen in the population studies. There was no significant interaction between treatment effect and frailty for the outcomes, such as stroke and cardiovascular event and total mortality. As Dr. Eugene Yang nicely presented at the previous talk, in the SPRINT senior study, the primary endpoint and all cause of mortality was significantly lower in the intensive treatment arm. The predefined frailty assessment was performed by gait speed measurement and frailty index calculation and cognitive function assessment. The median frailty index was 0.18 and 0.17, and about 30% of the participants were classified as frail population. The results stratified by baseline frailty status and the gait speed showed higher event rate with increasing frailty in both treatment groups. However, within the each frailty stratum and gait speed category, absolute event rates were lower for the intensive treatment group. The benefit of intensive EP control was consistent among these aged 75 years or older who were frail or had reduced gait speed. In the post-hoc analysis of the SPRINT senior study, there was no significant difference in gait speed decline both in intensive and standard treatment groups. However, there was a notable interaction when considering physical quality of life. For the participant with higher physical QOL, the intensive blood pressure lowering was linked to the slow rate of decline in gait speed. Conversely, for those with poorer physical QOL, the intensive EP lowering seems to correlate with the faster decline in gait speed. These findings suggest that the physical QOL may influence the outcomes of hypertension treatment on physical function in the older adult. Additionally, it's important to note that like HYBET trial, SPRINT also excluded the most frail individuals and several other subgroups of patients with common age-related conditions such as type 2 diabetes and history of stroke, symptomatic heart failure, dementia, orthostatic hypertension, and those living in nursing homes. However, as we know, the elderly patients with hypertension often have the multiple coexisting illnesses that would exclude them from the participation in these clinical trials. When applying the exclusion criteria from those 13 ICTs, including HYBET and SHEP, to a policy cohort of more than 5,000 of patients with hypertension with ages 60 years or older, the 71 of the patients meet the at least one exclusion criterion. And as you can see here, the trial eligible patients were remarkably healthy as compared with those who were excluded. Therefore, even in the clinical trials that specifically enrolled the elderly hypertensive patient, it is possible that only the relatively robust elderly were selectively enrolled to the clinical trials, and this cannot be said to represent the entire frail older adult. Lastly, I'd like to present some expert recommendations on managing hypertension in frail older adult. This table presents a comparison of hypertension guidelines for frail older adults across the various countries. Notably, most guidelines lack a consistent definition of frailty, with only 4 providing specific criteria for frailty, each distinct from the others. In general, the guidelines recommended the individualized treatment and the individualized treatment goals and the use of clinical judgment, but do not establish a uniform blood pressure target, often suggesting the higher SVP threshold around 160 mm mercury for treatment initiation. Although no specific antihypertensive agents are recommended, all guidelines emphasize the importance of tolerability due to the increased risk of adverse effect in frail patients. This variability underscores the need for more standardized recommendation for the frail elderly hypertensive patient. Although usually we cannot routinely perform detailed frailty assessment in daily clinical practice, hypertension management should be modified in elderly according to their functional reserve and frailty levels. Some experts recommended that this simplified frailty assessment by this visual numeric scale based on the Canadian study of health and aging score. They proposed this approach to discriminate between 3 profiles of patients, that is, those with the preserved functional status, those with loss of function but the preserved autonomy for the ADL, and those with severe loss of function impairment and loss of autonomy for ADL. For the preserved function group, the authors recommended full therapy to achieve outcomes similar to that of younger patients. For the loss of function and altered ADL group, they recommended higher target BP, like the 150 mm mercury, and reducing the antihypertensive medication in cases with SBP less than 130 mm mercury, or if there is also static hypertension. For the gray zone, they recommended that the detailed frailty and functional assessment in order to assess risk-benefit ratio for the patient. Some authors recommended the deprescribing of antihypertensive medication, especially in frail older adults. This is one of the proposed deprescribing algorithms. For older individuals aged 75 years or older at high risk of adverse event, such as previous adverse event or the moderate to severe frailty, after their BP is controlled below guideline recommended levels, typically below 150 mm mercury for those aged 80 and above, after review the patient current medication to identify antihypertensive medications that may need to be withdrawn, especially those that could be contraindicated due to the new condition or conditional changes. After each the medication is withdrawn, BP and adverse symptoms should be monitored. However, it is important to note that we still need more evidence regarding the long-term benefit and the harms of deprescribing antihypertensive medications in this population. We still have the remaining challenges. The first one is frailty measurement can be quite elusive and difficult to define precisely. Assessing both frailty and functional status is often time-consuming and requires specialized skills. Frailty itself is a multidimensional concept with highly variable presentations in severity among the individuals. We anticipated that the ongoing clinical trials will provide robust evidence for blood pressure management in frail patients. This How Old BP trial is currently being conducted across 12 national university hospitals in Korea. The PI is the chairperson Kwang-il Kim now, and initiated by the Myung-chan Jo, also the chairperson in this session. This study included the hypertensive patient ages 65 years and older who are randomized into an intensive treatment group and standard treatment group. In addition to the precise BP measurement, the study included the comprehensive frailty assessment using frailty questionnaire and gait speed, grip strength, as well as the cognitive function and quality of life assessment. As of October 2024, a total of 2,361 participants have been enrolled, with a primary outcome event rate of approximately 2% among the participants. A longer term of follow-up period will be essential to gather the meaningful conclusion. There are also ongoing studies focusing on de-prescribing antihypertensive medication in extremely frail patients. One example is the Retreat Frail trial, a national multicenter study in France to assess the impact of reducing antihypertensive treatment and compared with the conventional treatment. This trial enrolls patients aged 80 or older who live in nursing homes, have a SBP below 130 millimeter mercury, and are on one or more antihypertensive medication. Participants are randomized into either a step-down treatment group or a control group and will be followed for 3 years. This study recently completed the enrollment of 1,126 participants, and we are waiting the result. Another study, the Optimized BP trial, is a prospective randomized open-label pragmatic trial that will compare the effect of de-prescribing with usual care. The result of these de-prescribing studies conducted with nursing home residents may offer the valuable guidance for managing treatment in extremely frail elderly patients. I'd like to summarize my talk here. The frailty is a common problem in elderly hypertensive patients, and the prevalence of hypertension is higher in frail elderly patients. The recent clinical trials shows that the CV benefit of BP lowering less than 130 millimeter mercury is not modified by frailty status, but the very frail individuals were always excluded in these trials. Hypertension management should be modified in elderly, especially in octogenarians, according to their functional reserve and frailty levels. There is high necessity of solid scientific evidence based on controlled trials to guide physicians on how to treat hypertension in various segments of the elderly population. Thank you very much for your attention.
Thank you, Professor Lee, for your very comprehensive review. And let's start the discussion. And for the discussion, we invited 4 distinguished panelists: Min-Kwan Kim from Yonsei University, Sung-Ha Park, Yonsei University, and Jae-Hyung Park from Chungnam National University, and Jin-Kyung Oh, Chungnam National University. Who will start first?
Yes, thank you for all speakers for wonderful lecture. I'm Min-Kwan Kim from Yonsei University. I'm working in Yongin Severance Hospital. I have a question to Professor Kamite. Recently Donald Trump win the U.S. president election. I'm amazed and envious that Trump can speak so fluently at almost 80 years old. Professor Kamide, Kamide's lecture, I'm very impressed. But could you explain this is very simple question. Could you explain the mechanism by which uncontrolled hypertension causes cognitive dysfunction?
Okay, thank you very much for your question. So I think it's a circulating the volume is the lower. If older people has atherosclerosis in the whole body, so I think brain blood vessel also has a very going to be atherosclerotic. So I think if over 80 and 90 subject has low blood pressure control, so I think a low perfusion blood it's maybe associated with cognitive decline, I think. That's the main reason. And also, I'm not sure, so they are going to be not many contact with other peoples and many multifactorial factors over 80 and 90. But I think if too tight blood pressure control is not good for the over 80, sometimes 85 or 90 people. So very careful about too tight control for those old peoples, right?
So, Professor Kamide, thank you for your great talk. So, you know, the Lancet Commission mentions that hypertension is a major risk factor for dementia in the Middle Ages,
Yes.
but not in the elderly. But your data shows that maybe hypertension, which onset at an elderly age, may be associated with cognitive decline. So from your data, were these patients, did they have hypertension before the age of 65, or did they develop hypertension at an older age?
That's a very good question. So I think middle-age hypertension is significantly associated with later cognitive decline. That's definitely true. But still, recent older people is a very good condition until less than 75 and 80. So I think high blood pressure influence on the brain function and brain circulatory status. So until 75, less than age 75 or 80. So, but after that, so that will be less, too low blood pressure is not good for the dementia. So I think my opinion, so until age 75, so we have to have a tight control, blood pressure control would be prevent dementia. But after 75 years old, we have to be careful about too tight control. It's my opinion.
I have a question to Professor Choi. Thank you for all presenters for their excellent lectures. Professor Choi, assessment of frailty is somewhat time-consuming, and I think your institution is excellent for geriatric care. And how often do you measure frailty in your daily practice, and which method?
In our hospital, we have a great team, a multidisciplinary team, and we do the comprehensive geriatric assessment. So I daily use that, but it takes about 30 minutes to 1 hour. So I think it is really difficult to do that for all the patients. So I selected some patient who looks like frail, and the people who are expecting some very important treatment plan, like surgery or the chemotherapy. And I usually measuring frailty with comprehensive geriatric assessment, but I also doing some research on using the digital technology. Sometimes I record some voice and making people doing some very simple task with the tablet But I think it is really hard to identify real frailty with that kind of simple method. I think it could be used for the screening method who need to take a comprehensive geriatric assessment. Yeah.
Another question, Professor Che. As you mentioned, there are many scales and technology for frailty assessments, but most of them are based on physical functioning status. But I think biochemical factors also play a key role in frailty development. So how do you think about incorporating these biomarkers like hormone, protein, or inflammatory cytokines into frailty assessment?
Yeah, I think that biological changes like hormone instability or is one of the pathophysiology of frailty, and I also check that kind of things at my clinic, outpatient clinic, but I think it is only one dimension of the frailty. So for now, there is no specific chemical biomarkers to identify frailty. There are some kind of cytokines or like anemia or increased creatinine is a related frailty, but I think if that kind of approach could be made, that will be the like a frailty index. I think we could make some kind of some panel of blood test could be made by like frailty index, but I think it costs a lot. So I think comprehensive geriatric assessment is cheaper than that, I think.
Just a question for Eugene. Thank you for your excellent talk. So the current guidelines are extremely vague about these frail individuals, about treating, you say, individualized treatment, which is saying we don't have any evidence. So do you have any certain criteria that you would use to start treatment in these frail individuals with orthostatic hypertension and frailty?
So I think that's at the end of my talk. I still think the problem is that even though both the ESC and the ESH guidelines do provide some contextual framework for assessment of frailty, in reality, as a cardiologist, I don't have time to do some comprehensive assessment. So I think, in general, we use our own clinical judgment about the patient's health status to decide intensity of treatment. So I think that is a gap. I think, as Juhi pointed out also, we don't have enough scientific evidence to really guide specific recommendations. And so as a result, I think that's why it's individualized to the practitioner. And as a cardiologist, I don't have time to do a frailty assessment. Maybe if we have digital tools and things that allow us to do an assessment that is easy to evaluate in clinical context, then that would help. But in general, I think it's sort of the eyeball test. The patient comes in a wheelchair, which many of my patients do or use walkers, then those are probably individuals where my treatment threshold is going to be different, right? And it's not going to be based on the actual chronological age, as mentioned. It's going to be based on the individuals themselves, as I have many active 90-year-old patients where I would still be aggressive in terms of their blood pressure targets. But 55-year-old person with metastatic cancer is probably not somebody where I'm going to be as concerned about, targeting blood pressure, at least in US guidelines, of less than 130. So I think it still becomes individualized decision for most clinicians because we don't have the evidence, and two, because there really aren't clear standards of what to do and how to measure that in most people's practices. So,
Professor Yang, I also have a question regarding the definition of orthostatic hypertension, because the orthostatic hypertension defines the decrease of systolic blood pressure greater than 20 millimeters of mercury after standing. But in many frail elderly patients, their blood pressure is quite low, around 100 millimeter of mercury. And some patients have some orthostatic intolerance, but the decrease of blood pressure is less than 20 millimeter of mercury, so we cannot define those patients as the orthostatic hypertension. But in contrast, some uncontrolled hypertensive patients who have very high blood pressure, the systolic blood pressure tend to decrease more than 30 millimeter of mercury. So many data suggesting that the poor prognosis of the orthostatic hypertension may reflect the uncontrolled hypertension. So, and also considering the autoregulatory the hemodynamic system, some very frail elderly patients showed very low systolic blood pressure, so they exceed the lower limit of the cerebral hemodynamic perfusion pressure. So, what is your opinion about the definition of orthostatic hypertension? Are you happy with the current definition, or we need something more about the definition of orthostatic hypertension?
Yeah, those are great points. And so, in Dr. Durashik's excellent scientific statement, that issue is reflected in this pseudo-orthostatic hypotension, right? So when somebody has a very high blood pressure, the magnitude of change in blood pressure, I didn't have time to say this, but one of the things that it's mentioned in the statement is that maybe you need a different change in blood pressure. So instead of 20 millimeters of mercury, maybe you need 30 millimeters at a minimum because of somebody who has a starting blood pressure that's very high. So I think that sort of addresses that, because that clearly somebody who's a blood pressure 180 that goes to 140, do we necessarily assume they have orthostatic hypotension? Probably not. On the other end, when you're talking about older patients where their central regulatory mechanisms of autonomic function are contributing to potentially the variability in blood pressure or changes or drop in blood pressure, that's again some of the gaps that we're talking about, right? So somebody will have clear orthostatic symptoms but will not meet the definition of orthostatic hypotension. So again, that's where clinical judgment tells you that if some patient tells me that I'm getting lightheaded standing up, even if the blood pressure change is not reflected, then that indicates that there's some intolerance that needs to be recognized, and potentially de-prescribing or de-escalation of treatment is probably necessary.
Thank you. Before closing the session, we're going to present the breakover presentation for the foreign speakers. Dr. Kamide and Dr. Yang, could you come up the stage?
Kamide, in deepest appreciation for your dedication and contribution to the Korean Society of Hypertension as an invited faculty of Hypertension Seoul 2024 in conjunction with the 61st Scientific Meeting of the KSH, November 8, 2024. Eugene Yang, in deepest appreciation for your dedication and contribution to the Korean Society of Hypertension as an invited faculty of Hypertension Seoul 2024 in conjunction with the 61st Scientific Meeting of the KSH, November 8, 2024. 예, 이 자리에서 저희 개회식을 하도록 하겠습니다. 그래서 자리 계속 해주시면 감사하겠습니다. 예, 이 세션은 마무리하도록 하겠습니다. 참석해 주셔서 다시 한번 감사의 말씀드리겠습니다. Thank you for joining this session. 딴 데는
So lovely. So romantic. So fantastic. 발길 닿는 곳마다 사랑이 가득하니까. 여기 서울에서 너만의 소울을 느껴봐. Feel so good. 서울 my soul.
처음에
전 세계 사망 위험 요인 1위 고혈압. 매년 1000만 명이 고혈압으로 인해 사망하지만 고혈압 환자의 절반만이 자기 혈압을 알고 있습니다. 많은 사람들에게 고혈압의 위험성을 인식시키고자 MMN 캠페인이 시작되었습니다. 나와 내 가족을 위협하는 고혈압. 올바른 혈압 측정만으로도 사망을 예방할 수 있습니다. 혈압 측정, 더 이상 미루지 말고 가정에서부터 시작해보세요. 그렇다면 올바른 가정 혈압 측정 방법은 무엇일까요? 측정 전에는 먼저 화장실을 다녀옵니다. 담배, 커피, 혈압약을 복용하지 않고 운동도 하지 않습니다. 커프를 두르는 팔은 맨팔 또는 얇은 옷을 착용해야 합니다. 그 다음 바른 자세로 앉아 5분 정도 안정을 취합니다. 커프는 심장과 같은 높이에 감고 측정 중에는 말을 삼가주세요. 1분 간격으로 아침에 2번, 저녁에 2번 측정하여 기록합니다. 나와 내 가족을 지키는 가장 쉬운 방법. 함께 혈압을 측정하세요.
예, 시간이 돼서 개회식을 시작하도록 하겠습니다. 모두 착석해 주십시오. 예, 안녕하십니까. 대한고혈압학회 총무이사 김광일입니다. Good morning, everybody. This is Kwang Il Kim, the Secretary General of KSH. 하이퍼텐션 서울 2024 제61회 축의 학술대에 참석해 주신 모든 분들께 감사의 인사 말씀드립니다. 지금부터 축의 학술대회를 시작하기에 앞서 대한고혈압학회 회장이신 동국의대 이무영 회장님의 인사 말씀이 있으시겠습니다.
안녕하십니까. 대한고혈압학회 회장 이무영입니다. 이 외국인 분들은 우리가 이제 회장과 이사장이 있다는 걸 잘 몰라가지고 맨날 저보고 프레지던트라고 그러는데요. Actually, I'm not a president. I'm just a chairperson of Korean Society of Hypertension. 오늘 우리 30주년입니다. 고혈압학회 30주년이고 이제 성대하게 이제 고혈압학회 준비가 됐고요. 오늘 고생하신 준비하느라고 여러 선생님들께서 많이 고생하셨는데 감사드리고요. 올해 30주년을 맞이할 여러 가지 준비가 돼 있으니까 우리 고혈압학회 참석하셔가지고 많이 즐겨주시기 바랍니다. 다시 한번 감사드리겠습니다. 고맙습니다.
예, 회장님 감사합니다. 다음으로는 대한고혈압학회 이사장이신 한양의대 신진호 이사장님의 인사 말씀과 축의 학술대회 소개 및 주요 사항을 말씀해 주시겠습니다.
안녕하십니까. 존경하는 회원 여러분, 이렇게 30주년을 맞이하는 하이퍼텐션 서울을 개최하게 돼서 굉장히 기쁘게 생각합니다. 이 행사와 관련해서 많이 수고해 주신 학술위원장, 학술간사님 그리고 모든 학술위원님께 깊은 감사의 말씀을 드립니다. 이번 학술대회와 30주년 행사가 같이 열리기 때문에 우리가 따로 열리는 학술위원회 학술 행사에 그 축하 행사에 많은 관심을 가져주시고 또 서로 축하하면서 그런 분위기로 학술대회가 진행됐으면 좋겠습니다. 영어로 간단하게 인사드리겠습니다. Ladies and gentlemen, it's a great honor for me to welcome you all of our domestic and international colleagues and participants to Hypertension Seoul 2024. This year, the Korean Society of Hypertension proudly reflects on 30 years dedicated to the fight against hypertension, a journey marked by our commitment to disease prevention, overcoming ignorance and unawareness, and the spirit of collaboration. Today we face new challenges including an aging society, the rise of big data and artificial intelligence, and issues with the communication and non-adherence. But we remain steadfast in our efforts to tackling these challenges together, for making progress step by step to advance science and improve care and our friendship. Most of all, I would like to express my special thanks to Professor Jang Won-shin and all the members of scientific committees for their hard work in preparing the program for this meeting. We warmly and happily invite you to join us at Hypertension 2020-24 and enjoy your time here in the city of Seoul. Thank you. 그리고 제가 나머지 학회에 대한 소개를 간단하게 해드리도록 하겠습니다. 지금 30주년에 관련된 내용들은 함께한 30년, 함께할 100년 이렇게 고혈압학회로 정해져 있고 저희 이거 제가 소개합니다.
예.
평점은 잘 아시겠지만 평점기에 입시를 할 때 퇴장할 때 한 번씩 꼭 스캔해 주셔야 됩니다. 그리고 주요 세션은 이제 그 에피데미올로지 세션, 그다음에 솔트와 관련된 세션이 열리게 되겠고 관례적으로 저희가 컬래버레이션 하고 있는 Korean Society of Nephrology와 조인트 심포지움이 예정돼 있습니다. 그리고 영어 세션은 주로 룸 A에서 열리게 되고 올해는 룸 B에서 토요일 날 Society of Obesity와도 조인트 심포지엄이 열려서 앞으로 비만에 대해서 저희 고려학회에서 좀 더 액티브한 그런 리서치나 콜래보레이션을 계획하고 있습니다. 이번에는 총 15분의 Foreign International Faculty께서 저희 인비테이션에 응해 주셔서 풍성한 그런 학술 강연을 들을 수 있을 것으로 생각됩니다. 또 어워드 세션은 영 인베스티게이터 클리니컬 리서치 어워드가 있고 포스트 프레젠테이션에 대해서도 어워드가 있겠습니다. 포스트 프레젠테이션 존은 exhibition area의 보더에 설치되어 있기 때문에 스크린으로 설치되어 있기 때문에 참여하셔서 많은 디스커션을 해주시면 좋겠습니다. 그리고 직접 참여하시지 못하는 분들을 위해서 온라인으로 또 웨비나 사이트를 이용해서 인터랙션을 할 수 있는 그런 기회가 있으니 이것도 많이 참여해 주시기를 바라겠습니다. 올해 저희가 또 그 Korean Hypertension Fact Sheet를 업데이트 했는데 이 팩트 시트는 저희 홈페이지에서 많이 활용해 주시기를 바라겠습니다. 이상으로 학회에 대한 소개를 마치고 참여해 주신 여러분께 감사드립니다.
예, 신진호 이사장님 감사합니다. 예, 학술제 주요 이벤트에 대해서 안내해 드리도록 하겠습니다. 대한고혈압학회 올해가 이제 30주년이 되는 해입니다. 창립 30주년을 맞이해서 오늘 오후 6시에 이 자리에서 기념 행사를 진행하오니 많은 분들의 관심과 참석을 부탁드리겠습니다. 저희가 30주년을 맞이해서 기념 행사 경품 추첨도 예정하고 있습니다. 경품함은 12시부터 5시 30분까지 등록 데스크 앞에 비치될 예정이고요. 다음과 같은 1, 2, 3등 경품이 준비되어 있습니다. 올해는 경품 추첨이 이제 2번 있습니다. 그래서 폐회식 때 또 이 자리에서 경품 추첨이 진행이 될 거라서요. 명찰에 포함된 경품 응모권을 응모함에 넣어주시면 1등부터 5등까지 다양한 경품을 드릴 예정입니다. 응모함은 내일 12시부터 5시까지 안내데스크에서 운영될 예정입니다. 또 스탬프 투어가 진행이 됩니다. 그래서 이번 학술대회에 많은 후원사에 이제 참여가 있었는데요. 등록하실 때 현장 안내데스크에서 받으신 스탬프 투어 용지를 지참하셔서 전시부스 방문하시면은 스탬프 투어 참여가 가능하겠습니다. 또 저희 내린이 마스코트인 내린이가 이제 학회장 곳곳에 있어서 내린이 찾으셔서 거기서 스탬프 찍으시면 좀 재미있는 투어가 되지 않을까 싶습니다. 적극적인 참여 부탁드리겠습니다. 마지막으로 대한고혈압학회 임우영 회장님의 개최 선언이 있겠습니다.
일단 저보고 개최 선언을 해달라고 요청을 받아서요. I'd like to express to all of you, express my warmest or hottest greeting to you. And I asked to opening announcement here. So I will express. 지금부터 2024년 대한고혈압학회 하이퍼텐션 서울 30주년 고혈압학회 학회를 개최하겠습니다. 참석해 주신 여러분께 모두 감사드립니다. 많이 즐겨주시기 바랍니다.
빠지게 될 거야.
In the heart of the city where
So lovely,
love paints the street and inspirations.
so romantic,
Excitement's in the air, it's a playground of delight. Soulful cities call.
so fantastic. 발길 닿는 곳마다 사랑이 가득하니까. 여기 서울에서 너만의 소울을 느껴봐. Feel so good. 서울 my soul.
전 세계 사망 위험 요인 1위, 매년 1,000만 명을 사망케 하는 고혈압. 정기적인 혈압 측정만으로도 나와 내 가족을 지킬 수 있습니다. 뇌, 심장, 신장, 눈 등 주요 장기에 조용하지만 치명적인 손상을 일으키는 고혈압. 전 세계 고혈압 환자 중 절반은 자기 혈압을 인지하지 못하고 있습니다. 나트륨, 지방, 흡연, 음주를 줄이고 가벼운 운동과 적정 체중을 유지하여 모르는 사이에 건강을 침범하지 못하도록 고혈압을 예방하고 행복을 지킬 수 있습니다. 나와 내 가족을 지키는 방법. 혈압 측정부터 시작합니다.
Love my soul. 서울에 오면 사랑에 푹 빠지게 될 거야.
In the heart of a city where
So lovely,
love paints the street and inspirations of
so romantic,
excitement in the air. It's a playground of delight. Soulful cities call.
so fantastic. 발길 닿는 곳마다 사랑이 가득하니까. 여기 서울에서 너만의 소울을 느껴봐. Feel so good. 서울 my soul.
지금 시작해야 되는데 어떻게? 5분 발, 예, 영어 5분 발표에 아니 7분 발표에 5분 디스커션. 이치 프레젠테이션마다.
Good morning, ladies and gentlemen. Welcome to Young Investigator Award. My name is Jong-won Ha from Yonsei University. Professor Il-seok Son from Kyunghee University will co-chair this session. In this session, we have three judges. Professor Jung-woo Son from Yonsei Wonju University, Professor Jung-sun Jo from Catholic University, and Professor Hae-mun Jung from Kyunghee University. So I'd like to introduce first presenter of this session, Dr. Jian Lee from Korea University. She'd like to talk on current status of use of validated home blood pressure monitoring devices among Korean patients with hypertension. Dr. Lee, please.
Thank you for the introduction. Hello, I'm Jian Lee, and my topic is current status of use of validated home blood pressure monitoring devices among Korean patients with hypertension. I have no conflicts of interest. Hypertension is the most modifiable risk factor of cardiovascular diseases, but the control rate defined as blood pressure lower than 140 over 9 millimeters of mercury is only 56% in Korea. The accurate determination of BP is very important, and home blood pressure monitoring improves the diagnosis and treatment of hypertension. And current clinical guidelines advocate the use of validated HBPM devices. The 2023 ESH guideline strongly recommended only properly validated devices should be used and presented stride BP. And the most recent 2024 ESCC guideline also recommended to measure BP using validated devices as a class 1. However, formal clinical validation for BP devices is not mandatory in all countries to be put on the market. According to the recent review paper of the BP monitors available, less than 15% of the devices are validated, and one Australian study showed only 18% of the validated wrist devices and upper arm devices. There are 2 Korean studies. Professor Jung's study conducted in a single center in Suwon with 200 people showed that only 39% of the patients were using validated devices. And Professor Reed's study, which conducted in 2 cities of Goyangsi and Pajusi, showed 52% of the patients using validated devices, but it was conducted with 350 people. So larger number and with more heterogeneous and general population with national data is needed. This study was conducted on Korean hypertensive patients using Care4Me, a smartphone healthcare application, which allows the patients to record their HBPM. The patients can input their HBPM data as well as their model number of HBPM devices, and their physicians can monitor their patients' HBPM. STRIBP is an international organization endorsed by ESH, ISH, and World Hypertension League. And they presented validated home blood pressure devices. So we checked the devices the patient inputted on the app based on the stride BP. According to the stride BP, validated devices included 3 categories, which is validated devices which have passed established validation procedures that have been checked and approved by the stride BP board, and preferred devices which have fulfilled at least one stride BP approved validation study, and equivalent devices which is equivalent to a device that has fulfilled the criteria. From January 2022 to August 2024, total 2,731 patients they inputted their model number of HBPM devices on the app. There are 56% of men, and the mean age was 53 years old. And patients were enrolled all over the South Korea, including Seoul, Gyeonggi-do, Incheon, and Jeollado, and Gyeongsang-do, and 3 university hospitals and 162 primary clinics. And around 73% of the patients were from primary clinics. From the total population, about 97% of patients were using upper arm devices and 3% of using wrist devices. And only 46% of the patients, which is 1,255 patients, were using validated devices. We further checked the validation status based on the models. 110 models were identified, and with stride BP, about 23% of the devices were validated, and with Medavo, around 18%, and with Dable, another general registries, around 23% of the devices were validated. When we combined these 4 registries, the validation status improved up to 33%. Then why the use of validated HBPM devices is higher in Korea than other than the world? Because since 2014 October, the Ministry of Food and Drug Safety only approved the devices which fulfilled ISO criteria, which is the difference of mean difference less than 5 and mean standard deviation less than 8 millimeters of mercury. So we further checked the validation status of the models based on approval dates. And we found out that 48% of the validated devices were marketed after the date. When we check the baseline characteristics according to the validated devices, we found out that Seoul has the highest percentage of patients using validated devices, whereas Incheon showed the lowest, which is statistically significant. So this is the first nationwide study to analyze the current status of the use of validated HBPM devices among real-world hypertensive patients in Korea. Our study contains a large number of patients who are heterogeneous and generalized from 3 university hospitals and 162 primary clinics with precise data. And we found that only 46% of the patients were using validated upper arm or wrist devices. These results propose the patient education on accurate HBPM and public accessibility of validated devices is urgently needed for a better management of hypertension. Thank you for your attention.
Thank you, Dr. Lee, for the excellent presentation. So the Q&A will be
For 5 minutes. From judges.
Okay. So every presentation will be followed by the Q&A. So the judges can ask.
My question is whether there is the price difference of between validated and non-validated device. If there is a price difference and the non-validated device is cheaper, then I can accept that the non-validated device would be chosen. But if there is no price difference, then non-validated device would be chosen due to a lack of information for device. How about?
That's a great question. Actually, I didn't search all of the prices of 110 models, but even for Omron device, which is the supposed to be most accurate, they also have non-validated devices, a lot of it. So I don't think the non-validated devices are cheaper than validated devices. And I also searched Naver about the home BP devices, and I found out a site that patients use to how to choose the good HBPM devices, and they ask each other and they searched for the information in table and stuff when they can read English and stuff. So I think there can be a difference between English readers and non-English readers, etc.
Thank you for presenting this valuable research on the use of validated blood pressure device in our country. I'm surprised to learn that nearly 50% of all home blood pressure devices are not validated, but even more higher, that is higher than other countries. And I have one question. Have you compared the difference between the validated blood pressure device and office blood pressure, as well as between the non-validated device and office blood pressure? Do you have data?
Actually, in this study, we didn't compare the values checked by validated or non-validated HBPM device to the office BP, because we focused on the validation status. But as I presented on the slide, because of the Minister of Food and Drug Safety Department's approval on BP devices, they have to be accurate after 2014 October with mean difference and standard deviation. So after that device, about 48% of the HBPM devices, they can be accurate. I think there will be a correlation with the office BP.
only one comment. And this research was based on data recorded by patients using the application. And because application users are relatively more engaged patients, I think the results may show a higher rate compared to the general patient population. Yeah.
Yes, I think so too. But also the two previous Korean studies, one study of Professor Tong included patients in one clinic, and they asked patients to bring the devices to the clinic so they can be eager patients than others. And Professor Reed's study also, it's a telephone study of survey. So I think because our study contains patients from around 170 clinics and hospitals, I think he can represent better population of the real world. Thank you.
Okay, thank you, Dr. Lee. We'd like to move on. Next presenter. Next presenter from Hallym University, Dr. Dae-young Chun, and he'd like to talk on lower systolic blood pressure associated with 10-year mortality in young patients, nationwide cohort study. Dr. Chun, please.
Thank you for your kind introduction, Chairman. My name is Dae-young Chun from Hallym University, Korea, and it is very honor for me to have make a presentation in such a great conference, 2024 KSHE, in 13th anniversary. I have nothing to disclosure. Hypertension significantly influences the development of cardiovascular disease, especially in young adults. And there are studies on the association between systolic blood pressure and cardiovascular disease in young adults before they develop hypertension. We already know about so many studies such as Framingham Heart Study or Cardia Study or MESA Study and so on. But most are composed of a small number of cohort studies, not just small number, 1,000 or 10,000, but highlighting the need for research on much more larger populations. So our study utilized the Korean National Health Insurance Database to assess major adverse cardiac and cerebrovascular event risk relative to systolic blood pressure levels in individuals in their 30s up to 13 years. A retrospective cohort of 5,653,519 individuals in 30s from the KNHID database provided data on demographics, health behaviors, and comorbidities. Systolic blood pressure was the primary exposure, categorized into 7 groups, each divided by 10 millimeter mercury increments, ranging from less than 100 millimeter mercury to over 150 millimeter mercuries, and analyzed alongside factors such as diabetes, dyslipidemia, and lifestyle habits. The primary outcome was a composite of myocardial infarction, heart failure, stroke, and all-cause death. The majority of patients fell within the systolic blood pressure between 110 to 119 millimeter mercury range, 30.9%, and 7.2% patients were already diagnosed with hypertension and already taking antihypertensive medications. And lower blood pressure were more likely to be female and had a lower body mass index. In lifestyle, increase in systolic blood pressure was associated with higher alcohol consumption and a current smoker. And among comorbidities, the proportion of diabetes and dyslipidemia tended to increase with higher systolic blood pressure. The composite primary outcome occurred in 1.9% of the study populations, with myocardial infarction at 0.2%, heart failure at 0.2%, stroke at 0.7%, and all-cause death at 0.8%. When calculating hazard ratio using individuals with systolic blood pressure more than 150 millimeter mercury as a reference, the data indicates that hazard ratio decreases correspondingly with the reduction in blood pressure. We set the more than 150 millimeters as a reference hazard ratio 1, and at that time, between 140 to 159, 149 has a hazard ratio is 0.65, and 130 to 139 has a 0.52, 0.44. The hazard ratio is decreasing correspondingly with the reduction in blood pressure. This trend was consistent for each component of the primary composite outcome. Myocardial infarction has the same consistent same trend, and stroke and cardiac death has the same trend. Heart failure has a little bit different consistent because less than 110 millimeter mercury. At that time, the hazard ratio was reversed between below than 100 and over 110. It may be related with J phenomenon, and showing a decrease in hazard ratio with lowering blood pressure and other composite outcomes. Also, the Kaplan-Meier curve for event-free survival shows that the lower systolic blood pressure group has a higher survival rate. The higher systolic blood group has a lower survival rate, and the trend varies over the time to 13 years. So not just a single component, but each MACE component, excluding heart failure, and their composite all show a reduction in hazard ratio when systolic blood pressure is lowered. So these insights are vital for shaping public health strategies and tailoring personalized medical approaches, particularly for the young adult populations who had not hypertension but elevated blood pressure. This study has some limitations because this cohort only drawn from a single country, East Asian, and blood pressure measurements were taken only once at that time, and not account for variables such as adherence to salt reduction, other dietary practices, or types of physical activities. But this study highlights the importance of strategy for early blood pressure management in young adults who had not hypertension, but we can reduce cardiovascular disease risk from large cohort data. As we shown in 2024 European Society of Cardiology guidelines, they mentioned not only hypertension patients, but they mentioned elevated blood pressure patients, and they have to observation more accurately and more, they have to accurately. So this study extends our current understanding by providing research from the largest cohort to date and showing that lower systolic blood pressure is associated with a lower risk of cardiovascular disease. Thank you for your attention.
Thank you, Dr. John, for the excellent presentation. This presentation is open for comment from the judges.
The leading cause of death among young people is suicide, but all-cause mortality is included among the primary endpoint. It seems that caution is needed interpreting this result. What do you think about?
I didn't mention about that, but we exclude the patient who had a traffic accident patient and who had a suicide patient in KNHD database, but not sure because as you know, the Korean database had sometimes had a database on the suicide attempt or something, but sometimes are not, so not accurate, and we will already known about these problems, but so maybe the total amount of the all-cause death is a little bit high rather than expected. So maybe it can be reflected by, as you mentioned.
Thank you for your presentation. In a young adult population with a low prevalence of other comorbidities, blood pressure could be an important factor influencing clinical outcomes. However, since only a single BP measurement was taken, the possibility of BP elevation due to conditions other than cardiovascular disease should also be considered. And it seems that this study did not analyze factors other than hypertension. Were other comorbidities adjusted for in the analysis?
Thank you for your very valuable questions. Yes, this is the weakest point that only a single point of a blood pressure can cannot evaluate whole time their cardiovascular risk, mortality, or so on. So this is the weakest point. But when you have health, we have a health checkups, and at that time, when the patient have a high elevated blood pressure at that time, we should to have the warning signs to they are going to be a more prevalent cardiovascular disease rather than normal blood pressure or lower blood pressure patient. So we have make another strategy for elevated blood pressure only a single time. And second, we analyze multi-analyze such as diabetes and dyslipidemia and some kind of smoking habit or alcohol consumptions. We analyze the whole multivariable analyze the whole analyze, and we conclude that including the diabetes or dyslipidemia or other risk factors and all excluding, it can same result as I showed.
Thank you for excellent research. Early treatment of hypertension in young patients with low cardiovascular risk is often ambiguous and may easily be overlooked by both the patient and clinician in clinical practice. Although the difference in the survival curve are not big, quite high, but you can clearly see the lower blood pressure is associated with a better event-free survival, even in young patients. In patients who already been diagnosed with hypertension, having antihypertensive medication, has this pattern been consistent observed?
Thank you for your valuable questions. I forgot that mention about that. Yes, there are only 7.9%, less than 10% of patients already taking antihypertensive medications, already diagnosed with hypertension, and they have a consistent finding on the basic research. So lower blood pressure with more event-free survival in hypertension patient and non-hypertension patient. That is consistent finding.
There is no J phenomenon in young patient.
Yes, no J phenomenon in the primary outcome, but only in heart failure. There is a J phenomenon was observed in heart failure outcomes, not myocardial infarction, and all-cause death or stroke.
Okay. Dr. Chun, thank you for your nice presentation. Professor Sun will lead next two.
Thank you, Dr. Ha. Okay, I will moderate next two presentations. I'm Il-Seok Sun from Kyung University. I'd like to introduce the third speaker, Soo-Jung Park from Hanyang University. She will talk about the association between body shape index and incidence of cardiovascular events in Korean adults with hypertension. Dr. Park, please.
Thank you for your kind introduction. Hello, everyone. My name is Soo-Jung Park from Hanyang University Medical Center. Today, I'm here to present my research titled Association between a Body Shape Index and Incidence of Cardiovascular Events in Korean Adults with Hypertension. I'll introduce the backgrounds of my study. Obesity is well recognized as a key cardiovascular risk factors, and both American and European guidelines recommend using BMI as the primary measure for assessing obesity. However, abdominal fat carries higher risk than subcutaneous fat. Both guidelines also suggest measuring waist circumference in addition to BMI. However, conventional anthropometric indices like BMI and waist circumference have limitations in accurately reflecting abdominal obesity. BMI cannot distinguish fat and muscle, and it can also fails to account for fat distribution. Although waist circumference is a useful measure of abdominal fat, but it is strongly correlated with BMI, limiting its independent predictive value. So these limitations likely contribute to obesity paradox. Now I'll explain a body shape index, a new metric developed to overcome these limitations. ABSI was first introduced in 2012 by Neil Krakauer, an American researcher, and ABSI is calculated using formula shown on the left side of the slide. ABSI is calculated using waist circumference, removing the influence of BMI, height, and weight. And in this adjustment allows ABSI to achieve independent measurement of abdominal fat accumulations. ABSI can provide better reflection of abdominal fat accumulation, so it is expected to improve the prediction of cardiovascular and metabolic risks. Many studies have utilized ABSI in various populations, and this slide shows one of the key findings from the original study. This graph shows how ABSI and BMI and waist circumference relate to mortality risk. On the left, ABSI graph shows that as ABSI increases, the mortality risk rises steadily. In comparison, BMI and waist circumference graph shows U-shaped pattern, suggesting that ABSI has stronger and more consistent linear relationship with mortality risk. This is the study overview. As we have discussed so far, a body shape index can serve as a novel risk factor for predicting cardiovascular events. Numerous studies have investigated ABSI, but no studies have examined its predictive value for Korean patients with hypertension. Therefore, the aim of this study is to evaluate the predictive value of ABSI for cardiovascular events in Korean patients with hypertension. We used data from Ansan cohort, and to compare outcome effectively, participants were divided into 3 groups based on their ABSI totals, and primary outcome was base. Let's move on to the method. I'll explain our data source and how we collected information. Our study is based on Ansan cohort, which is a part of Korean Genome and Epidemiology study. Since 2001, 10,030 Koreans aged 40 to 69 years living in Ansan and Ansong have been enrolled. Participants have undergone 8 serial follow-up assessments conducted every 2 years through scheduled revisits over a 16-year period. This is the flowchart of the study. In this study, hypertension is defined as follows, shown on the left side of the slide. Out of 10,030 participants, we identified 3,757 participants who met this definition of hypertension. And participants with a history of MACE and loss of follow were excluded. And finally, 3,237 patients were left for the final analysis, and we divided these participants into 3 groups according to ABSI totals. And this is the result. This table shows baseline characteristics. Overall, the participants with the higher ABSI total show the trend having higher age in male sex and higher systolic blood pressure, and the prevalence of diabetes mellitus and chronic kidney disease and worse metabolic profiles are more common in the higher ABSI total. And higher ABSI total is associated with a greater waist circumference, while BMI was not. And this graph shows cumulative incidence of cardiovascular events over a 16-year follow-up period. The third total, represented by the blue line, was the highest incidence of MACE, while the first total, shown in red, has the lowest. And this table shows incidence and hazard ratio for cardiovascular events using by Cox proportional hazard model. It indicates that higher ABSI total is associated with the increased risk of MACE, and even after adjusting several variables, including age, sex, BMI, blood pressure, and medical history, higher ABSI total increases risk of MACE about 1.4 times. And this is the conclusion. We found that a body shape index is significantly associated with the incidence of MACE in Korean middle-aged adults with hypertension. Thus, ABSI may serve as a useful marker for identifying middle-aged hypertensive patients at high risk for cardiovascular events. Finally, future research is needed to explore the clinical implication of using ABSI in routine practice for risk stratification and management of hypertensive patients. This concludes my presentation. Thank you for your attention.
Thank you, Park, for your great presentation. It's time for discussion for your talk. Judges, please.
The body shape index show result that it can be a useful marker for high risk group for Korean hypertension patient. Since the body shape index is calculated by adding waist circumference to weight and height, which constitute BMI calculated. So in this study, show better prediction for event than the results based on BMI. Do you have a analysis?
Compared to BMI?
Yeah.
Yes, we did compare to BMI and waist circumference, but I did include that result on this presentation, but they are similar in predictive power, but ABSI is not superior to conventional indices.
Yeah. Were there any differences in the results based on gender, female or male?
I can't answer that question right now, yeah.
When the predicting mortality risk, lower BMI and waist circumference can be paradoxically be associated with a higher mortality, as you said, the U shape. But whereas lower body shape index consistently indicate the lower mortality risk, make me more clear to interpret. I agree with that, but body shape index is a required quite complex formula for calculation, which can be complicated for the clinical use. Do you have any more simpler method or practically useful for the in clinical setting?
I agree with your opinion because it is more complex than conventional indices. And I think ABSI is created based on Western population. So a new metric for especially for Asian, East Asian population would be valuable for the hypertensive patient.
One more question? Okay, thank you, Dr. Bach. We will move on to last presentation. I'd like to introduce last speaker in this session, Dr. Hee-jin Lee from Seoul National University. She will talk about the accuracy of the cuffless wearable ring-type blood pressure monitor, CAT-1 Plus, versus conventional 24-hour ambulatory blood pressure monitoring. Dr. Lee, please.
Thank you for the introduction. I'm Hee-jin Lee from Seoul National University Hospital. Why do cuffless blood pressure measurement devices evolve? Cuff-based office blood pressure measurement has several limitations. One significant limitation is well known that blood pressure changes throughout the day. Especially blood pressure changes during sleep exhibit several patterns in different individuals. These changes during sleep are categorized into 4 types: extreme deeper, deeper, non-deeper, and riser. These diurnal patterns of blood pressure variation is important because it helps identify different cardiovascular risks. Therefore, accurate measurement of blood pressure during sleep is crucial for predicting and appropriately managing cardiovascular risks. Due to the aforementioned limitations of cuff-based office blood pressure measurements, hypertension guidelines recommend the use of ambulatory blood pressure monitor or a home blood pressure monitor to diagnose hypertension. However, ABPM often held as the solution to the limitation of office blood pressure. also has its own limitations. Since ABPM is a cuff-based device, repeated measurements during sleep can result in poor sleep quality and elevated blood pressure during cuff inflation. This may provide an accurate picture of the patient's blood pressure pattern during sleep. This study aimed to assess the accuracy of Cartman Plus device, a novel ring-type cuffless blood pressure measurement device across various ages, genders, and medication status in comparison with standard ambulatory blood pressure monitoring. Now let's take a look at our protocol and data pre-processing methods. Cartman Plus is a ring-type cuffless blood pressure monitor that uses photoplasmogram technique. This study compares blood pressure measurements taken by Cartman Plus and ABPM over a 24-hour period. Before the 24-hour measurement, the device was calibrated in 3 different positions. During the data pre-processing stage, 15-second PPG signal from the Cartman Plus were converted into 10-second signals from after filtering out noise to enhance signal quality. The mean age of the participants was 52 years with a predominance of female. The distribution of mean blood pressure was as follows, and 45% of patients were receiving medical treatment for hypertension. During a 24-hour period, the ABPM monitor recorded an average of 60 blood pressure readings, whereas the Cartman Plus blood pressure recordings were average of 750 blood pressure readings. Let's first look at the main results of the study. The means of the ABPM and Cartman Plus blood pressure readings did not differ by more than 5 millimeter mercury, and the standard deviation did not differ by more than 8 millimeter mercury for both systolic blood pressure and diastolic blood pressure over 24 hours during daytime and nighttime. The correlation plot also confirms a strong correlation between the measurements from the 2 devices with R values all above 0.7. The blind outcome plot also confirmed the agreement between the measurements from the 2 devices. A strong correlation was also observed when comparing the ability of the 2 devices to track diurnal changes. The ROC curve confirmed the ability of Cartman Plus to diagnose hypertension. Now let's take a look at the results of the subgroup analysis. When subgrouped based on the mean age of 52 years, sex, and medical treatment for hypertension, there was a high agreement between the blood pressure measurement between Cartman Plus and ABPM with no significant differences between the groups. We explained whether there was a difference in agreement between the 2 groups based on how they were calibrated. We found no differences in agreement between whether the devices were calibrated for sitting, standing, and supine positions separately or by combining calibration data from all 3 positions or 2 positions. In further analysis, we examined blood pressure changes according to cuff inflation and found no significant differences during the daytime. However, a significant increase in blood pressure was observed after cuff inflation during the nighttime. let me conclude. The Carton Plus ring type cuffless blood pressure measurement device demonstrated remarkable accuracy in recording blood pressure through PPG signals over various periods compared to standard 24-hour ABPM. Its innovative design and efficient data collection capability represent significant progress in blood pressure monitoring technique, offering strong potential for future integration into clinical environments, particularly for tracking nocturnal hypertension. Thank you for your attention.
Thank you, Dr. Lee. Is open for discussion. Judges?
The cuffless device is based on photoplasmography. So when compared to ABPM, there is no statistic difference, but it seems to measure lower value for daytime and higher value for nighttime. So there is a bit difference in the night deep difference result. So I wonder if there are any limitation in measuring blood pressure using photoplasmography when there is a variability in blood pressure.
Thank you for your follow-up question. It is different way to measure the blood pressure between Carton Plus and ABPM, but so there's a difference in our time. We are low value. We show low value in diastolic blood pressure, and also daytime we show low blood pressure, but we think that we're going to correcting the measurement way, but I think the tracking is more important. We only use office blood pressure and sometimes use home blood pressure, but tracking 24-hour is more important, I think.
I have a similar question. Have you ever considered or investigated any reason of the higher? Usually, the ring type blood pressure monitor tend to be lower reading compared to home AMBP, but appear higher, especially at night. So, do you investigate the reason of the compared to AMBP? Is a ring type cuffless blood pressure device more higher than AMBP at night time? Patient position or something like that?
Yeah, we also worried about the result. We are arguing that the nighttime VP may be overestimated for the cuff inflation, but in fact our result is more higher than the ABPM. So, but we couldn't find the reason. But also, I answered to the judge. I think the tracking is valuable for this device, but still remain the limitation.
No more comments? Okay, thank you. Thank you, Dr. Lee, for your nice work. Okay, it's time to close this session. Thank you all the speakers and judges for your great job, and audience for your kind attention. Thank you.
Love my soul. 서울에 오면 사랑에 푹 빠지게 될 거야.
In the heart of the city where
So lovely,
love paints the street and inspirations are
so romantic,
excitement in the air. It's a playground of delight. Soulful cities call.
so fantastic. 발길 닿는 곳마다 사랑이 가득하니까. 여기 서울에서 너만의 소울을 느껴봐. Feel so good. 서울 my soul.
요즘 자주 보이는 단어가 하나 있습니다. 고혈압. 혈압이 만성적으로 정상보다 높은 것을 말하는데요. 수축기 혈압이 140, 이완기 혈압이 90 이상이면 고혈압으로 판정합니다. 우리가 고혈압에 관심을 기울여야 하는 이유는 무엇일까요? 바로 고혈압은 뇌혈관 질환, 심부전증, 동맥경화증과 심장질환 등의 합병증을 일으킬 수 있기 때문입니다. 국내 성인의 고혈압 유병률은 28.4%. 우리 가족도 그 위험에서 벗어날 수 없겠죠? 고혈압은 특히 가족력이 크게 작용하는 질환입니다. 부모 모두 고혈압의 경우 80%, 한쪽만 고혈압의 경우 20에서 50%로 자녀에게서 나타납니다. 그렇다면 우리 가족이 실천할 수 있는 고혈압 예방 및 관리법은 무엇일까요? 바로 금연, 절주, 운동, 식이요법입니다. 흡연과 음주는 혈압 상승에 강력한 위험 요인이므로 금연 및 절주는 필수적입니다. 또 규칙적인 운동도 혈압을 줄이는 데에 효과가 있습니다. 지방과 정제 탄수화물을 줄이고 과일과 채소 섭취를 늘리는 대시 식단과 소금 섭취를 줄이는 것도 도움이 됩니다. 주기적인 혈압 측정과 지속적 관리로 너와 내 가족의 건강을 지켜주세요.
Love My Soul. 서울에 오면 사랑에 푹 빠지게 될 거야.
In the heart of the city where
So lovely,
love paints the street and inspirations are
so romantic,
excitement in the air. It's a playground of delight. Soulful cities call.
so fantastic. 발길 닿는 곳마다 사랑이 가득하니까. 여기 서울에서 너만의 소울을 느껴봐. Feel so good. 서울 My Soul.
요즘 자주 보이는 단어가 하나 있습니다. 고혈압. 혈압이 만성적으로 정상보다 높은 것을 말하는데요. 수축기 혈압이 140, 이완기 혈압이 90 이상이면 고혈압으로 판정합니다. 우리가 고혈압에 관심을 기울여야 하는 이유는 무엇일까요? 바로 고혈압은 뇌혈관 질환, 신부전증, 동맥경화증과 심장질환 등의 합병증을 일으킬 수 있기 때문입니다. 국내 성인의 고혈압 유병률은 28.4%. 우리 가족도 그 위험에서 벗어날 수 없겠죠? 고혈압은 특히 가족력이 크게 작용하는 질환입니다. 부모 모두 고혈압의 경우 80%, 한쪽만 고혈압의 경우 20에서 50%로 자녀에게서 나타납니다. 그렇다면 우리 가족이 실천할 수 있는 고혈압 예방 및 관리법은 무엇일까요? 바로 금연, 절주, 운동, 식이요법입니다. 흡연과 음주는 혈압 상승의 강력한 위험 요인이므로 금연 및 절주는 필수적입니다. 또 규칙적인 운동도 혈압을 줄이는 데에 효과가 있습니다. 지방과 정제 탄수화물을 줄이고 과일과 채소 섭취를 늘리는 대시 식단과 소금 섭취를 줄이는 것도 도움이 됩니다. 주기적인 혈압 측정과 지속적 관리로 너와 내 가족의 건강을 지켜주세요.
Love My Soul. 서울에 오면 사랑에 푹 빠지게 될 거야.
In the heart of the city where
So lovely,
love paints the street and inspirations are
so romantic,
excitement in the air. It's a playground of delight. Soulful cities call.
so fantastic. 발길 닿는 곳마다 사랑이 가득하니까. 여기 서울에서 너만의 소울을 느껴봐. Feel so good. 서울 My Soul.
요즘 자주 보이는 단어가 하나 있습니다. 고혈압. 혈압이 만성적으로 정상보다 높은 것을 말하는데요. 수축기 혈압이 140, 이완기 혈압이 90 이상이면 고혈압으로 판정합니다. 우리가 고혈압에 관심을 기울여야 하는 이유는 무엇일까요? 바로 고혈압은 뇌혈관 질환, 신부전증, 동맥경화증과 신장질환 등의 합병증을 일으킬 수 있기 때문입니다. 국내 성인의 고혈압 유병률은 28.4%. 우리 가족도 그 위험에서 벗어날 수 없겠죠? 고혈압은 특히 가족력이 크게 작용하는 질환입니다. 부모 모두 고혈압의 경우 80%, 한쪽만 고혈압의 경우 20에서 50%로 자녀에게서 나타납니다. 그렇다면 우리 가족이 실천할 수 있는 고혈압 예방 및 관리법은 무엇일까요? 바로 금연, 절주, 운동, 식이요법입니다. 흡연과 음주는 혈압 상승의 강력한 위험 요인이므로 금연 및 절주는 필수적입니다. 또 규칙적인 운동도 혈압을 줄이는 데에 효과가 있습니다. 지방과 정제 탄수화물을 줄이고 과일과 채소 섭취를 늘리는 대시 식단과 소금 섭취를 줄이는 것도 도움이 됩니다. 주기적인 혈압 측정과 지속적 관리로 너와 내 가족의 건강을 지켜주세요.
Good afternoon, everyone. I'm Sung-Won Choi from Hallym University. It's time for the luncheon symposium by sponsors to Daewoo and Daiichi Sankyo Korea. So, as you know, this year the symposium is 30 years the birthday of Korean Society of Hypertension. So the motto is 30 years together and 100 years partner. So you're all attended to the hearing this important issue on the blood pressure control and take a good bill. So there is two speakers from this session. The first speaker is Kim Hemi from the Jungang University. She will talk about the update on BP control strategy in elderly patients with hypertension. So please.
Thank you for your kind introduction. Good afternoon, everyone. I'm Hemi Kim from Jungang University Hospital. Today, I will discuss update on blood pressure control strategy in elderly patients with hypertension. Here's the outline of my presentation. I will start by examining the specific characteristic of hypertension in elderly patients and review relevant clinical trials and discuss current guideline recommendation. The definition of old age generally begins at age 65 years, while very old traditionally refer to individuals over 80s. However, the ESC guideline recently extended the threshold for the very old to 85. This redefinition reflects the growing focus on nuanced approach in managing elderly patients who often have distinct health profile and need. In Korea, hypertension is prevalent among elderly. Data shows that 50% of individuals of 70 have hypertension, and those aged 65 and above account of 40% all hypertensive cases. This high prevalence means that hypertension is common concern in the elderly, requiring targeted strategy tailored to their unique health characteristics. One primary characteristic in elderly hypertension is arterial stiffness. Aging naturally leads increased arterial stiffness and heightening salt sensitivity, while also reducing glomerular filtration. This combination often results in systolic hypertension with elevated pulse pressure and decreased nocturnal blood pressure dipping. These changes also make elderly patients more prone to drug-resistant hypertension and heart failure with preserved ejection fraction, presenting challenging in clinical practice. During ventricular contraction, some of the stroke volume is temporarily stored in aorta and central arteries. This stretches the arterial wall, raising local blood pressure, and the energy stored in those vessel walls during systole is released during diastole, ensuring a steady blood flow to peripheral tissues. This natural mechanism diminishes as arterial stiffness increases with age. The compliance of large artery also play a critical role in minimizing energy expenditure during organ perfusion and in protecting small arteries in target organs such as brain and kidneys from damaging effect of pressure fluctuation. When arterial compliance decreases, these protective effects weaken, heightening the risk of organ damage. Clinically, we see that as people age, their systolic pressure tends to rise, while diastolic pressure tends to decrease. This pattern contributes to high prevalence of isolated systolic hypertension among the elderly, a trend confirmed by Korean health insurance data. Another characteristic of elderly patients with hypertension is the presence of multiple comorbidities, which complicate treatment plan and necessitate careful consideration of all existing health conditions. Orthostatic hypotension is also more common in this age due to related decline in autonomic nervous system function, resulting in inadequate compensatory response to postural changes. This condition further complicates blood pressure management. Additionally, assessing frailty is crucial alongside age in elderly patients. Frailty can affect medication tolerance of overall prognosis, making individualized treatment strategy essential. Hypertension and frailty often overlap and influence treatment outcomes. In summary, elderly hypertensive patients are often characterized by isolated systolic hypertension with reduced nocturnal dipping and higher rate of orthostatic hypotension and require careful management that consider comorbidity and frailty. Now let's look at the clinical relevance of blood pressure reduction in elderly patients by reviewing major clinical trials. It is well known that higher blood pressure correlates with an increased risk of mortality from cardiovascular disease regardless of age. Even minor elevation of blood pressure can significantly impact the outcomes. A meta-analysis showed that reduction blood pressure by 5 millimeters of mercury significantly lowered the hazard ratio in all age groups except those over 85. These findings support the use of pharmacological blood pressure reduction as a crucial intervention for elderly patients, regardless of the aging. The SHARP trial is a trial that demonstrates a 36% reduction in stroke incidence by treating isolated systolic hypertension in patients aged greater than 60 and older greater than 60 with systolic blood pressure greater than 160 millimeters of mercury or higher. These findings highlighting the importance of blood pressure control in reducing CV risk in the elderly. Similarly, the 60-year study reduced the stroke incidence by 40%, further reinforcing the benefit of systolic blood pressure control in this population aged greater than 60 with the systolic blood pressure over 160. There has been ongoing debate on whether antihypertensive treatment is beneficial for hypertensive patients aged over 80. To address this question, the HYBA study was conducted. For individuals aged greater than 80, and HYBA study compared the antihypertensive treatment with a placebo in patients with systolic blood pressure greater than 160 millimeters of mercury. In this study stopped early because it shows a significant reduction in mortality in treatment group. This outcome was significant even though the reduction in stroke was not statistically significant, underscoring the value of blood pressure control in the very elderly. The HYBA study also analyzed outcomes by frailty and found that frailty did not significantly modify the positive impact of antihypertensive treatment in this population, supporting the benefit of blood pressure reduction in very elderly patients. Up to this point, I have reviewed the benefit of blood pressure control in elderly patients. Now let's review the studies that investigate optimal blood pressure target for this population. The JATO study compared strict versus mild treatment in patients aged 65 to 85 with systolic blood pressure greater than 160 millimeters of mercury, and found no significant difference in primary endpoint. However, among the patients under 75, stricter control appeared favorable. The Banish study also found no significant difference outcome in between strict and moderate blood pressure control in patients aged greater than 70 years and systolic blood pressure over 160 millimeters of mercury. This study raised the question about whether strict blood pressure control is necessary in all elderly patients. However, the SPRINT trial provides different insight, especially through the SPRINT senior study, which focused on patients aged greater than 75. This study showed that intensive blood pressure control reduced absolute event rate across all levels of frailty, supporting the idea that even frail elderly patients can benefit from intensive blood pressure management. After the SPRINT trial, meta-analysis was published by collecting previous studies on elderly population. A meta-analysis of these studies also indicate that the intensive blood pressure control reduces major cardiovascular events in elderly patients, though it may increase the risk of renal failure and adverse events. These mixed findings sparked ongoing debate about intensive blood pressure control in older adults. To address this debate, the STEP trial was published. This study examined the intensive treatment versus standard blood pressure control in patients aged 60 to 80 and providing further clarity on the benefit of intensive treatment in this group. In STEP trial, olmesartan was the primary antihypertensive medication administered initially at 20 milligrams. For additional blood pressure control, amlodipine, thiazide, and beta blockers were added as needed. This structured approach aimed to achieve the target blood pressure in both intensive and standard treatment groups. The trial's participants had an average age of 66, with approximately 46% being male. The mean systolic blood pressure difference between two groups was 9.2 millimeters of mercury. The result was significant. The intensive treatment group achieved 26% reduction in the primary endpoint compared to the standard group, highlighting the cardiovascular benefits of intensive blood pressure control. Secondary outcomes were also favorable with reduction in stroke, acute coronary syndrome, heart failure, major adverse cardiovascular event, and mortality from cardiovascular events in the intensive treatment group. Notably, the safety outcome showed no significant increase in dizziness and hypertension syncope in the intensive group compared to the standard group, suggesting that intensive blood pressure could be well tolerated among the elderly patient. Real-world data following the STEP trial reinforced these findings. The study included over 13,000 patients with hypertension aged 60 to 80 years. Patients were divided into normalized systolic blood pressure, blood pressure less than 130, and non-normalized group. Systolic blood pressure was 130 to 150. This study showed that normalized systolic blood pressure group was associated with reduced CV disease and all-cause mortality in hypertensive patients aged 60 to 80, supporting the trial's conclusion that intensive treatment benefits elderly patients. In the STEP trial's sub-analysis studies showed that intensive treatment was shown to reduce the risk of new-onset LV hypertrophy and significantly slowed the progression rate of the LV hypertrophy. This study confirmed that intensive blood pressure control is effective in reducing the risk and the progression rate of the new onset LV hypertrophy, potentially leading to improvement in cardiovascular outcomes. STEP DBP sub-analysis was confirmed that intensive blood pressure control based on systolic blood pressure, even in patients with low baseline diastolic blood pressure, provide cardiovascular outcome benefit without an increase in adverse event. So in summary, recent study collectively suggests that intensive blood pressure management can lead to better CV outcome in the elderly patient group. Now let's consider how these findings are reflected in current guidelines. Guidelines on target blood pressure for older adults vary. The ACC/AH recommends a target systolic blood pressure less than 130 millimeters of mercury for all patients, reflecting a more aggressive approach. In Korea, the target for elderly patients is systolic blood pressure less than 140 millimeters of mercury, incorporating evidence from SPRINT and the STEP trials. However, for frail elderly patients or those over 80, systolic blood pressure treatment is generally recommended only if blood pressure exceeds 160 millimeters of mercury, acknowledging the unique risk of this population. The 2023 ESH guidelines suggest a target of 140 over 80 for individuals aged greater than 65 or 130 over 80s if tolerable, and recommends initiating treatment at systolic blood pressure greater than 160 for those of 80. This is summary of the 2023 ESH guideline in elderly patient group. The latest ESC guideline suggests an initial systolic blood pressure target of 120 to 129 for patients under age 85 without orthostatic hypotension. For those with moderate frailty under 85, similar targets applies with treatment, start with calcium channel blockers or RAS inhibitors. While guidelines vary, but they increasingly recommend more intensive treatment while advising personalized care for those over 85. Next, I will briefly talk about olmesartan studies conducted in Korea on elderly patients. The RESERVE Pro study, which include 50% of patients aged greater than 65, confirmed the olmesartan's efficacy and safety. Similarly, the RESERVE INTO study in Korean hypertension patients showed high target blood pressure achievement rate in patients with age greater than 65, reaffirming olmesartan's effectiveness in elderly Korean patients. To conclude, controlling blood pressure in patients aged greater than 65 can reduce cardiovascular events and mortality. Although a general target of systolic blood pressure less than 140 or 130 is recommended, individualized treatment based on frailty and cardiovascular risk is essential. Thank you for your attention.
Thank you, Professor Kim. She very good summarized for the BP control in the elderly patients. So all the guidelines says the elderly patient is a subpopulation, but as you should saw, the Korea's hypertension is older than 65 is high increasing, and 43 patients are old ages. So I don't think that all the elderly hypertension is not a subgroup population, it's main group of population for prevention of hypertension. So I move on to the next speaker, Chun Dae-young from Hallym University. He will talk about the optimal strategy for the 24-hour BP management. So the long time and good control of blood pressure is important for him. So please.
Thank you for the kind introduction, Chairman. My name is Dae-young Chun from Hallym University, and my title of the presentation today is Perfect 24-Hour Blood Pressure Control Strategy under Antihypertensive Drug Treatment. And please feel free to listen comfortably as you enjoy your meals. The contents of my presentations are as follows. And first is importance of 24-hour blood pressure monitoring and management. Blood pressure continuously changes both in the short term as like seconds and long term like as seasonal or years. In the very short term, blood pressure tends to be higher, and at that time acute mental stress cause stressful situations tends to be higher on the blood pressures. On a daily basis, blood pressure is generally higher during the daytime compared than at the nighttime. And over the long term, blood pressure tends to be higher in colder seasons and compared to warmer seasons. And the following is a 24-hour blood pressure record for a hypertensive patient. When we met a patient in our office, the patient had 140/90 millimeter mercury blood pressure. However, when measuring blood pressure over 24 hours, we observed instances where blood pressure was sometimes normal and sometimes go up to the exceed over 200 millimeter mercuries. And additionally, blood pressure dropped during sleep. We call that is nocturnal BP dipping, and rapid increase or morning BP surge upon waking time. This demonstrates that blood pressure fluctuates continuously throughout the day, so confirming hypertension based on office blood pressure alone can lead to misdiagnosis and mistreatment. The recent 2024 ESC guidelines place a strengthened emphasis on out-of-office blood pressure measurement. The recently updated guidelines mention that out-of-office BP measurement is recommended for diagnostic purposes. And if out-of-office BP monitoring is physically or financially unfeasible, and at that time repeated in-office BP measurement are recommended at a class 1B, and out-of-office BP monitoring is also recommended for ongoing management of hypertension management, not only for diagnosis. In the 2018 ESC guidelines, hypertension diagnosis was based on only office blood pressure measurement. But the recent 2024 ESC guidelines state that screening is based on office blood pressure, and the diagnosis of hypertension is then confirmed using out-of-office blood pressure. And specifically for patients with an office blood pressure of 140 to 140 between 160 and diastolic blood pressure 9 to 10 millimeter mercuries, it is recommended that confirm throughout out-of-office blood pressure monitoring should be needed. And if out-of-office BP is not feasible, repeated office blood pressure measurement should be conducted. And if the patient have more than 160/100 millimeter mercury, and at that time, preferably by either home or ambulatory BP measurement is recommended. So in the 2024 ESC guidelines, the blood pressure categories have been simplified into 3 categories, such as non-elevated blood pressure groups and elevated blood pressure groups and hypertension groups. This, as mentioned previously, the protocol for confirming hypertension diagnosis involves initial screening using office BP for screening, and after that, followed by out-of-office blood pressure measurement for patients with elevated BP or hypertension. So far, evaluation of the time course of blood pressure over a 24-hour period can be achieved only with the use of ABPM. This likely includes the mean blood pressure, which is thought to reflect the true blood pressure level, along with the diurnal blood pressure rhythms such as dipping status or morning surge. And it also provides information on BP variability and the effects of the drug effect. In healthy subjects, nighttime blood pressure decreases by 10 to 20% of daytime blood pressure, and we call that is a normal dipper pattern. And the dipping pattern is evaluated by the ratio of the daytime to nighttime blood pressure compared to the normal dipper. If nighttime blood pressure drops significantly by more than 20%, we call that group is extreme dippers. and nighttime blood pressure decreases abnormally low or even rises, it is categorized as non-dipper or reverse dipper, or sometimes we call they are risers. It is well known that nighttime blood pressure is the strongest predictor of cardiovascular outcomes compared to office, home, daytime, and 24-hour blood pressure. So the nighttime blood pressure is also important. And possible mechanisms of nocturnal hypertension include volume overload conditions and autonomic dysfunctions and other factors. In particularly, Asians, including Koreans, should be especially cautious of nighttime hypertension because they can take high salt intake and salt sensitivity increase circulating fluid volume. Also, Asians need to be particularly cautious about morning and nocturnal hypertensions because compared to other ethnic groups, Asians have a higher prevalence of morning and nighttime hypertension. Nighttime blood pressure is associated with cardiovascular events, especially heart failure, as well as age-related organ damages such as chronic kidney disease and cognitive dysfunction. And it is well known that unlike dippers, whose nighttime blood pressure normally drops by 10 to 20%, non-dippers and risers, mortality and cardiovascular risk and target organ damage, or we call that as hypertensive-mediated organ damage, increases in non-dipper and reverse dippers. In meta-analysis, nocturnal hypertension is associated with an increased cardiac and carotid structural alterations, such as left ventricular mass index increasing and carotid IMT thickening. And nocturnal hypertension patients have a higher risk of cardiovascular event compared to those with hypertension only during daytime, because it is generally difficult to diagnose. Treatment is often not provided. And in diabetic patients without heart failure, an abnormal non-dipping pattern increases the risk of LV diastolic dysfunction. In those with PAP patients, nocturnal hypertension is independently linked to heart failure rehospitalizations. In CKD patients, those with nighttime MUCH had a 2.5 times higher risk of LV hypertrophy and a 4.3 times higher risk of a composite kidney event compared to controlled hypertension. So all the subgroups, including diabetes and or chronic kidney disease, the nighttime blood pressure is so important. But in a study comparing patient preference for a 24-hour ambulatory blood pressure monitoring and 7-day home blood pressure monitoring, in patients' general opinion and easy to perform or comfortable to perform or restriction of daily and weekly schedules, ABPM is inferior to home blood pressure monitoring in terms of overall acceptance and preference by hypertensive patient. So ABPM can interfere with ABPM can interfere with sleep and may cause pain, skin irritation, and sometimes bruising. And due to the inconvenience of ABPM, its utilization rate in Korea is extremely low. About 1% of patients receiving medical care for hypertension underwent 24-hour ABPM. Additionally, ABPM testing is usually conducted only at higher level institutions such as tertiary hospitals, not primary clinicians. So this is the second chapter. As I mentioned in the previous chapter, accurate measurement of blood pressure is essential for the diagnosis and treatment and prognostication of individuals with high blood pressure, even in nighttime. So now I will introduce the CART-BP, a new ring-type device for continuous blood pressure measurement. CART-BP Pro is a continuous, comfortable, convenient, and accurate cuffless blood pressure monitoring device, and it makes no sleep disturbance, no risk of bruise or cuff wearing area, and even when you're wearing a CART-BP shower is okay. The CART-BP Pro uses a PPG technique, photoplethysmography. Method, allowing blood pressure measurement without the need for a cuff. And PPG is a technique that measures blood volume changes using a sensor to detect light absorption in the tissues. And CART-BP Pro has demonstrated the high accuracy in BP measurement, meeting international validation standards against various cuff-based measurement methods. The first study was a performance test of the CART-BP Pro's deep learning algorithm model based on invasive arterial blood pressure data during the surgery. And the second study was a clinical trial comparing it with a conventional cuff-type oscillatory blood pressure monitor. And the third study compared the CART BP Pro with traditional cuff type ambulatory BP pressure monitoring. I will now discuss the third comparison in more detail. This study was published earlier this year in the Korean Circulation Journal. An ESH working group on blood pressure monitoring and cardiovascular variability recommendations for validation of cuffless blood pressure measuring devices. There are total 6 test items: static test, device position test, treatment test, and awake or sleep test, exercise test, and recalibration test. In the CART BP Pro study, the primary test selected was the awake or sleep test. The passing criteria for this test required that both systolic and diastolic blood pressure variations between daytime and nighttime remain with an average of 5 mm mercury and with a standard deviation under 8 mm mercury. And additionally, the correlation coefficient for blood pressure changes between day and nighttime must be 0.7 or higher. This study is to evaluate the applicability and precision of a CART BP Pro compared to conventional 24-hour ABPM. A method is each participant wore both CART BP Pro and ABPM device on the same arm for approximately 24 hours. Then BP estimation from CART BP were compared with the corresponding ABPM measurement. And the result is that CART BP Pro met the validation criteria. First thing, mean blood pressure less than 5 mm mercury and standard deviation less than 8 mm mercury is met the validation criteria. And second validation criteria, correlation coefficient more than 0.7. So the test is validation met the validation criteria for the ESH recommendations. And comparing average 24-hour daytime and nighttime blood pressure differences between the CART BP Pro and ABPM, a high level of agreement was observed. So the CART BP Pro can offer us a promising option for continuous BP monitoring in clinical practice from morning to night. And this will be my last chapter of presentation, from morning to night, perfect 24-hour blood pressure control. The purpose of hypertension treatment is to prevent cardiovascular disease caused by increased blood pressure, and to reduce mortality. To achieve this, it is necessary to manage 24-hour blood pressure and also regulate circadian rhythms, including dipping and morning surge, and minimize blood pressure variability. In the SPRINT study, intensive blood pressure treatment compared to the standard blood pressure treatment, we already know about that, so resulting in lower rates of both fatal and non-fatal major CV event and death from any cause. And in the sub-study of a SPRINT ABPM study, intensive clinical-based BP treatment rules nighttime, daytime, and 24-hour SBP compared to standard clinic-based blood pressure treatment. And the STEP study, the STEP evaluates the cardiovascular benefit of intensive blood pressure treatment in elderly hypertensive patient, especially in China patient. And at the study, more than 60% of the subjects received antihypertensive treatment based on olmesartan. And in older patients with hypertension, intensive treatment with olmesartan resulted in a 26% significant reduction in the incidence of cardiovascular event compared to standard treatment. And this study, incidence of the dizziness, syncope, fracture, and the renal outcomes did not differ significantly, only differs in hypotension, and not the incidence of angioedema or headache, cough, and urticaria. In meta-analysis, olmesartan showed higher level of blood pressure reductions. These yellow bars are olmesartan over 24 hours compared to other ARBs. And olmesartan also maintained greater reductions in blood pressure over 24 hours compared to losartan and valsartan. And this intensive blood pressure control with olmesartan is due to being a potent, long-acting ARB with a high AT1 receptor affinity. And when multiple studies on olmesartan were analyzed collectively, olmesartan was found to control 24-hour blood pressure more effectively when combined in dual or triple therapy with calcium channel blockers or diuretics. And olmesartan restored and shifted the circadian blood pressure rhythm for a non-deeper to a deeper pattern. Maybe there was a significant increase in sodium diuresis during the day, and this inhibition of tubular sodium reabsorptions may be a key mechanism by which olmesartan normalized circadian blood pressure rhythms. And both clinic and morning home BP improved with olmesartan-based treatment, demonstrating a sustained 24-hour blood pressure lowering effect of olmesartan that extends into the morning. So this is my final slide. Ambulatory blood pressure monitoring provides comprehensive information about blood pressure, making it more useful than office blood pressure measurement. And CART BP Pro is a wearable device, which is cuffless continuously BP monitoring device, can help us measure 24-hour BP conveniently. And perfect 24-hour blood pressure control minimizes the hypertensive mediated organ damage and risk of cardiovascular disease events. So we should measure blood pressure during 24-hour and manage it. And olmesartan long-acting and potent ARB is a good treatment option for perfect 24-hour blood pressure management. Thank you for your attention.
Thank you, Professor Chun. Really very big impression to you, especially the 24-hour the ring-tight blood pressure measuring device. And all over the world, there are so many devices for the PPG-based blood pressure measurement device, digital. But this Korean CART BP Pro has some many clinical data for validation of the BP blood pressure measurement. And 2 months ago, this device is approved of the insurance for system for replacement and 24-hour ambulatory blood pressure. And the hypertension is widely accepted. Early and intense treatment is very good for the prevention of the CV event. But as you know, the old guidelines says the out-of-office blood pressure measurement is very important. But we have not good tool for the measuring the blood pressure in dynamic status. So I think that there is a new option for the blood pressure control in your patient and the Korean Society all over the world. So I think that this is very interesting session for you. And thank you for all audience and the brilliant two speakers. This time is 5 minutes left, but as you see, you can and go around so many booths for the today's schedule. Thank you. We close this session.
Love My Soul. 서울에 오면 사랑에 푹 빠지게 될 거야.
In the heart of the city where
So lovely,
love paints the street and inspirations.
so romantic,
Excitement's in the air, it's a playground of delight. Soulful cities call.
so fantastic. 발길 닿는 곳마다 사랑이 가득하니까. 여기 서울에서 너만의 소울을 느껴봐. Feel so good. 서울 My Soul. Love my soul. 서울에 오면 사랑에 푹 빠지게 될 거야.
In the heart of a city where
So lovely,
love paints the street and inspirations are
so romantic,
excitement in the air. It's a playground of delight. Soulful cities call.
so fantastic. 발길 닿는 곳마다 사랑이 가득하니까. 여기 서울에서 너만의 소울을 느껴봐. Feel so good. 서울 my soul.
Hello everyone. It's time to start our EP session. I'm the chair of the working group on epidemiology, Hyun-Chang Kim from Yonsei University. My co-chair is Eugene Yang from Seattle, USA. First of all, I have to say that congratulations on 30 years of Korean Society of Hypertension. The Korean Society of Hypertension actually from the beginning cares about the prevention and epidemiology of hypertension. And working group on epidemiology started 14 years ago as an official working group. So every year the epidemiology working group produces a Korean hypertension fact sheet and epidemiology session at the hypertension meeting. Today's topic is the observational data myth, guideline gaps and controversy. And I'll introduce two speakers from Korea, and my co-chair Eugene Yang will introduce two speakers from USA. Our first speaker is Ho-Gyu Lee from Yonsei University. Ho-Gyu Lee studied biochemistry in UC Berkeley, and he graduated Yonsei University College of Medicine. He was trained as a internal medicine specialist in Severance Hospital, then got a PhD degree in preventive medicine, and currently he is associate professor of preventive medicine, Yonsei University College of Medicine. And he's talking about the Korean hypertension fact sheet 2024 and young adult hypertension. Please.
Thank you, Chair, for the kind introduction. We have a really interesting session today, and I'm really pleased to open up this session by introducing our annual report called the Korea Hypertension Fact Sheet. Thank you. I think we distributed one of these when you registered for the conference. So we've been doing this for quite some years. It's our 7th year reporting this fact sheet, and every year we present some important descriptive statistics regarding hypertension prevalence and management in Korea. And each year we have a designated chapter with a special topic of interest each year. For example, in year 2020, we focused on young adult hypertension. And after 4 years now, we decided to do it again because it's an important topic and we wanted to see what changed over the past 4 years. So these are the chapters. Unfortunately, I don't have time to go over all the chapters, but I will mainly focus on the ones that are relevant to young adult hypertension. So first, this is a general summary of our fact sheet. You can see that there are 13 million Korean adults have hypertension in Korea. That translates to a crude prevalence of 30.1%. And among them, 11.5 million are diagnosed, 10.9 million are treated, and 8.1 million are adherent to treatment. So these figures translate to 77.2% awareness, 74.1% treatment, and 58.6% control rate. Before I proceed, I just want to remind you how extraordinarily remarkable these numbers are compared to the rest of the world. This is data from NCD risk. This is hypertension management rates over the world in men and women. You can see that there's a 49% diagnosis rate, 18% control for men, and for women, 59, 47, and 23. So you can see that the numbers in Korea really dwarfs the figures in the rest of the world. And we achieved this in quite a short period of time with very rapid increase in the level of management. So this is a trend, the number of people with hypertension by management status. The red is undiagnosed, and the green is controlled. So for in the middle age and the older, generally the number of people with hypertension rapidly increase, but the portion of treated and controlled hypertension increase relatively, whereas the portion of undiagnosed or untreated are decreasing. So is this true for all age groups? Well, apparently not, because for young adults, for 20 to 39 years of age, the absolute number of people with hypertension is not as high as the other age group counterparts. But the portion of undiagnosed hypertension is high, and it continues to be that way. So this is a summary of young adult hypertension statistics. Let's start from hypertension. Okay. So there are slightly less than 1 million people with hypertension in age 20 to 39, and this is less than 1/10 of the entire people with hypertension over all ages. So this is a small number, but then if you see the bar below, most of them are not persistently treated for hypertension, and a significant portion of them actually do not see doctors for hypertension. So really, this little shaded area, this is the portion of young adult hypertension that are actually adequately and persistently treated. And not only this, I think this is an interesting part. So we have so few number of people with hypertension in young adults, but then there are actually more than double of that with pre-hypertension, and equally as many with people with elevated blood pressure with a similar criteria with the AHA guideline. And the pre-hypertension in KSH guideline is equivalent to a stage 1 hypertension in the ACC-AHA guideline. So I think we can see it this way. Most of the elevated blood pressure in 20 to 39, I think they will progress into pre-hypertension in the next decade. And probably those with pre-hypertension will progress into overt hypertension in the next decade. You can see that actually the similar numbers are matching in these periods. So, the number of overt hypertension is not as many as the rest of the age groups, but people with pre-hypertension elevated blood pressure that will eventually progress into overt hypertension is actually large and is probably increasing. And the awareness of these young adults is low compared to the other age groups. For instance, after middle age, the awareness rate has increased dramatically, and it's close to 75 and even above 80% in the older ages, whereas in the young adults, the numbers are below 30 or 20%. And this is a similar way of looking at it, just in a different axes. So this green line is for age 20 to 39 with the trend of awareness rate. But I think it's interesting to see that this was the time when we presented our 2020 fact sheet, and this is now 2024 fact sheet. I think we are seeing some improvement over this period. So I want to think of it as I want to hope that we are doing a pretty good job setting the awareness in the medical field and in the general public related to young adult hypertension, and we are actually seeing some improvement of awareness. I think similar, we are seeing improvement for treatment rate. It is still lower than the other age groups, but I think we are seeing some improvement, and also for control rate. I want to mention some special considerations in young adult hypertension. And first, I want to start with medication adherence. this is a trend of adherence rate among young adults, and it's 43% among treated hypertension, and it hasn't really been increasing much over the last 10 years. So I think we need more work in this particular area. And is this important? And we have a piece of data that the low adherence to antihypertensive medication in young adults is associated with a greater risk of premature cardiovascular events among young hypertension. This is an area that you can't really do on RCT. So I think this perfectly fits to our today's theme of observational data meets knowledge gaps. So what factors are associated with medication adherence? So apparently older age male sex are associated with better adherence and persistence, and low SES and worse lifestyles are the other way around. And interestingly, we see that initial combination therapy is associated with good adherence and good persistence. And among those started with combination therapy, using a single pill combination is associated with better adherence and persistence. So are we doing it that way in young adult hypertension? We can see that in our fact sheet data. So overall, the rates of using more than dual therapy, of a combination therapy is around 60% in the overall age. And among 20 to 39, the rate is slightly lower, but still about 50% of young males are using combination therapy. I think it's lower among females, and maybe because these age groups are more easily controlled without using combination therapy, or maybe they're undertreated. Well, the data, and I think we have to give a careful interpretation. And usually RAS blockers and calcium channel blockers are associated with better adherence than the other two classes. And in general, we are using more RAS blockers and calcium channel blockers than diuretics or beta blockers. The trend is slightly different for young female, probably because in their childbearing age, their choice of medication will be affected by their childbirth plans. Well, next is diastolic hypertension. So this is the distribution of systolic and diastolic blood pressure in scatter plots. So there is a general correlation between the two, but then some people have relatively higher systolic and some people have relatively higher diastolic blood pressure. It turns out that among young adults, the distribution is shifted toward higher diastolic blood pressure, whereas for older individuals, towards higher systolic blood pressure. So it turns out that among people treated for hypertension, this is the average blood pressure among people with hypertension. And among young adults, the average diastolic blood pressure among all young adults with hypertension is 88, so close to 90. So it's way high. It's much higher than what we consider a generally acceptable cutoff for a diastolic blood pressure. And this is much higher than the rest of the age groups. And this is not the case for systolic, but this is for diastolic. So we can see that there is a general trend of having high diastolic blood pressure among young adults, and this might be less recognized and less aware among young adults with hypertension. So is this important? We have another piece of data that among young adults, having only elevated diastolic blood pressure at the level of stage 1, according to ACC guideline, and both stage 2, is associated with higher risk of premature cardiovascular events in these individuals. So having only elevated diastolic blood pressure apparently is a high-risk feature. And among those with low SBP, according to diastolic blood pressure, higher DBP was associated with higher risk of premature cardiovascular disease, and especially among young adults with age 20 to 39. So there has been quite a debate whether isolated diastolic hypertension is actually a risk or not. So we also participated in this little pro-con paper. And the general issues were whether age is important, so whether IDH is only important among young adults, and whether treatment status makes a difference, and also issues with DBP measurement accuracy, especially with mercury the measurement, and generally these observational data have less sample size, so that could affect the significance of results. And most importantly, people against the idea of IDH being risk tend to argue that IDH is only a risk when it progresses into a systolic hypertension. So we wanted to see that, and it's actually hard to see because there are years, tens of years between IDH and hard CVD events, and most likely they will progress into systolic hypertension. So it's hard to determine whether diastolic BP it per se is associated with the risk. So this is a challenging question, but I think we can make it simple. So if people with IDH already have subclinical CVD, which is a precursor of hard CVD events, then we can argue that the diastolic BP is a risk as an early prognostic marker of CVD. So actually, these questions were answered by our graduate students in their master's thesis. So we did so we took younger age people and then looked at thickened IMT, and sorry, my monitor just went off. So we looked at thickened IMT and the microalbuminuria as a hypertension-mediated organ damage. And we saw that isolated diastolic hypertension was associated with both of these subclinical diseases, the presence of these subclinical diseases. So people with high diastolic blood pressure, young people, were at higher risk of already having these subclinical events. The last consideration is primordial prevention. So risk factors tend to cluster, so people with hypertension also have a lot of other risk factors. So they have overweight, high cholesterol, glucose, and usually have poor lifestyle. So people with hypertension are more likely to have greater number of risk factors. Their distribution is generally shifted toward a greater number of risk factors. So this is pretty much the idea of ideal cardiovascular health. So we want primordial prevention. We want to prevent risk factors being clustered. We want to prevent risk factors occurring before the risk factors occur. So that's the idea. That's the concept of ideal cardiovascular health. And achieving ideal cardiovascular health among young people were associated with much lower risk of incident premature cardiovascular events, and even people who started with poor CVH, if they recovered, then that was associated with protection against the risk of premature events. And this was not a study solely on hypertension per se, but in both non-hypertension and hypertension subgroup, the results were equivalent. So this points to the fact that the primordial prevention of risk factors is important in young people with hypertension. So let me summarize these findings. So First, I mentioned that we have the highest control rate in Korea compared to the rest of the world, but we have low awareness and less treatment among young adults. But we are seeing recent improvements, and the control rate is high among young adults, among young hypertension, if persistently treated. And that low medication adherence persistence is an issue among young hypertension, and this confers a high cardiovascular risk. And diastolic form of hypertension is also a common form of young adult hypertension, and this is also a high-risk feature. And last I mentioned that primordial prevention of risk factors occurring, primordial prevention of risk factor clustering is important, particularly among young adults with hypertension. Thank you for your attention.
Thank you so much.
It was a great presentation, Hogyu. So I'd like to introduce our next speaker from the United States, Dr. Daiichi Shimbo. He's the director of the Columbia Hypertension Center and Laboratory. He's a professor of medicine, and he holds many international roles with the American Heart Association and other hypertension societies. So he is going to talk today about office blood pressure thresholds for screening masked hypertension.
Okay, good afternoon. Thank you for the invitation. I'm going to talk about something that's dear to my heart, mass hypertension. Here's my disclosures. I report funding from the National Institutes of Health. I have no other financial conflicts of interest. So I'm speaking to a hypertension audience. So you are all aware that obviously we can measure blood pressure in the office, but we also have out-of-office blood pressure monitoring. And in my mind, it is a measure of true or ecologic blood pressure. It's the blood pressure that you measure in the real world. And we have two types that have been well validated by multiple studies. One is ambulatory blood pressure monitoring, which I'm going to call ABPM, and home blood pressure monitoring, which I'm going to call HBPM. It's important to recognize that the gold standard from most guidelines say that ABPM is actually the reference standard for out-of-office monitoring. And I don't have time to go into why, but it's mainly because there's just more evidence supporting ABPM over home. Because we have two kinds of blood pressure measurement, one in the office and then one out of the office, we can now classify people into four phenotypes. If you have high office blood pressure, let me see if you can see my, oh, yep. And you have high out-of-office blood pressure, you have something called sustained hypertension. And if it's not high on either modality, you can see it's called sustained normotension. It turns out these represent the highest and lowest CVD risk for these two phenotypes. I think this group knows about white coat hypertension, that's high out-of-office blood, high office blood pressure, but the out-of-office blood pressure is not high. But today's talk is the opposite phenotype. It's office blood pressure that's not high, but your out-of-office blood pressure is high. And the reason why it's called mass hypertension, because if you're in the clinic measuring blood pressure and you don't do out-of-office monitoring, it's going to be masked. You won't be able to diagnose it. And it's important to recognize that these phenotypes are among people who don't take BP medications. So this is for initial diagnosis. The data are very clear that compared to sustained normotension, mass hypertension is associated with an increased risk of cardiovascular disease events. I looked very carefully at multiple meta-analysis in the literature. This is one I'd like to quote by Zhang et al. Reported that the adjusted risk ratio with a 95th confidence interval for cardiovascular disease events associated with mass hypertension versus sustained normotension is 1.70. You can see the confidence intervals there. It's important to recognize that most of the literature uses the thresholds that I'm highlighting in red, where office blood pressure threshold is 140/90, which corresponds to what I show here are the thresholds on ambulatory and home. I only mention this because you'll see later there is big controversy about the 2017 ACC-AHA guidelines, which focus on 130/80 and the corresponding thresholds from the out-of-office blood pressure monitoring. This slide is just meant to say it is high risk, and for most part, there's no way to diagnose it unless you do out-of-office monitoring. So here's the issue. At least in the United States, it's very difficult to do out-of-office monitoring. And like I just told you, ABPM is the reference standard. So it's really difficult to do ABPM in practically everybody who doesn't have high blood pressure in the office. Think about it. Are we really saying we should do out-of-office monitoring for everyone, regardless of the office blood pressure measurement? We estimated in a previous study that 153 million US adults would actually have to be screened with ambulatory monitoring or home monitoring to make the diagnosis of mass hypertension. I just think that's crazy. I just don't think that's feasible. So a lot of people have thought about a targeted approach. Should you only do ABPM or home for people with a specific criteria and just pursue those for screening? So way back when I was a junior faculty, we often speculated that mass hypertension may be an intermediary phenotype between sustained normal tension and sustained hypertension. And let me go through this. So many of you probably think that office blood pressure is higher than out-of-office blood pressure. We see that quoted all the time. It's called the white coat effect. You come to the office, you see a coat, white coat, the clinician's wearing, your office blood pressure goes up. But actually, we've shown that in healthy people who are younger, who don't have hypertension, are not on BP meds, the out-of-office blood pressure is actually typically higher than the office blood pressure. Okay? And so they have sustained normotension, but the out-of-office is higher than the office. And so what happens is, and we've shown this, is as you age, both go up, but the out-of-office blood pressure hits the threshold for hypertension first. And the office blood pressure is not hypertensive yet, it's in the borderline range. And then as you get older and you have more comorbidities, both start to increase, and then both office and out-of-office are actually above the threshold. So you see there is a conceptual model between mass hypertension between an intermediary phenotype, and you would speculate that having blood pressure in the borderline hypertensive range in the office would predict mass hypertension. In fact, that was our hypothesis. At this time, because we're using a threshold of 140/90, we speculated there would be a large diagnostic overlap with what used to be called pre-hypertension and mass hypertension. And in fact, we found that in one of our studies. This is a study in one of our program projects, 770 individuals untreated with a clinic blood pressure less than 140/90. You can see the percentage, the number and percentage of people with pre-hypertension, and you can see the number and percentage of people with mass hypertension. Do you see the mass hypertension circle almost completely fits into the pre-hypertensive circle? This is shown another way. You can see that the prevalence of mass hypertension is just much higher among people with pre-hypertension, and it's uncommon when you have a clinic blood pressure less than 120/80. In fact, the overall percentage is about 3.2% if your office blood pressure is less than 120/80. And you can see here that, in fact, the highest prevalence is what's called the upper prehypertensive range. Now, does everyone understand the implications here? Because if it's really just focused on prehypertension, maybe that's the group you should target for out-of-office monitoring, and you should really don't do any sort of out-of-office monitoring if the clinic blood pressure is less than 120/80. In fact, we tested the diagnostic accuracy of this approach basically using two of our studies called the Mass Hypertension Study and the IDH study, and a third that wasn't ours called the Jackson Heart Study, and we modeled it onto NHANES data, 2009 to 2012. And you can see here that if you just focus on prehypertension, do you remember that 130-something million people you would have to screen? It's only 59 million people you would have to screen if you just use prehypertension as a screening criteria for ABPM. And if you use the upper range, it's even smaller. You would only have to screen 20 million people with out-of-office monitoring. We did look at the sensitivity and specificity. I'm highlighting here. When you use prehypertension, the sensitivity is about 83%, and the specificity is about 62%. Now, when you do a screening test, it's actually really important that the sensitivity be high because you're trying to minimize the false positive rate, okay? Or the false negative rate. And so think about it. If you're doing a screening test and it ends up being negative, don't you want to feel comfortable that you actually don't have the disease and you don't need to pursue further diagnostic testing? So in fact, the sensitivity is high. This data basically supports the use of prehypertension as a screening criteria. Now the specificity actually was low, so there is a high false positive rate, but we don't really care about that because you're going to end up doing ABPM anyway, just to make sure. Now the upper range of prehypertension, even though you're screening less people, do you see that the sensitivity is actually quite lousy? The specificity is high. So in fact, that's not a great approach, even though you're more often right than not if you end up having the upper range of prehypertension and have a likelihood of having mass hypertension. You have to be careful because the sensitivity is not great. And then if you end up not having it, you could still have mass hypertension. So this data strongly supports the hypothesis that mass hypertension is an intermediary phenotype between sustained normotension and sustained hypertension, and that may be a criteria for using screening. Another thing, and I think my previous speaker said, as you become hypertensive, you have a bunch of other cardiovascular risk factors. And we began to notice that people with mass hypertension are older, male, have higher cholesterol, and so forth. So we also thought about maybe you could use the pooled risk equation to actually predict who has mass hypertension because those are the ones who are most likely to have it because they have hypertension, essentially. And so we tested this in the Jackson Heart study. We used different definitions of mass hypertension based on daytime, nighttime, 24-hour, and then any form of mass hypertension from daytime, nighttime, or 24-hour, and you can see the definitions here. And you can see at the top, from left to right, is the pooled risk equation categories going from lowest risk to highest risk. Does everyone see that the prevalence of mass hypertension starts to increase quite significantly regardless of how you're defining mass hypertension? And if you look at the unadjusted and adjusted prevalence ratios, you can see, indeed, as you're more higher risk, you're more likely to have mass hypertension. And so one wonders, if you just pop in the pooled risk equation and someone is high risk, I wonder if that's a group that you should focus out-of-office monitoring on. Not the entire group of people less than 140 over 90, but just the group who is high risk based on the pooled risk equation. Unfortunately, it didn't do such a great job. We actually looked at the C statistic comparing the ACVD risk score compared to just using systolic and diastolic blood pressure in the clinic. And you can see here, the ones that are bolded are actually statistically significant difference between these two statistics. In fact, there was no difference in mass hypertension, no difference in mass daytime, no difference in mass nighttime, basically saying that this is not a superior way to predict mass hypertension, despite the fact the prevalence is higher. And in fact, if you looked at mass 24-hour hypertension, you see it actually did worse, statistically significant lower C statistic for using the pooled risk equation versus just using clinic systolic and diastolic blood pressure. Very disappointing. And in fact, it makes sense because if you actually look carefully at these risk predictors, do you know what the most powerful predictor of out-of-office blood pressure is? It's actually office blood pressure, despite the fact that they might have other risk factors. So this certainly doesn't surprise me. Another approach is the colleagues in the UK came up with this something called the proof BP formula. Now, along the left is what guidelines in the US, United States Preventive Services Task Force, and the NICE UK guidelines recommend. Basically, it's the ABPM approach. You should just screen with clinic blood pressure if it's high, repeat the clinic blood pressure, and if it's high again, you should send something for ambulatory monitoring. That's what United States Preventive Services Task Force says and the UK NICE guidelines. And in fact, if it's normal clinic blood pressure, you should just rescreen again in 5 years. And you're only doing it, the trigger for doing ABPM, if office blood pressure is high. Does everyone recognize that if you do that, you're going to miss mass hypertension? Because you're not doing ABPM for those with normal office blood pressure. Along the right is a different approach. They said, why don't we use a risk calculator to predict what the out-of-office blood pressure would be if you didn't do ambulatory monitoring. And they had a data set of ABPM, and they had a data set of clinic, and they did their risk calculator. And they basically said, using these factors along the right, let's come up with a new calculated clinic blood pressure, and if it's above 145/90, then you should actually assume they have hypertension, mass hypertension. And if it's low, you should actually assume they don't have ambulatory hypertension. And anyone in between, you should just send for ambulatory monitoring and make the decision there if it's high or low. Now, as it turns out, for diagnosis, this approach is actually excellent. Look at the sensitivity, specificity, positive and negative predictive values, all excellent. And if you just focus on mass hypertension, the false negative rate is only 3%. So in fact, it is a good way to actually use a predicted risk equation, but using higher or lower thresholds based on what you anticipate the out-of-office monitoring would be. So here's what's interesting. The 2017 ACC guidelines did take the pre-hypertension approach, which I just told you about. So they actually recommend doing ABPM or HONE for people who are actually in the borderline office blood pressure range. So because we focus on 130/80, does everyone recognize now there's no longer pre-hypertension? So what they ended up doing is saying, oh, let's make a leap of faith. You should do out-of-office monitoring if your blood pressure is in the range in the yellow. And in fact, CMS uptook these recommendations. It's a reimbursable indication to screen for mass hypertension and do ABPM for blood pressures in this range in the office. And we estimated it would actually only allow 41 million people to be screened. Oh, sorry. So as it turns out, do you know there's actually no data, even though it's a 2A indication, there's actually no data to support this. So I presented data at Lifestyle Epi in Chicago, and we actually tested this and looked at the diagnostic approach. We took people in a study called the ID8 study. These are people who are drug-free, not taking BP meds. And it's 408 individuals who are adults. You can see what the exclusion criteria are. We did multiple kinds of office blood pressure measurement. Everyone got manual. Everyone got an oscillometric method using the BP True device and also using the Omron device. The order was randomized. And for these analysis, we used the Omron data from the first 2 visits, which, by the way, the 2017 ACC guidelines recommend doing office blood pressure measurement over 2 visits. And we did ABPM twice. We're using the first ABPM to make the diagnosis of mass hypertension. We restricted the analysis to people with complete office blood pressure data and complete ABPM recordings, and those who actually have an office blood pressure less than 130/80, which left us a sample size of 263 participants. And we used the 2017 ACC criteria for having high out-of-office blood pressure based on the awake blood pressure and 24-hour blood pressure shown here. And you do realize, since everyone in this study has a blood pressure less than 130/80 in the office, do you realize that if you have high out-of-office blood pressure, by definition, you have mass hypertension? We looked at sensitivity, specificity, positive and negative predictive values, and a positive test is did you fall in this range that the guidelines recommending, and if you fell below the range, it's a negative test. We used likelihood ratios to actually see, did it do a good job or not? If you're not familiar with these, let's say your prevalence of your population of a disease is 30%. Let's say you're testing a population that has a 30% prevalence of mass hypertension. A likelihood ratio of a positive test, it's really good if it's above 10. So it's saying that if you have a 30% prevalence and you use 10, then it increases your chances to well above 80%. So a strong test suggests it's greater than 10 for likelihood ratio positive, and the likelihood ratio negative, it's very good if it's less than 0.01 because it lowers the chances of having mass hypertension if it's a negative test. I don't have time to go through this. Basically, younger cohort, young adults, enriched with Hispanics and non-Hispanic blacks. And you can see the prevalences of mass hypertension along the bottom was 26% using awake and 29% using 24-hour blood pressure. You can see that 38% actually fell in this borderline hypertensive range. Now that's important because that means you don't have to screen everyone with ABPM. Just 38% of the population need ABPM. The problem is it did very lousy. The sensitivity and specificity were just okay. The positive and negative predictive values were okay. The negative predictive value was actually pretty high, but do you see the false positive and false negative rates? And then if you use the criteria for likelihood ratio for a positive negative test, you see that it's actually quite weak, meaning that it's a terrible way to screen for mass hypertension. And this is based on awake blood pressure. The same data I'm showing actually for 24-hour blood pressure. Basically, this borderline hypertensive range is just not a good way to screen for mass hypertension. And in fact, we ended up studying this as well. Remember that proof BP formula? We came up with a proof BP US formula. And we used different data sets to come up with an estimated out-of-office blood pressure. And we did focus on people in this range. You can see here that if you just use 2017 ACC guidelines, you're sending about 35% to get ABPM, which mimics the data I just showed you. But if you use Proof BP or Proof BP US, do you see you're actually sending more people for out-of-office monitoring? What's interestingly enough is this study did not actually look at the diagnostic accuracy. So I actually don't know if Proof BP is a good way to make the diagnosis of mass hypertension if you're using the 130/80 threshold recommended in the guidelines. So last slide. When using ABPM thresholds corresponding to an office blood pressure threshold of 140/90, perhaps prehypertension status or the Proof BP algorithm may be good to screen for mass hypertension. However, if you're going to use the 2017 ACC/AT guidelines of 130/80 thresholds, I have no idea what the best approach is. It's really unclear. And certainly, I'm not sure that it's a 2A recommendation because it's not really backed by a lot of evidence. And to finally, data for HBPM to detect mass hypertension. A lot of the data I just showed as ABPM is really actually unknown. So thank you very much.
Thank you, Professor Shimbo, for that excellent talk.
Thank you, Dr. Daich-Shimbo, and I'll introduce our third speaker, Choro Park from Yonsei University. Dr. Park had a medical degree and a PhD degree from Yonsei University. He was trained as an internal medicine doctor and a fellow training in the department of nephrology, and he won multiple research awards from the Korean Society of Nephrology. And today he's talking about optimal blood pressure for people with CKD. Dr. Park, please.
Okay. Thank you, Chairperson, for the nice introduction. And good afternoon, everyone. My name is Choro Park from Yonsei University. I'm truly honored to be here and present this important topic today. My talk today is about BP control in patients with CKD. This is a never-ending story without clear conclusion. This issue becomes more complex when we narrow down to advanced CKD patients, particularly when their eGFR falls below 45, since these patients have been usually excluded from RCTs examining the effect of BP control. Therefore, this talk would focus on the optimal BP for patients with advanced CKD. Here is what I'm going to touch during my talk. Firstly, I will provide a brief overview of the current guidelines in patients with CKD. Then, I will bring this issue into focus for patients with advanced CKD based on the currently available literature. As I mentioned just before, I'll start with a brief overview of the current guidelines on the BP target in patients with CKD. Let me start by providing a simple example. This patient was 55 years old male with hypertension and diabetes. His BP, eGFR, and urine albumin excretion and current medication are as shown. The question is, would the lower target of BP improve the patient's outcome? This is a quite critical issue because we, nephrologists, encounter this type of patients every day in our clinical practice. Then, what is the lower of the optimal BP in CKD patients? As you know, the optimal BP level should achieve these goals. First of all, mortality and CV outcomes are expected to improve by reducing high BP. On the top of that, especially in patients with CKD, the goal of BP control is to retard the progression of CKD, which encompasses the attenuation of kidney function decline and the delay of the onset of ESKD. However, the BP target has not yet been conclusively determined. This slide shows BP goals suggested by various guidelines across the world. Some advocate for a target less than 130, while others propose less than 140. Notably, North American countries have recommended a target less than 120. There is a discrepancy on this matter between American and European guidelines. For BP target in CKD, ESA set the lower safety boundary at 120, while ACC, AHA recommends a single SBP target of less than 130. Additionally, the European guidelines still advocate for a primary BP goal less than 140 and 90 in all CKD patients, with a lower target less than 130 in patients with albuminuria and those at high risk of CVD. Nevertheless, they caution against lowering BP less than 120 and 70. The updated European guidelines remind us of the KDIGO 2012, the previous guideline from KDIGO, which similarly established separate BP targets depending on albuminuria severity. Despite these controversies, the latest 2021 KDIGO guidelines embraced the lower target SBP less than 120. However, the KDIGO panels acknowledge that this target is not primarily for kidney protection, but is largely based on splint trial given cardiovascular and mortality benefits conferred by the lower BP target. Additionally, it should be noted that the 2021 KDIGO BP guideline emphasizes the use of standardized office BP measurement rather than routine office BP measurement. More recently, ASPIRT trial showed that lowering SBP less than 120 resulted in lower rates of composite cardiovascular outcome compared to lowering SBP less than 140. These results of ASPIRT trial also advocate the SBP target suggested by 2021 KDIGO, although the proportion of CKD patients in this study was relatively small. However, the optimal BP target in patients with advanced CKD, whose eGFR less than 45 or 30, seems more complicated. In addition, the KDIGO panels also stated that there is less certainty that the benefit outweigh the harm with the following scenarios, that the CKD grade 4 and grade 5. These uncertainties is mainly attributed to the paucity of well-designed randomized controlled trials, exclusively examining the effect of BP control for clinical outcomes in patients with CKD. The splint trial, the patient with CKD in the splint trial shows the mean eGFR of 48. In the ASPIRT trial, whose eGFR less than 60 was about 6%. So, even though the several RCTs, such as splint and ASPIRT trial, include patients with CKD, patients with severely impaired kidney function usually excluded from those studies. Furthermore, evidence for the optimal BP target to prevent kidney function decline scarce because RCTs examining the effect of BP control prioritized cardiovascular events as the primary outcome, while adverse kidney outcomes were evaluated as the secondary outcome. So, to summarize the first part, the current guidelines do not achieve consensus of the optimal BP target in patients with CKD. The ACC AHA favors a lower target compared with the ESC ESH. KDIGO has endorsed the ACC AHA recommendation based on cardioprotective effects associated with the lower target as evidenced by the SPLINT study. Intensive BP control may be acceptable in CKD grade 1 through grade 3A, mainly driven by cardioprotective effect and survival benefit. However, there is lack of evidence supporting the lower BP target in advanced CKD, especially CKD grade 3B to grade 5, whose eGFR less than 45. So next, let's move to the second issue. The optimal BP for patients with CKD, especially with moderately to severely reduced kidney function. I'll start with the literature covering the optimal BP target to reduce cardiovascular events and mortality in these patients. In a collective analysis including 4 RCTs, including MDRD, ASK, ACCORD, and SPLINT study, there were trends toward a marginal reduction in mortality and CV outcomes in intensive BP control group versus standard BP control group. This association became statistically significant, particularly when excluding patients with eGFR greater than 60. Although the number of patients classified as CKD grade 4 was relatively small, the improved outcome associated with intensive BP control was not influenced by kidney function. Regarding the mortality outcome, one meta-analysis study involving 18 trials in patients with CKD stage 3 to 5 showed that intensive BP control was associated with a 14% lower risk of all-cause deaths compared with the less intensive group. However, please note that the achieved SBP in the intensive arm was 132, not 120. In the subgroup analysis, these results were not modified in patients with eGFR less than 30. How were the results from observational studies? Now, let's start with the results from leisure and cardiovascular risk anomalies in CKD study. This study involved about 300,000 patients with incident CKD from US. The mean eGFR was 48, and the median follow-up duration was 7.6 years. This graph shows the association between SBP and the risk of all-cause mortality. There was a U-shaped association between SBP and all-cause deaths, and age modified the association of SBP with mortality. Compared with an SBP of 130 and 139, SBP greater than 140 was associated with higher mortality rates in all age groups, but with attenuation of these differences in older patients. On the other hand, SBP less than 120 was associated with higher mortality in all age groups. Interestingly, the results regarding the risk of incident coronary heart disease or ischemic stroke showed different patterns compared to all-cause mortality. There was a graded association between SBP and incident CHD or ischemic stroke in patients with CKD. This graph shows the association between SBP and incident CHD, and this graph shows the association between SBP and incident ischemic stroke. In another study involving about 2,000 patients from no CKD, a Korean cohort study for outcome in patients with CKD, there was a U-shaped association between SBP and the composite outcome of all-cause deaths or cardiovascular events. Specifically, this study showed that SBP between 110 and 119 was associated with a significantly lower risk of the composite of all-cause mortality or cardiovascular events. Recently, Our study group explored the association between BP levels and cardiovascular events or mortality in patients with CKD grade 3B to grade 5 using combined data from two representative CKD cohorts, the US CREEK study and no-CKD. This study included about 3,000 patients with CKD, and the median eGFR was 32. Patients were followed up a median duration of 4.6 years. We analyzed the association between SBP and a composite of myocardial infarction, stroke, hospitalization for heart failure or death using baseline and time-updated SBP. In this analysis, involving patients with eGFR less than 45 using combined cohort data, the higher SBP was associated with an increased risk of cardiovascular events and mortality. How about the optimal BP target for kidney outcome? Let's go back to all the studies regarding this issue. In 1994, MDRT studies showed that kidney protective effect of reducing BP to a target of mean arterial pressure 92, which is equivalent to 125 and 75, was very clear in CKD patients, particularly when they had proteinuria of more than 1 gram per day. This benefit was more evident in patients with eGFR between 25 and 55. In the long-term follow-up study of the original MDRT code, there was no heterogeneity between BP control and study course, indicating that lower BP target was beneficial even in patients with eGFR less than 25. Similarly, a long-term follow-up observation of the ASK trial also showed the significant benefits of intensive BP control on clinical kidney outcomes, particularly in patients with an overt proteinuria, which was not observed during the trial phase. How were the results from observational studies? CREEK investigators reported that prolonged exposure to SBP over 130 may portend increased risk for progressive loss of kidney function among persons with CKD using marginal structure model. In the study, the relationship between SBP and adverse kidney outcome was not affected by diabetes, proteinuria, or eGFR. How were the results from leisure and cardiovascular risk anomalies in CKD study? The results were similar to those from CREEK study, although age modified the association of SBP with incident ESKD as with mortality. A higher SBP linearly increased the risk of incident ESKD in the study. This association was also found in a study involving no CKD. The analysis with no CKD data confirmed previous findings of a significant association of higher BP levels with CKD progression. The stronger association with time-updated BP suggests that a single measured baseline BP is not a reliable predictor and underscores the importance of prolonged and sustained BP control. Our study group also explored the association between BP and CKD progression in patients with CKD grade 3B to 5 using the CREEK and no CKD code. This study included about 3,000 patients with CKD, and the median eGFR was 32. Patients were followed up a median duration of 4.7 years. Our study showed that a higher SBP was associated with an increased risk of CKD progression, defined as a composite of eGFR halving or the onset of ESKD in patients with CKD grade 3B to 5. The stronger association also observed with time-updated SBP, and this finding emphasizes the importance of consistently maintaining an optimal SBP over time. Furthermore, this association was not influenced by baseline kidney function. Now, let's return to the question that I raised in the introduction. Meta-analysis incorporating a lot of trials and all observational studies, including ours, such as the variable association of lower BP target with clinical outcomes in patients with advanced CKD. Then, the question should be changed to, can intensive BP control indeed improve the outcome in patients with advanced CKD? To address this knowledge gap, we have recently initiated the Excelsior CKD trial. This is a multi-center randomized controlled trial involving 13 centers in Korea, aiming to compare the effects of lower SBP target less than 120 versus 140 on CKD progression in patients with eGFR of between 15 and 45. We hope that the results of our new trial will be able to provide conclusive insights into this unresolved issue. This is the last slide of my talk. There is a lack of consensus on the optimal BP target in patients with CKD. However, the current literature suggests that intensive BP control appears to be beneficial in reducing cardiovascular events, mortality, and improving kidney outcomes in patients with CKD despite existing controversies. Nevertheless, the role of intensive BP control remains uncertain, as there has been no randomized controlled trials addressing this issue. Hopefully, our trial will be able to answer this unresolved issue. Thank you for your attention.
Thank you for the wonderful presentation.
Yes, so our next speaker is Dr. Stephen Jurashik from Beth Israel Deaconess Medical Center. Dr. Jurashik is an associate professor of medicine at Harvard Medical School, and he is also the associate director for ambulatory and community-based research at Beth Israel. He's going to talk about should there be lower limits for blood pressure targets in high-risk individuals. Dr. Jurashik.
Great. Thank you so much for the honor to be with you all today in the 30th anniversary of the Korean Society of Hypertension. So I'm going to be talking about this question: should there be lower limits for blood pressure target in high-risk individuals? I have nothing to disclose. So in order to frame this discussion, I thought we'd start just with a couple of things that I think are quite relevant in terms of answering this question. First, when we think about risk factor management with respect to cardiovascular disease, it's important that the risk factor be associated with cardiovascular disease and have some biologic plausibility, right? And this can be based on observational evidence. I think of the Bradford Hill criteria for causality in this respect. The second item I believe is really important is that there should be evidence that altering the risk factor can prevent cardiovascular disease, ideally in a clinical trial setting. The third important point is that we should know something about the risk relationship, right? Is this the relationship between the risk factors linear with cardiovascular disease? Is it U-shaped, so that lower range there's kind of an upswing in risk, or J-shaped, right, evidence of a plateau? And then what is normal? What is a normal range or goal for the risk factor in order to, for us to arrive at? Do we need to go lower and lower, or can we get to a point where would be naturally occurring healthy zone? The fourth item I think is really important to think about is measurement precision of the risk factor. And then the fifth item is the adverse events that can come from over-treating. If we have an area we're targeting, what if we go too far? What kind of side effects should we be worried about? And then lastly, costs, right? How many people should we be thinking about treating to prevent a single CVD event? So it goes without saying that cardiovascular disease is a leading cause of death throughout the world at this point. And with regards to prevention, there are two real thought leaders I'd like to highlight. One is Jeremiah Stamler, and the other is Jeffrey Rose. And so with Jeremiah Stamler, he talked a lot about primordial prevention, risk factor prevention. But up here on the left, you can see this two bell-shaped curves for blood pressure. And the idea of prevention is, right, if we can shift the curve to the left downward, even in small amounts, we can have significant reductions in stroke and CHD. And Dr. Stamler pointed out that in the context of hypertension, right, if we take the approach of constantly trying to catch up, respond to high blood pressure, while this is an important endeavor, it's late, defensive, mainly reactive, time-consuming, associated with adverse effects, and can only be partially successful and endless, right? And so it's always a catch-up kind of endeavor, and his statement is a really compelling argument for us to focus on prevention. And then Jeffrey Rose, in his really foundational work, Sick Individuals and Sick Populations, right, presented this kind of idea of serum cholesterol and the overlap between folks with non-CHD and CHD, right? And he made the statement that a large number of people at a small risk may give rise to more cases of disease than the small number who are at high risk, right? And so the basic idea here is that, yes, it might make sense to always focus on the high-risk group, but they are not going to account for the vast majority of cases. And so there is something to be said for this idea of treating the population, treating risk in the entire population to reduce burden of disease. And so when we think about high risk, I think these are a good set of factors to start with, right? We have on the left side the recent AHA Prevent score, and I know the working group here has a very nice and pertinent and related score for Korean populations. But these are a number of the factors that have been developed over time from Framingham and the pooled cohort equation and expanded that identify higher risk for cardiovascular disease. And I highlight age as a major driver of risk. And then in 2019, the AHA also had a number of risk enhancers. So these are factors that often are not in the scores, but are relevant, right? And that includes things like conditions during pregnancy, so like preeclampsia, inflammatory conditions, some ethnic groups, and then some unique biomarkers, right? ABI, C-reactive protein, et cetera. And in answering the question for blood pressure, I think it's also important to think about other risk factors where this has been applied quite effectively. And so I'll spend a moment just to talk a little bit about lipids. So here on the left, we have a strong linear relationship, going back to that framework I mentioned, of LDL cholesterol reduction and lower risk of cardiovascular disease based on clinical trial evidence. And on the right, we see a simulation of two different patients, one with a risk distribution in blue and the other in red. And you can see the one with the red obviously is at higher risk, okay? But they have a risk enhancer or some risk factors that kind of shift them to the higher zone. But in general, I think we could all agree that while circulating lipids may be associated with plaque, we might not adequately be able to identify the isolated factors related to that plaque that predispose the lesion to rupture, right? Whether there's an anomalous vessel or there might be some unknown, unmeasured items that contribute to plaque instability. So there's this unknown here. We have a risk factor that's related to it, but there's a lot of unknowns. The other thing about lipids, you could say, is that the risk factor profile is relatively benign with regards to treatment, right? So we know that there's some associated muscle syndromes that are relatively tolerable, and then some rare, unusual outcomes. But in general, there's no real concerns with extremely low lipid levels. And lipids themselves are relatively precise in terms of their measurement and are somewhat reproducible. And so, and then in thinking further about risk, right, when you look at continuous relationship with LDL cholesterol and cardiovascular disease, it's also apparent that there's not really a clear cut point of where that risk plateaus. You might say in this particular study, well, that's around 125, though they lost some precision there. But with this kind of framework in mind, right, we have the ACC-AHA 2019 primary prevention guidelines saying, well, yes, treat the folks with the extreme, with very high LDL cholesterol individuals, but then let's use a risk framework to help guide other therapy and preventive therapy, and focusing on risk as a useful guide for when we should start thinking about introduction of statin therapy. And the VA in the United States actually went even further in their 2020 guidelines, and they said, well, let's just forget about cholesterol altogether. Focus on risk, focus on getting people onto the cholesterol or statin doses that were used in trials, and don't even check for an LDL response. The idea is that you're trying to just apply the proven therapies to those at greatest risk. Okay, so what about blood pressure? So already we are using risk in a lot of our guidelines. And I took this from the Korean Society of Hypertension 2018, 2022 update, right? So those who are high risk, the recommendation is to treat to a lower goal, 130/80, as opposed to those with low to moderate risk where it's 140/90. And so what is some of the basis for this? Well, there's a substantial body of evidence, observational evidence, so this is 61 cohorts, 1 million adults, suggesting that regardless of age, the lower your systolic blood pressure, the better it is for you with respect to cardiovascular disease. And in fact, all of these linear relationships have no sign of really slowing down. Suggesting that if we were to extrapolate even further, there might even be lower risk at lower systolic blood pressures in cohort studies. We also know that blood pressure is related to primordial prevention and pathways of injury. And in this really nice study from the MESA cohort, they demonstrated that higher systolic blood pressure is associated with even very sensitive injury to coronary vessels, right, as depicted by coronary calcium score. And has been presented several times today already, the SPRINT trial, we're all very familiar with it. Well, SPRINT emphasized a more intensive blood pressure treatment goal, less than 120 systolic. And interestingly, during the trial protocol, they did not de-escalate therapy unless the systolic blood pressure, unless there was some side effect of treatment or the systolic blood pressure fell below 105 millimeters of mercury, suggesting that allowing the blood pressure to kind of go even lower than the goal was permissible and as part of, as manifested by their outcome, associated with a longer-term survival. In this meta-analysis of 48 randomized trials stratified by cardiovascular disease and no cardiovascular disease, the blood pressure lowering treatment trials collaboration also demonstrated benefit from more intensive therapy. And one thing they noted is that a 5 millimeter reduction of systolic blood pressure reduced risk of major cardiovascular disease events by about 10%. Irrespective of previous diagnoses of cardiovascular disease, so whether you're higher risk or lower risk, and even at normal or high normal blood pressure values. So it didn't matter where you were starting, didn't matter your baseline risk. And this is demonstrated here as well in this meta-regression, right? The greater the reduction, the lower the risk in almost a linear-like fashion. And on the right-hand side, regardless of where you were starting, even if you were starting with a systolic less than 120, your risk was reduced with more intensive therapy. So there was benefit that was commensurate with the magnitude reduction and regardless of starting point. Okay, so I hope maybe at this point folks agree that there seems to be, at least from cardiovascular disease, no real clear stopping point in terms of how far we should go in lowering blood pressure. Well, what about this idea of reaching normal and being satisfied with getting to a normal, healthy range? And I would argue that even this is kind of subject to debate. This nice study that was published in 2022 looked at unacculturated populations and acculturated populations and took the percentile, the 75th percentile of blood pressure for systolic and diastolic blood pressure and found that for the unacculturated population, this was about 120/70 compared to our modern populations where that would be about 140/90, which is our typical definition of hypertension. And so you can kind of see that even though we might have a lot of people with blood pressures in the 120 to 130 range, we say that that's normal. The reality is compared to unculturated, more naturally occurring populations, that still might be an abnormal blood pressure and would be defined as hypertension for those tribal groups, suggesting that our normal is not really potentially a healthy, natural normal. Okay, so however, I think there are some reasons why we don't go overly aggressive with blood pressure, right? And I think one of the biggest challenges, and I think it's been talked about quite a bit, is measurement and measurement error related to seated blood pressure. And we know that it's technically challenging to perform a blood pressure measurement. I included the AMA guide here that I think many are familiar with. We know there's so many different steps and things to do to get blood pressure accurately. It requires frequent retraining of technicians to really perform correctly in clinic. So that's one challenge related to blood pressure as a risk factor. Another challenge is device and precision, right? We have several international registries at this point trying to help guide or vet the accuracy of devices, but we know even the devices on those registries have their own acceptable degrees of measurement error, and many of them, particularly the oscillometric devices, are estimating systolic and blood pressure, and so that's a challenge. Brachial artery blood pressure itself is an indirect measure of pressure in the vessels of interest, right? People talk about central blood pressure. Really, we're often very interested in the coronary vessels or the cerebral vessels. And when you think about it, if someone has an aneurysm developing in the cerebral vessel, well, even if the pressure does reflect the pressure in the arm, it doesn't tell you about what that vessel can actually tolerate. And the same as microcirculation or various different vessels, we might not know what the pressure is in that particular vessel of interest. And so this is a challenge that we have with measurement. The other major issue has to do with the fact that blood pressure itself is dynamic. And so we often think about, well, we're measuring your blood pressure, are you controlled or not controlled, as if we were measuring a length on a board or something that's very discrete. And the reality is someone could have a disturbing thought, there could be a loud noise, change in environment, different environmental exposure, and their blood pressure is very different the next day. And so this is a challenge that we deal with. And last, the measurement window is extremely narrow with blood pressure. And I highlight this here on the bottom right, this sort of theoretical construct. The green represents office blood pressure, then we put over here in light blue home monitoring, and then these other lines may be ambulatory blood pressure. But you can see that throughout the day, someone could have all sorts of different environmental triggers and fluctuations in blood pressure that we cannot detect, and we do not have gold standard means of assessing in a natural environment. This can also be true for low blood pressures. And so when we talk about treating a blood pressure in the office setting, or even with some of our out-of-office measurements, we're still missing so much information about where people's blood pressure is going, both from the perspective of higher risk and low risk throughout the day. And over here on the bottom left, we just depict how the average, which we use to get more greater precision or accuracy in our assessments, really will not capture or can lose information about how someone's blood pressure might fluctuate throughout the day or from day to day. And this has been demonstrated quite clearly in the SPRINT trial. Here I have depicted the difference between daytime ambulatory systolic blood pressure and office clinic blood pressure used to titrate treatment. This is in a paper by Alama Ghazi. And what we can see is substantial lack of agreement between office and out-of-office assessments, suggesting that even with the excellent standardized procedures in SPRINT, there were still a lot of differences that people in blood pressure from people at home. We know that more intensive therapy does result in a number of notable adverse events. Hypotension, syncope, these were observed in SPRINT and in meta-analyses. Acute kidney injury, also thought to be related to hypoperfusion. And then hyperkalemia, which is often class-related effects. However, there are a couple of kind of outcomes that have been attributed to hypertension that I think are a little bit less evidence-based. So orthostatic hypotension being one of them, and this is some of our work looking at orthostatic hypotension. In some sense, more intensive therapy does not seem to induce orthostatic hypotension, but rather may actually lower the risk of having it. And then falls, often attributed to lower blood pressure, has not been seen in meta-analyses of clinical trials, nor has risk for fracture. So sometimes these are attributed to more aggressive therapy, but really haven't been shown in the evidence. What about microischemia from low blood pressure? We often think of this with increased pulse pressure individuals. Here in the secondary analysis of SPRINT, they looked at baseline diastolic blood pressure and did not find increased risk from therapy among those with lower baseline diastolic blood pressure. And in fact, there was no real difference across these strata. And then thinking a little bit more about age, right, that risk factor I highlighted earlier. So this is one group that is particularly high risk for cardiovascular disease events, but they also have greater blood pressure variability, so they're more challenging to treat. And so in this rendering by strata of age, we can see that intensive therapy, the dotted line, universally lowered risk of major cardiovascular events, though there was some lack of power, obviously, in the 85-plus group, but otherwise quite consistent. And in the STEP trial, which focused on older adults ages 60 to 80, we also saw a considerable reduction in cardiovascular disease risk from more intensive therapy. This was presented earlier by colleagues looking at frailty. We might say, well, what about the more frail adults? Well, in this secondary analysis of SPRINT with adults age 75 and older, there was really no difference between the fit, less fit, and frail individuals with respect to the benefits of intensive therapy. Some have said, well, what about folks with cognitive impairments? Maybe treatment of these individuals should be concerning or cause for concern. But as presented earlier, and in this meta-analysis by Hughes and colleagues, cardiovascular disease or blood pressure reduction can have benefits beyond cardiovascular disease with respect to dementia. So that might not be a reason to avoid treatment in this higher risk group. And so how have the guidelines kind of tackled the evidence? Well, the ACC-AHA guideline focused in 2017 focused on a goal of 130 for non-institutionalized ambulatory community dwelling adults. And then for those above age 65 who had a higher disease burden or a number of comorbidities, they emphasized shared decision making. Similarly, the Korean Society of Hypertension guidelines for those above 80 focused on a goal of or diagnostic threshold of 160, but then for those between 65 and 80, 140, with a goal to reduce blood pressure to 140. That has been retained in the update in 2022. However, other professional societies have also kind of wrestled with this, and you can see a fair amount of heterogeneity, some focusing on 150 range for older adults, others like KDIGO not specifying age, and then the recent ESC and ESH, even within Europe, having different perspectives between either going to the 130-80 or a higher 140-90, in some cases 160. I will point out that this really nice report by Brett Egan, where they looked at the number needed to treat, and they pointed out that the number needed to treat in STEP and SPRINT in the general population wasn't all that bad with regards to preventing the primary outcome of cardiovascular events, right, 86 or 45. But when you looked at the SPRINT population that was 80 or older or HIVIT, so these older populations, you can see the number needed to treat dropped down substantially. So when we think about older adults, again, a high-risk population, they're prone to benefit from a more aggressive therapy, and it doesn't require treatment of a lot of people to realize that benefit. They're also more prone to be harmed, right? And that's another factor that needs to be balanced when we think about lower thresholds. However, I'd point out that some of these outcomes, hypotension, syncope, electrolyte abnormalities, AKI, they may be reversible and not in the same kind of level of or disability induction that we might see from cardiovascular disease events. Another item to think about when it comes to threshold is what we're trying to achieve in the population, right? If we think about, if we set as our goal 140-90, and we stop there for the individual, well, in this sort of thought experiment, you can see you're going to have about half of your people at goal at a given time and another half not at goal at a given time. However, if you target a goal that's more consistent with the SPRINT trial, let's say 125, this assumes a 15 millimeter Mercury standard deviation, then you would have about 84% at goal at the 140-90 range, and you would have, and you would have only 2% below 95 millimeters of mercury. And then likewise, if you went even further, you would have greater population control rates. And so this is something to think about if we really want to achieve population control, this idea of being more aggressive at the individual level. I'll also point out this really interesting paper by Liu and colleagues where they used real-world data to look at dyads of blood pressure within 90 days, so two blood pressures, and they noted substantial variation between visit to visit. And so again, when we think about treating the blood pressure in front of us, it's important to recognize that the next blood pressure when that person comes in could vary substantially. And we're dealing with a moving target that really should be taken into account. And so in conclusion, high blood pressure has a linear relationship with cardiovascular disease. There's no plateau for benefit with respect to CVD, so lower is consistently better. Blood pressure measurement may represent the most compelling limitation on how low we might target with treatment due to hypotensive complications. Conversely, true blood pressure control is not a static state, as blood pressure will vary between visits. Cost may be relevant for lower risk individuals, but lower goals and targets may be reasonable for high risk individuals who can tolerate therapy without complications. And shared decision making is obviously critical in absence of trial evidence. So my answer to this question about lower limits is yes, with an asterisk. I think in some sense, right, lower limits would be net beneficial, especially for high-risk adults. But arguably, it's in each individual's interest to push their blood pressure as low as tolerable. But measurement limitations and side effect potential limit the population implementation, which needs to be customized to account for each person's unique situation. So thank you very much.
Thank you very much, Dr. Jurashik, for a great presentation. And now Dr. Kim is going to introduce our panelists.
Okay, now we have a discussion from our panelists, and after that, you can get some additional comments from audience. Today we have 5 panel discussion. Eunji Kim from Gachon University, Hyuk Lee from Yonsei University, and Daeyoung Chun from Hallym University. Dr. Kim first.
Thank you for. Thank you all the presenters for sharing insightful lectures. And I'd like to make a comment and ask a question to Dr. Lee. It's clear from the presentation that hypertension among young population should not be neglected given its lifelong impact. But compared to other age groups, conducting studies among young population can be challenging. So, like, for example, low participation rate or low utilization of healthcare services. So what do you think is the best way to collect young population data, and what kinds of data can be the most stable for this population?
Thank you, Professor Kim, for the excellent question, and it's actually a difficult issue. So the whole reason that we have so little evidence on young adult hypertension is precisely because it's so difficult to collect data from these patients. I mean, these patients don't even come to the doctor's office. I mean, how are we going to collect their data for research purpose? So that's a really difficult issue. So, but in case of Korea, we have the national screening data, and actually until a few years ago, the national health screening was only given to employees or general population of age 40 or over. But in recent years, the eligibility was expanded to all population above age 20. And I think that made a really big difference, both for the research and also for the general hypertension care. So we see that improvement of awareness, treatment, and control that precisely followed the years that this expansion of eligibility occurred. So I think in perspective of both clinical practice and research practice, I think collecting like the general population data of a young people is of particular importance, and given the circumstances that it's almost impossible to conduct randomized trials in these populations, basically using observational and real-world data in this population is particularly important, and that's exactly what we are trying to do in Korea.
Hercules.
Thank you, speakers. It was truly a wonderful session. So I agree with Dr. Shinbu that the masked hypertension is probably the most understated, under-recognized, and underestimated phenotype of hypertension, and we very much frequently miss it and do not care about the fact that we miss them. So, and as you mentioned, it is essentially impossible to screen all patients in the clinic with ABPM or even with home BPM, I guess. And some suggested strategies for targeted screening may also have their own pros and cons and may not be perfect. And in terms of like the burden or cost related to this mass screening of patients, I think the recent advancement of wearable devices may have some large role in this part. So, you know, Apple Watch or Galaxy Watch are very widely available these days, and virtually everyone can use it very simply to measure their blood pressure at home and monitor it throughout the day. So, I think if we can like advertise or like make people more aware of the importance of BP monitoring with those wearables, I think we may be able to re-expand the indication for screening with wearable or any home-based devices. So do you have any thoughts on the use of these devices? Thank you.
So I would say I agree. However, that technology it's almost like Star Trek. It's like, that's the ideal world. And as you know, a lot of promising devices that are wearable, some of which are cufflinks, I think a lot of work has to be done for validation. I think that's the main concern. If validation can be shown that these devices are accurate, then I'm on board to use it as an out-of-office blood pressure measuring, a way to detect mass hypertension. Yeah.
Okay, Taeyong-chan.
Okay, thank you for all the good presentations. And I have a question for Dr. Park. And it's really hard to set blood pressure target in CKD patient, and also there are many comorbidities with heart failure or some cardiovascular disease. So, and I've seen many times in actual clinical practice that if I have a lower blood pressure and at the time the patient going to AKI, and when I reduce my blood pressure management and it gets better. So do you have any advice you can give actual clinical practice medication? We already know about that. All the patients of CKD patients have to take ARB or AC inhibitors, but you can use which drug first, and or especially if it is meaningful to use ARB as a lowest dose.
Okay, thank you for bringing up a very important point. As you know that the BP control in patients with CKD is a very complex program because they usually have the advanced age and they are vulnerable to the AKI due to the hemodynamic compromise. So I have some questions or some considerations for the managing hypertension in patients with CKD, but usually the first question for the patient who comes to my clinic, I ask them how were your BPs at your home or at usually your livings, because in the office, but Dr. Simbo said that you focus on the masked hypertension, but in my office, I feel that the patients have more white coat effect or so lowering BP, the strategy for the lowering BP in patients with CKD, I'm trying to lowering BP as the patient tolerated. It is very important, and when I changing medications or some regimen, I follow up the patient in the short term. So And regarding the medication, I will present about the last blockade in advanced decade in the volume B this session. So if you have any questions about the medication, please come to the session. Thank you.
Okay, any other questions or comments? Can I have a question for Stephen Jurasek? So as you show clearly, the lower BP is better in general, but some guidelines recommend we can set up higher BP level for elderly people, frail patient. But are there any biomarker or objective indicator to identify for whom excessive BP lowering can be harmful?
That's an excellent, excellent question, and I don't know of one specifically. I mean, we've looked at markers of, again, using high sensitivity troponin to look at subclinical ischemia. The problem is with that marker is that's more strongly associated with high blood pressure. And so this idea of trying to get at ischemic or low states and their impacts on end organs can be very tricky. And I think one thing that the more we've looked into, particularly the orthostatic hypotension literature, I think the one thing to recognize is that you might run into trouble when people go very low with regards to their outcomes. But the times that their blood pressure is high is still pathologic. And so we're kind of dealing, especially with older adults, often these states of high blood pressure and low blood pressure. And when we say, well, we're not going to treat blood pressure in these individuals, you're kind of making a choice to prioritize one item versus the other. Now, that's not necessarily a bad thing. Sometimes that's what you have to do. If someone can't walk outside without fainting or having a hypotensive event or syncopal episode, that's a real problem. But I think the notion that ignoring the high blood pressure is okay is not necessarily evidence-based in my mind. I think we're kind of, those folks are still at higher risk for stroke and cardiovascular disease events with that high blood pressure. So.
Thank you.
Yes, I mean, we heard some really outstanding talks today. I think the comment question that Hyuk raised around the wearable devices, I think it's very promising. Interestingly, you look at Apple and their watch, they've developed the technology to measure blood pressure, but they haven't introduced it commercially because they are concerned, I think, about the fact that these devices are not validated. And in fact, they talk about that it's not really to measure blood pressure, it's more of a screening tool. So in fact, that might be where the utility of these devices are, since we can anticipate that the validation is going to take time. So in the meantime, if it does raise awareness, even if we are still concerned about the accuracy and those individuals then seek medical care, maybe that's where they provide some value, because Dr. Shimbo's analysis of trying to do 20 million ABPMs is probably not realistic. Maybe home blood pressure monitoring is the surrogate or replacement, but hasn't been studied. So I think we will end the session and thank the speakers and panelists for an outstanding group of presentations. Thank you.
Thank you.
Okay, great.
Love My Soul. 서울에 오면 사랑에 푹 빠지게 될 거야.
In the heart of a city where
So lovely,
love paints the street and inspirations are
so romantic,
excitement in the air. It's a playground of delight. Soulful cities call.
so fantastic. 발길 닿는 곳마다 사랑이 가득하니까. 여기 서울에서 너만의 소울을 느껴봐. Feel so good. 서울 My Soul.
전 세계 사망 위험률 1위 고혈압. 매년 1,000만
제가 영어가 워낙 안 좋아요.
아유 무슨 말씀? 뭐 보니까 아까 뭐 저기 패널리스트가 있는데 어떻게 저 인트로듀스를 어떻게 먼저 하시고?
제가 2개 하고
아, 2개 하시고
선생님 2개 하시고
돌아가지 말고요.
어?
왔다 갔다 하지 말고.
왔다 갔다 할까요? 어떻게
마음대로
할까요?
하세요.
그냥 두 개 하죠.
그렇게 안 마음대로 하세요. 예,
예.
그럼 앞에 2개 하시고 제가 2개. 그리고 지금 얘기 들으니까요, 이분이
예.
못 오셨대요. 첫 번째 분이요.
아 예. 문기훈.
예, 예.
아 문인기.
예, 이분이 못 오셔서.
박상하 교수하고 유태현 하고 유다 트란스 인도네시아.
아, 인도네시아 분.
예. 유다 트란스.
그래서 아까
저기
유다가 인사했구나.
저기 계시네. 유다 트란스.
유다 트라랑.
그렇게 하는 게 낫겠네요. 요거 두 번째가 정재훈 교수 저 같은 병원이고 제 데이터니까. 미국엔 언제 가셨어요?
저요?
예.
30 몇 년 됐죠.
저는 미국 가본 지가 벌써 한 30년, 20년이 넘었는데.
그러세요?
예. 그냥 맨날 유럽만 다녀가지고.
어디 계셨어요?
아니 저는 뭐 트레이닝은 하이델베르에서. 아니 한국이고. 그러니까 학회는 무조건 다 유럽만 다녀가지고. 예.
왜 미국 안 오세요?
ASH가 죽어서.
좀 덜 가서 그렇죠.
예. 그 다음에 하이델베르에서 또 오로 트레이닝 받아가지고.
독일 쪽에서요?
가뜩이나 영어 못하는데 독일 있다 보니까 더 못하더라고요. 독일식 영어를 배워가지고.
37분입니다.
예, 시작하죠. Good afternoon, our colleagues, ladies and gentlemen. We'll start this session. The title of this session is Dietary Approach to Stop Hypertension, focusing on salt intake. In this session, salt means sodium and potassium. Sodium and potassium is very important mineral that regulate our blood pressure and also eventually cardiovascular outcomes. So we have 4 speakers this session, and we have 4 panels. Unfortunately, one of the panels cannot come to here, so we have 3 panels. I will introduce myself. I'm Professor Lee from Dongguk University, University, and I am also chairman of Korean Society of Hypertension. And Professor Oh will introduce by himself.
My name is Young Oh from US, NHLBI, that's National Institute of Health.
Thank you. First 2 topics, I will introduce first 2 topics, and next 2 topics will be introduced by Professor Oh. First topic. The first topic is dietary strategy for hypertension management, dietary reference intakes for dietary sodium. It will be presented by Min Jung-shin from Korea University. Please.
Thank you for your kind introduction, Professor Lee. Thank you very much to the organizers. Give me the opportunity to talk about my topic here in this interesting session. The topic that I want to share with you today is regarding dietary strategies for hypertension management, mainly focus on the dietary sodium intake in Korean population, whose intake is much higher than others during the past 2 decades. And also, I would like to introduce Korea dietary reference intakes for dietary sodium in this presentation. This is actually an old story. It has been believed that high sodium intake elevates blood pressure, which in turn is related to increased morbidity and mortality for blood pressure associated chronic diseases. Now, for example, a previous meta-analysis has shown that a reduction in blood pressure by 5 mmHg was associated with reduced risk for mortality due to coronary heart disease and stroke by 9% and 14% respectively. This is actually on the premise that dietary sodium is associated with cardiovascular diseases, predominantly mediated by its impact on blood pressure. The original idea that sodium intake can pose a threat to the general population emerged only in 1980s. This shows the results from INTERSOLT study, which is one of the most influential but very old studies. In that study, they reported a weak association between urinary sodium excretion and blood pressure in ecological analysis across the 52 centers. And subsequent several observational studies have confirmed the previously observed association between increased sodium intake and elevated blood pressure. In addition, a meta-analysis of a randomized control trial revealed that modest reductions in salt intake have a significant effects on changes in blood pressure, both in normotensive and hypertensive individuals. Similarly, a 20-year follow-up of 2 sodium reduction trials identified a linear relationship between dietary sodium intake and cardiovascular disease outcome. Therefore, it has been suggested that increased sodium intake results in an increased risk for hypertension and consequently cardiovascular morbidity and mortality. Based on these observations, most international guidelines including WHO and American Heart Association, recommends sodium intakes at various ranges less than 2,400 milligrams per day. However, population sodium intake in almost all countries worldwide far exceeds the WHO guideline of 2,000 milligrams per day, as you can see here. So in order to reduce the sodium intake at the population level, there has been a growing number of national sodium reduction initiatives. This shows the intervention spectrum covering from agentic to structural components, and they distinguish it between interventions that are more agent, which target behavior change among individuals, and those that are more structural, which target settings where behaviors occur. This type of approach has this significant impact because the societal implications of shifting risk profiles to a favorable direction is potentially very large in the entire population. As a representative example, this shows the experience from Finland, which illustrated the impact of sodium reduction policy and use of epidemiological surveillance data when setting priorities. The substantial decline in coronary mortality over this period is mainly ascribed to population-wide sodium reduction and consequent improvement in public health. As with Koreans, we all know that our mean sodium intake has long been among the highest all around the world, but this has steadily decreased to a level of 3,200 milligrams per day at this moment. And according to Korean National Health and Nutrition Examination Survey, a decreases in blood pressure appears to be highly associated with a decline in dietary sodium intake, which in turn is likely to be associated with a fall in mortality from stroke and ischemic heart disease over the same period. These observations indicate that the efforts of Ministry of Food and Drug Safety of Korea, initiated in 2010, have been very effective in reducing sodium intake at the population level. So this nationwide program includes technical supports to food manufacturers, restaurants, and food service for reducing sodium contents in food, along with the promotion of several nutrition education programs for the community communities and for the individuals. And in order to further characterize the effects of population-wide sodium reductions, we next conducted a comparative risk assessment analysis in order to quantify deaths attributable to high sodium intake. This CRA method is a very useful tool for quantifying disease burden due to specific factors and for synthesizing evidence in order to inform policy priorities. So using this framework, we were able to estimate the number of deaths that would have been prevented if the current distribution of exposure had been changed to a hypothetical alternative distribution. The results show that the calculated population attributable fractions for stroke and ischemic heart disease were remarkably decreased during the same period in Korean adults, which corresponds to the decline in dietary sodium intake at the population level. And this slide shows the summary of quantitative estimates of how changes in risk factors have contributed to shifting disease burdens over the 20 years, as you can see here. And when evaluating the contribution of each risk factor, the number of deaths attributable to inappropriate dietary sodium intake have substantially decreased over the past 20 years in Korean population. So far, so good. Then a question has been raised as to how low sodium intake should go. Do we need to further reduce sodium intake toward the WHO target of 2,000 milligram sodium per day? And one thing that I'd like to share with you is the fact that health policy focused on population-wide reductions in sodium intake have several assumptions as follows. The first question is whether current intakes are excessive, and the healthy range must be below current intakes, and sodium intake can be substantially reduced by public policy. And finally, unlike all other essential nutrients where a healthy range is defined by a Gaussian distribution, lower sodium intake is always better. However, recent scientific publications have challenged these assumptions. The first aspect is regarding how robust the evidence for very low sodium intake is. A major challenge to the assumed benefit of low sodium intake on cardiovascular events came from the prospective cohort studies reporting on increased risk of cardiovascular disease with low sodium intake, and they suggested that moderate range of sodium intake generally consumed at average is associated with the lowest cardiovascular disease risk. This is actually in contrast to what we have been aware of. And this was further supported by subsequent studies showing the lowest risk in regions of moderate sodium intake range and the higher potassium intake, and the highest risk in reasonable extremes of sodium excretion along with low potassium excretion. As such, emerging scientific evidence has raised uncertainty about the health effects of universal sodium restriction. In addition, low levels of sodium may have negative effects through blood pressure independent pathways. So as a matter of fact, reductions in sodium intake to lower level less than 3 grams per day markedly activate renin-angiotensin-aldosterone system to conserve sodium, which is also known risk factor for cardiovascular disease. And along with this, we have a sodium appetite set at 3,500 milligram per day, which is centrally regulated in response to peripheral hormonal signal. Therefore, although extreme reductions in sodium intake are possible in controlled settings for short term, such as seen in randomized controlled trial, however, they are not sustainable over the long term in free living population because individuals have a physiological set point as well as a sodium appetite. Taken all together, these findings indicate that human sodium intake is controlled by human physiology and may be difficult to be modified by public health policy only. It is also interesting to see that few countries meet WHO target, and most countries with a sodium close to WHO target are developing countries with a malnutrition issue. So it seems that it's extremely challenging to meet this goal in regular daily life and maintain a long-term, at the same time consuming balanced nutrition in current food environment situations. In order to support the observation from pure study, we assess the risk of mortality according to energy-adjusted sodium intake using K-enhanced data linked by the mortality in Korean population. Our results show that the individuals with moderate sodium intake range showed a significantly lower risk for all-cause mortality. On the other hand, when it comes to the cardiovascular disease associated mortality, the individuals with extremely higher sodium intake showed a significantly association with the higher cardiovascular mortality. And these results indicate that current guideline of sodium intake does not provide any additive beneficial associations with mortality in this Korean population. On the other hand, there is also mixed result showing that lower sodium intake is always better to cardiovascular disease at the population level, including the opposite opinion in terms of lack of valid and reliable method measurement issue, or the poor study design, or and so on. So, for example, it was reported that higher sodium excretion along with the lower potassium excretion was related to higher cardiovascular disease risk using pooled data from 6 prospective cohort studies. In that study, they analyzed the multiple 24-hour urine samples, which provides robust evidence to support the benefit of reducing sodium intake and increasing potassium intake. So the ratio of sodium to potassium intake may be more precise indicator when studying the effect of low sodium diet on blood pressure associated chronic diseases. And also, meta-analysis of randomized control trial demonstrate a linear reduction in cardiovascular disease when dietary sodium is reduced from 4,100 milligram per day down to 2,300 milligram per day. More importantly, special considerations needed to be for vulnerable individuals, such as elderly people and patients with hypertension, or the individuals with a high sodium intake at baseline, and the existence of salt sensitivity along with the ethnic variability, which is ultimately toward the precision guideline. So while awaiting the results of a large-scale randomized control trial studying the effect of low sodium intake on cardiovascular disease, at this moment, the range of sodium recommendation needs to be reconsidered to be optimal for public health based on current scientific evidences together with the feasibility issue. And in this case, the range should be to achieve blood pressure benefits of lowering sodium intake without overactivation of renin-angiotensin-aldosterone system and the lowest rate of cardiovascular events as evidenced by epidemiological studies. In the meantime, recently, Korean Nutrition Society has revised a Korea dietary reference intake, a new model for DRIs for dietary sodium. And the committee has been charged to review the available evidence to update current DRIs. And especially, there has been a consensus that DRIs need to consider the inclusion of a chronic disease endpoint during the process in order to extend from the traditional DRI components. So the results were based on synthesis of evidence from sodium reduction trials as well as a extensive systematic review process. This slide actually shows the summary of updated Korea dietary reference intakes for Koreans. Among these, the CDRR, chronic disease risk reduction intake, is the newly introduced DRI component, of which the definition is the lowest level of intake for which there was a sufficient strength of evidence to characterize a chronic disease risk reduction. So for sodium, the CDRR is the intake above which intake reduction is expected to reduce chronic disease risk within an apparently healthy population. So based on the comprehensive meta-analysis, as I earlier said, on the dose-response relationship between sodium intake and chronic diseases, CDRR component for dietary sodium was set at 2,300 milligrams per day for Korean adults at this moment. To conclude, positive associations between dietary sodium intake and elevation in blood pressure has been firmly reported. In addition, too much sodium remains a valid concern, especially in hypertensive individuals. And with the sodium reduction initiative, there has been a remarkable decline in sodium intake in general Korean population. Whether there is a population-wide benefit from further reductions to a level of WHO target to 1,000 milligrams per day remains questionable, but at this moment we do not have any additional strong evidence to change the guideline cutoff for dietary sodium at the population level. Finally, upstream interventions are urgently needed and strongly recommended to improve the food system to reduce sodium intake. I just finished by acknowledging particularly all of the students in my laboratory who did most of the work that I've talked about today. Thank you for your attention.
Thank you, Professor Sin. That's very interesting. I'm sorry, my eye is not good. So I have to change it whenever I have to read this paper. Next topic is debate issues in salt intake and measurement. It will be presented by Professor Jae-hoon Jung from Dongguk University. He is my junior colleague. Please.
Thank you for introduction. Today I'm going to talk about debate issue in salt intake and measurement. I start with the association between sodium intake and blood pressure. The result of InterSalt study, an observational epidemiologic study, showed that a 24-hour urinary sodium excretion was positively correlated with systolic and diastolic pressure. And in a more recent study using National Health and Nutrition Examination Survey data shows that when the urinary sodium excretion was divided into 4 groups according to the amount, the higher the urinary sodium excretion, that is, the higher the sodium intake, the higher the blood pressure. A similar trend was seen when based on the urinary sodium to potassium ratio, and there is an inverse relationship between the potassium excretion and systolic blood pressure. Let's see what the result of the intervention studies are. In this small study, in a 2-year intervention study conducted in 2 villages in Portugal, the moderate salt reduction diet showed was 13 millimeter mercury lower systolic blood pressure and 6 millimeter mercury lower diastolic blood pressure after 2 years intervention compared to the control diet. Let's look at the result of a study using the DASH diet, which was developed to prevent hypertension. The study sought to examine the effect of a 30-day control diet and DASH diet in adults with blood pressure greater than 120/80 and stage 1 hypertension. And subjects were divided into 3 groups according to the sodium intake, and in both the control diet and the DASH diet, the lower the sodium intake, the lower the blood pressure. And in all 3 sodium groups, the blood pressure was lower on the DASH diet compared to the control diet. So the combination of DASH diet and the low sodium diet was most effective method to reduce the blood pressure. In a meta-analysis which took the relation between 24-hour urinary sodium excretion and blood pressure, the lower the urinary sodium, the lower the blood pressure, both in normotensive and hypertensive subjects. So far, we have looked at the relationship between sodium intake and blood pressure. So what is the association between sodium intake and cardiovascular outcomes then? This is a small-sized study which was conducted to find the effect of salt reduction on CVD risk factor. The subjects were divided into two according to the salt intake. The placebo group, which was the standard group, and higher salt group who took the slow sodium release tablet. As expected, higher salt group was the morphine blood pressure and the ambulatory blood pressure was significantly higher. And in terms of the target organ damage, aberrant current ratio and pulse velocity was significantly lower in placebo group. When divided by race, the aberrant current ratio showed a similar result regardless of race, but pulse velocity was only significantly different only in black people. That means the sodium sensitivity may play a role. Today, because of time limitation, I do not talk about the salt sensitivity. How about the long-term outcome of the salt restriction? This long-term study looking at the sodium reduction and cardiovascular disease outcome, the result of long-term follow-up study of the TOP study, which look at the association between dietary sodium reduction and cardiovascular disease in middle-aged pre-hypertensive subjects, showed that when the sodium the intake was lower, the incidence of cardiovascular disease was lower. When TOP1 and TOP2 results were combined together, even after adjusting those confounding factors like age, race, sex, and various infection, cardiovascular disease risk was significantly higher in salt restriction group. How about the stroke? This largest sized population-based cohort, which was conducted in Takayama, Japan, the study subjects were divided in total according to the sodium intake. And as you can see here, the total stroke mortality, ICH mortality, and ischemic stroke mortality was significantly higher in high salt intake group. However, these study results were only seen in men. There was no statistical significance in women. The other, the largest scale epidemiological study, which was also conducted in Japan, showed a similar result. This study divided the total according to salt intake, mean blood pressure, and stroke mortality in the entire country, and they examined the relationship between the salt intake, blood pressure, and stroke mortality. And the results showed that salt intake had a positive relationship with both mean blood pressure and stroke mortality. However, mean arterial pressure was not significantly correlated with stroke mortality, which means sodium intake itself has adverse effect on stroke mortality independent of blood pressure. In another prospective study which was conducted in Finland shows a similar result. This study evaluated the relationship between coronary heart disease, cardiovascular, and all-cause mortality between 24-hour urinary sodium excretion. And in the result, every 100 millimole, which was 5.8 gram, increase in 24-hour urinary sodium excretion was associated an increased risk of 50% in coronary artery disease mortality and 30% in cardiovascular disease mortality and 22% in all-cause mortality. And the prospective studies of meta-analysis showed a similar result. Higher salt intake was associated with about 1.23 times higher risk of incidence of stroke, risk of stroke, and 1.17 times higher risk of cardiovascular disease. Contrary to the research results introduced so far, some researchers claim the salt paradox. In an observational study of two cohorts, including the on-target and transcendent trials, estimated 24-hour urinary sodium excretion using Kawasaki formula showed a J-shaped association with composite cardiovascular events, which is composite of cardiovascular death, myocardial infarction, stroke, and hospitalization for congestive heart failure. When looking at each outcome components, cardiovascular death and myocardial infarction and congestive heart failure showed J or U-shaped association, and however, the stroke shows a relatively linear association between estimated sodium excretion and incidence risk of a stroke. Another large-scale epidemiological study, Pure study, also showed a similar result. This study also evaluated the relationship between sodium excretion and the risk of cardiovascular and even death. And this study also used the Kawasaki formula to estimate the 24-hour urinary sodium. And the study results show that there is a J-shaped association between the sodium excretion in both death from any cause and cardiovascular, major cardiovascular events. And there is an inverse relationship between potassium excretion and cardiovascular events and all-cause death. The possible explanation of this study result is a plasma renin activity, and it is a possible underlying mechanism. As introduced by the previous speaker, when sodium intake was reduced, the plasma renin activity is arise, and the plasma renin is associated with higher incidence of myocardial infarction. Another study also shows that higher renin activity was associated with all-cause mortality, or CVD mortality, coronary disease, and myocardial infarction. In summary, a possible explanation for the salt paradox is that sodium intake levels affect the renin-angiotensin-adrenaline system, and when looking at the plasma renin activity and sodium excretion graph together, it's very similar to the events graph, J or U-shaped. However, when looking at the effect of sodium intake on renin level, meta-analysis of general population and RCTs, which was conducted over prolonged sodium intake reduction, led to lower standard mean difference of renin level. And this studies results suggest that prolonged reduction in sodium intake is very unlikely associated with elevation of plasma renin levels. The key factor of the salt paradox is the measurement of salt intake. Measurement of salt intake is divided broadly to these three methods: a dietary survey-based method, a spot urine method, and 24-hour urine sodium measurement method. Dietary survey-based method relies on food intake determined by a questionnaire or an interview, and nutrient intakes are calculated using food composition tables. However, this method has inherent limitations, such as reporting errors, inaccurate or incomplete food composition tables, missing data, and coding errors. And this method is difficult to compare sodium intakes between countries, studies, and surveys because of the different dietary survey method and food composition table used, like the Philippines, Korean, and Kenya. And spot urine method was developed to estimate a 24-hour urine sodium excretion using the spot urine. There are many formulas were developed, and these formulas use the spot urine sodium and other factors like sex, weight, and height. And 24-hour urine sodium measurement is a gold standard method of sodium intake estimation. However, these gold standard methods also have a limitation because there is a large day-to-day variation in sodium intake, so multiple 24-hour urine collection is needed to obtain a more accurate result. For example, as shown in this table, there was significant discrepancies in the baseline 24-hour urine measurement and at 1 year, 5 year, 15-year measurement. The consistency was only about 50%. The relation between 24 urine sodium measurement and the estimated 24 urine sodium showed a significant linear relationship in several occasions. Yes, it's a very useful tool, but there's some limitations. In blonde plot comparing estimated 24-hour urine sodium excretion using the spot urine formula with a directly measured 24-hour urine sodium excretion, all these formula overestimated 24-hour sodium excretion at low levels and underestimated 24-hour sodium excretion at higher levels. Another study also shows that all these formulas were underestimated 24-hour urinary sodium excretion at higher level and underestimated at lower levels. And when the spot urine was measured multiple times, the equation using the average of the 3 spot urine samples provides an improved estimation of 24-hour urinary sodium excretion at population level compared with the estimation achieved by those single spot urine samples. The result of the study of the correlation between 24-hour urine sodium excretion and blood pressure are shown here. When 24-hour urinary sodium is measured, blood pressure increases relatively linearly as the sodium excretion increases. However, when 24-hour urinary sodium was estimated using the spot urine formula, sodium excretion and blood pressure shows a J-shaped relationship. So there is a negative relationship between estimated 24-hour urine and the really measured 24-hour urine. How about the cardiovascular event? The cardiovascular event also shows that similar result. When using the 24-hour urinary sodium excretion, which was gold standard, there is a linear relationship between the sodium excretion and the all-cause mortality. However, there is a J or U-shaped association when using those spot urine formulas, Kawasaki, Intrasort, and Tanaka formula. So the result of the J or U-shaped result is because of the inherent the limitation of the spot urine formula. So in summary, all formula overestimate the 24 sodium at low levels, but underestimated 24 sodium at higher levels. There was, even though there was a linear relationship between measured 24 urinary sodium excretion and the spot urine method, there was a discrepancy. The sodium measured shows that linear relationship. However, the sodium excretion from formula showed the J-shaped relationship. The J-shaped relationship are due to introducible of those formulas, and therefore, formula estimated 24-hour urine sodium excretion should not be used to examine the relationship between sodium excretion and blood pressure, since they alter the real associations. The result of a study which collected multiple 24-hour urine collection gives a clear message. In a study combining individual data from following the 6 cohorts measuring shows that higher sodium and lower potassium intakes measured in multiple 24 urine samples were associated in those response matter with a higher cardiovascular risk. To summarize my presentation today, high sodium intake is positively associated with blood pressure, and the association between high sodium intake and cardiovascular outcomes are significant. Although many studies have reported no or inverse or J or U-shaped association of sodium intake with blood pressure, cardiovascular outcomes, and mortality, those studies used biased methods to determine sodium intake. The spot urine collected method is inaccurate and should not be recommended to measure sodium intake at the individual level. And at least modest amount of source restriction may be recommended in both hypertensive and non-hypertensive subjects for the favorable cardiovascular outcomes. Thank you for listening.
Okay, now we move on to third topic. Third topic, we're going to talk about sodium regulation in Asian countries. From Dr. Yun-Ching Chow, and she is a Professor Chia. She's a head of the Department of Medical Sciences at Sunway University, and she's emeritus professor of University of Malaysia. So her talk is about the reduction of sodium intake for the management of hypertension in Asia. Thank you. Go ahead.
Thank you, Mr. Chairman. What I'm going to do is to talk about reduction of sodium intake for the management of hypertension with the focus on Asia. Now, this is just my disclosure. We have known this data about the causes of death in the world globally. For many decades, it has been the non-communicable diseases, namely ischemic heart disease and stroke. But of course, in 2021, this was a little bit of an anomaly because of the COVID pandemic. But whatever it is the cardiovascular diseases that number very high in the leading causes of death. And this is true not only in the high-income countries, but also in upper middle income countries like my country, Malaysia, in lower middle income countries like many of the countries in Southeast Asia like Myanmar, Vietnam, and so on and so forth. And we know that the driver behind these cardiovascular deaths is high blood pressure. It's hypertension. It is the major cause of death. It far outranks things like high cholesterol, physical inactivity, obesity, and so on and so forth. So therefore, the problem is driven in terms of the cardiovascular death is due to high blood pressure. And if we look at the prevalence of hypertension in the world, globally, the mean is around 34%. Unfortunately, more than 1 billion of patients with hypertension, and that accounts for over 80%, live in low and middle income regions. And that, of course, will include countries in Southeast Asia, which has a relatively large population size. And if we were to look at the transition, the change in the prevalence of hypertension between just 10 years, between 2000 and 2010, the blue color signifies lower prevalence, the green, pink, and the red higher. We can see that many areas that had the blues in 2000 have now turned to pink and green, suggesting an increase in prevalence of hypertension in just 10 short years. And of course, sadly, again, the higher prevalence compared to different regions in the world is in the middle and the low income countries. Now, if we were to look at the salt map in the world, where the blue signifies the lower salt intake of 5 grams or less, the green, yellow, orange, red, higher salt intake, we can see that in many regions of the world, except for Africa, the salt intake would be bordering on yellow, orange, and red. And again, many regions in Asia come into this high salt intake range. Globally, it has been estimated that the mean varies between 9 to 12 grams per day, depending on the region you come from. If we were to superimpose the map of the salt on the prevalence of hypertension, again, except for for Africa, the regions with the high salt intake are also the regions with the high prevalence of hypertension, particularly in Asia. The relationship between salt intake and arterial hypertension is not anything new. It's not something we've just discovered recently, but it was described in 600 BC by the Yellow Emperor, who said if too much salt is used in food, the pulse hardens, suggesting arterial stiffness, tears make the appearance, suggesting dissections, aneurysms, and so on, and the complexion changes. I think this refers very much to the sallowness of the end-stage renal disease. And of course, we look at slightly more modern times, and this, of course, is more than 40 years ago, amongst an unacculturated population. These are the Yanomamo Indians who live in northern Brazil and southern Venezuela, where they live on bananas, wild vegetables, and very occasionally they may have game, fish, and insects. So practically, they have no access to salt. You could say they are actually a no-salt diet population. And studies that looked at the salt intake based on the 24-hour urine excretion of sodium, we find that they have negligible, almost non-existent salt in their diet, whereas amongst the missionaries who were working amongst them, it was about 6 grams. And of course, 6 grams is modest compared to what is happening in current times. And of course, amongst both the men and the women, there is no one with a blood pressure that's more than 110, but in the missionaries, there were people who had blood pressures close to 140 or even in the hypertensive range. I think the 2 previous speakers have already shown us and convinced us about the relationship of salt intake to blood pressure, but this is just a quick study that looked at normotensive individuals who were loaded with salt, and immediately you see with the higher salt intake, the higher is the blood pressure. Similarly, this was again shared just now, that any increase in intake of salt increases both cardiovascular diseases and coronary heart disease by about 1.45 to 1.5, 45 to 50%. Now, the WHO, of course, knows that the leading cause of death is cardiovascular disease. They are aware that salt intake globally is high, and so in 2013, they set 9 global goals to reduce NCDs by 2025, which is just next year, and I don't think anyone is near achieving this goal. And the target was to reduce the prevalence of hypertension by 25%, reduce the salt intake in the population by 30%. So that brings us to the question of why is salt reduction of particular importance in Asia? I think that some of the reasons is because of the difference in characteristics about hypertension in Asians. One, of course, and we know this very well, is that the steeper association between blood pressure and cardiovascular disease. This is a study that compared Asians and Caucasians, and if we were to look at the hazards ratio and blood pressure, we can see that in the Asians, for both coronary artery disease and stroke, it is a steeper relationship than in the Caucasians. So just to put it very simplistically, if we have an individual whose blood pressure is raised by 10 millimeters, the hazards ratio is around 1.8 in the Asians, whereas in the Caucasians, for the same 10 millimeters, it is only raised by about 1.3. So therefore, Asians are at greater risk of adverse events of hypertension. The other thing, of course, is that strokes, especially hemorrhagic strokes, are more common than coronary artery disease in Asia. This is the study that looked at the strokes and ischemic heart disease. The brown is the stroke, the lighter, the gray, I think, is the stroke. The brown is ischemic heart disease. And here we can see, particularly in certain countries in Southeast Asia, like Indonesia, Myanmar, Vietnam, strokes predominate. In Eastern Asia, China, strokes predominate over ischemic heart disease. And of course, I think this morning we did hear something about the morning hypertension, which is the rise in blood pressure upon wakening. And again, the morning hypertension has been shown to be much higher in Asians than in Caucasians, and again, independently associated with cardiovascular risk. I don't have time to show you the actual data, but take it as that is what is happening. We also have the problem of obesity and metabolic syndrome epidemic in Asia. In my country, more than half of the population is overweight and obese. And of course, finally, the issue of high salt intake and high salt sensitivity in Asia. What we can see, and this has already been shown, but just to revisit this a little bit, in both the INTERSALT and INTERMAP studies, these were studies done more than nearly 40 years ago. In the INTERSALT study, we can see the salt intake in China, particularly North China, and in Japan is far higher than that in the developed countries like US, in the Western world like US and the UK. Fast forward to more recent times, even now, Malaysia, my country, is consuming about 8 grams per day, Thailand about 9 grams per day, far higher than the 5 grams per day that is recommended by WHO. The association of salt intake with blood pressure is actually, it tells us the magnitude of increase in blood pressure. Overall, it's about 2 millimeters. So if you were to eat, say someone is on 10 grams, you're 5 grams above the recommended, you would potentially raise your blood pressure by 10 millimeters. So there's a huge rise in blood pressures. And of course, what is also important to note is that if you are on a high salt intake, your blood pressure gets elevated far more than if you were a low salt intake, almost 3 times. And that is also very important for us in Asia, where no country eats anything less than 7 grams per day. Similarly, in hypertensive, they are much more prone, much more sensitive to rise in blood pressure with each extra gram of salt intake they take per day. And of course, the elderly population are also see a greater rise in blood pressure with each gram of salt intake that they take. And so the salt sensitivity, we again, no time to share the data, but The Asians are much more salt sensitive. The elderly and the obese are also more sensitive. And of course, as I mentioned, many countries in Asia are aging rapidly. Obesity is an epidemic. So we're going to see lots of problems in terms of the relationship of salt intake and in the country. The good news, of course, is we can get blood pressure reduction, better in fact, in people who are on higher salt intake. And this is well illustrated in the DASH study, where when you look at people who are on low, intermediate, or high salt diet, at any level of salt intake that you take, any reduction does produce blood pressure lowering from about 2 to 5. But the people who are on high salt intake, and this would apply particularly in Asia, where our salt intake is 8 grams and above, we can get potentially 6 millimeters reduction in systolic blood pressure, and that to me is equivalent to a single monotherapy for the treatment of hypertension. So how is Asia doing in terms of salt reduction? What salt policies do we have in Asia, and how are we doing compared to the rest of the world? A review of salt policies in Southeast Asia found that some of these policies were not standalone. They were embedded in either national health policies, nutritional policies, that somehow they get lost a little bit, lost in translation, or worse yet, they're unpublished. And in many countries, there were varying strategies. And when they looked at it from the view of the WHO's pillars of intervention for salt reduction, looking at product reformulation, consumer awareness, or environmental changes, most of the countries in Southeast Asia do not have all 3 pillars, except for Singapore, who is doing remarkably well in terms of having all the 3 types of strategies in place. The midterm review, this is a summary of the progress, and this is more recent data that looked at the progress of implementing salt reduction in the WHO regions. And this includes strategies like intervention in settings, food reformulation, consumer education, front of pack labeling, and salt tax. We can see in the European countries, many countries have subscribed to many of these strategies. Western Pacific, of course, in this instance, it will be Korea and Japan, doing not too badly. But look at Southeast Asia. We are doing so poorly, and I come from Southeast Asia. And this is because the denominator is number of countries. We can see, I just counted the number of countries in Europe, counted the number of countries in Asia. We have the same number of countries. It's not as if we have fewer countries. So very few countries in Southeast Asia have done much to reduce salt intake. Obviously, for any policies or strategies to work, we should try to find out what's the best policy, the best returns that we will get for our investment. And so a systematic review has been done that looked at different strategies. And what was found is that mandatory reformulation alone would achieve the greatest reduction of salt intake in the population of nearly 1.5 grams. So that is very, very, in some ways, very effective in getting people to reduce the salt. And of course, other strategies like voluntary reformulation, school interventions, labeling, education, and all that also reduced to a lesser extent. But if all these strategies are done together, we can then achieve far greater than the 1.5 grams per day. And this is well illustrated in Korea, in your own country, where in 2012, and I think our first speaker did allude to this to some extent, where knowing that half the population were consuming more than 10 grams of salt per day, they instituted the goal to reduce sodium intake by 20%, quite modest, to nearly 4,000 milligrams, which is about 10 grams. By 2020, they gave themselves 8 years, and they included 5 key components. One was consumer awareness campaign to try to change behavior of food consumption, increasing the availability of low-sodium foods in schools and in work sites, low-sodium meals in restaurants, voluntary reformulation, and this is voluntary, not even mandatory, of processed food to lower sodium content, and the development of low-sodium recipes for foods prepared at home. Because we've done qualitative studies, we've done KAPs, and many of the public say, we don't know how to prepare delicious tasting food at home with low salt. And so therefore, Korea did this in their strategies. And by 2014, in 2 short years, they managed to reduce dietary salt intake by 23.7%. And so this tells us that multi-component interventions have great potential to reduce population sodium intake. So all these components will need to involve both upstream and downstream interventions. And so generally, if these are all done together, it can achieve great reductions in salt consumption across an entire population. Some of the advocacy work that has been done, and this is just sharing the experience in Malaysia. We set up the Malaysian Society for World Action on Salt, Sugar and Health. We call it MyWash. It has been endorsed by the National Society of Hypertension, affiliated to the ISH and World Hypertension League. We have done a lot of educational events for the last 2-3 years. And just recently, we launched a campus-wide salt reduction in Sunway University, where we got all the food vendors to lower their salt intake by 30% in 3 months. So we're going to measure their salt intake very soon. I mean, not salt intake, the salt in the foods in December. We also convened a what we call MySalt, which is a Malaysian Salt Action Leadership Teamwork just at the beginning of last month. Basically, we got together all the Malaysian stakeholders, all the ministries of health, education, agriculture, the universities, researchers, the scientists, and we targeted the out-of-home sector because in Malaysia, 79% of the people eat out, and we had the views of the food vendors, the food manufacturers, the challenges they have, and we shared it with these stakeholders, and we made recommendations based on our research findings, and hopefully they will implement many of these findings. And more recently, we also convened a sea salt meeting, which is similar to the MySalt, but this time it involves Southeast Asian leaders, again, the ministries, the health promotion boards, and we shared what is going on in our own country, shared best practices, what worked well and what not so well. And the aim of this meeting was that we develop recommendations for implementing salt reduction to improve hypertension management in Southeast Asia. And the latest proposal that we have is to form the Asia Salt Consortium so that we can all agree on common strategies to enable salt reduction in Asia because the intake is high. Agree on mandatory salt labeling on manufactured foods because we sell food to each other. What if your food comes in my country without labeling? It just causes confusion and so on and so forth. Reformulation of food to have lower salt content. Set the maximum salt levels in foods. For example, in my country, 20 food items have been identified where they cannot, there is a maximum level of salt that they have to adhere to. And then, of course, to try to encourage the use of salt substitutes because we know it does work quite well. And hopefully that these strategies will be in place. It's important as we manufacture foods and export to each other. And then finally, with the Asia Salt Consortium, we want to form an Asia Salt Consensus. And this is primarily because many Asian countries, as you see, they don't have many strategies. The ministries do not make a move. I don't know whether they're afraid or what. But they say if we have a consensus that comes from Asia, that would nudge them to move forward. And so that is our plan, to help to move towards faster and greater reduction in salt intake. And not just have a piece of paper, but for them to put these policies, these recommendations into action so that we can see some outcome at the end of a time period that we are setting. With that, thank you very much for your attention.
Thank you, Dr. Chia. That's excellent presentation. Really good to hear about all the work that going on in Malaysia. So we're going to next talk, the last talk of the session from Dr. Stephen Juracek. He's from the Harvard University. He got MD and PhD from Johns Hopkins University. His talk is less sodium, more potassium. So we're going to talk about potassium this time, or both population-wide strategies to prevent hypertension. Thanks.
Great. Thank you so much for this honor to speak with you all today. I'm going to be talking, as was mentioned, about sodium, potassium, and both. And so will be some elements that you've seen already, but hopefully some new elements as well. As a disclosure, I'm supported by National Institutes of Health and the American Heart Association on 2 trials related to optimizing sodium and potassium ratio in groceries. So I'll start by focusing on sodium. And we've seen various different versions of this already. However, this map here demonstrates how much cardiovascular mortality might be attributed to excess sodium consumption throughout the globe. And you can see, and it's been stated, that we're just really consuming too much sodium worldwide. Almost every region is either in the yellow to orange-red area in terms of deaths per million attributed to sodium. And trends aren't really improving. This figure shows regions of the world and in both 1990 and 2010, so 21 different regions. And you can see that in general, each of these, the upper circle is the 2010 estimate, and you can see that sodium intake has been increasing nationwide. And here we have the WHO recommendation and AHA recommendation. So we're already not doing very well, and it seems like trends have been heading in the wrong direction. This was shown previously, one of the early studies demonstrating the relationship between sodium excretion and blood pressure, right? So an ecologic study of 52 different countries kind of put this idea of sodium and blood pressure on the map. And as was mentioned, and this is a recent study of indigenous populations in Colombia, but this idea that we have hypertension with aging may not be a physiologic or pathophysiologic phenomena, but rather related to our environmental exposure to sodium. And in this a particular study, the investigators went to 2 different tribes in Colombia. The Aquana individuals were exposed to, had more sodium in their food, more Western influence. And the Yanomami individuals had minimal Western contact. And you can see that there's age-related hypertension here, potentially related to sodium, and then here, no age-related hypertension. And so regardless of children to adults, everyone had an average systolic of around in the 90s. We also know that there's ecologic evidence in support of sodium intake across countries with respect to deaths from stroke, as demonstrated in this left panel here. And on the right, this is a study that was conducted in the UK looking at a program to reduce of sodium trends and blood pressure trends in the population, as well as deaths related to ischemic heart disease. And what you can see is that there's, in general, similar trends as sodium intake has gone down in the UK. What about getting down to the more mechanistic or individual physiology data, right? We see here this nice, one of the early works by McGregor and colleagues in the Lancet in 1989, where 3 different sodium levels were associated in dose-response fashion with blood pressure. And then I think the largest study, and this has been demonstrated in prior talks, DASH sodium, 412 participants of average age 48, not on hypertension treatment, were fed 2 different diets for over 12 weeks, the DASH diet and control diet, and they underwent in a crossover design 4 weeks of different sodium levels. And this figure, as demonstrated, showed not only the reduction from DASH, but even within a healthy diet or in control, a typical American diet, there was incremental reduction in blood pressure with each gradation of lower sodium. And so the high was a level typical at the time, intermediate, the current guideline around the 2300 that we see, and then low was a 1500 milligram per day for a 2100 kilocalorie diet. And so a more optimal level. And in a secondary analysis, we further demonstrated that the impact of sodium was even greater among individuals with high baseline systolic or diastolic blood pressure. And so sometimes we think, oh, well, lifestyle is really for those with mild hypertension, but the reality is you can get very large reductions from sodium reduction to the magnitude of 10 to 20 millimeters of mercury. And there have been so many trials of sodium over the years. In this meta analysis of 85 trials. They noted a linear relationship between sodium intake and reduction in systolic and diastolic blood pressure across the entire range of dietary sodium exposure, independent of baseline blood pressure, with greater effects in participants at higher baseline blood pressure. So many of the things we saw in DASH sodium, they observed through this meta-analysis as well. So sodium is really a potent determinant of blood pressure. How does sodium reduction compare to other lifestyle interventions? We saw some data from TOPE earlier, but this is trials of hypertension prevention. They enrolled over 2,000 participants, middle age, with a diastolic blood pressure of 80 to 89. It was a parallel design with 3 lifestyle change groups over 18 months. And so here are the lifestyle change groups: weight reduction, sodium reduction, and stress management versus usual care. And then there was also the supplement design, which followed crossover 6-month period separated by a washout. And they looked at common supplements: calcium, magnesium, potassium, and fish oil. And what they found was that the only 2 lifestyle interventions that lowered blood pressure were weight reduction and sodium. So really the foundation of many of the guidelines currently around lifestyle for management of hypertension. We also saw this figure earlier as well. This is the long-term follow-up of TOPE, and I think it's really telling that there's this sort of legacy residual effect with respect to the cumulative incidence of cardiovascular disease, in that those on the sodium intervention continue to have lower risk of these adverse events. And in a second analysis, Nancy Cook and colleagues also demonstrated similar findings with respect to all-cause mortality. What about over the lifespan? This is a really fascinating trial that was conducted in newborn infants over the first 6 months of life. About 500 infants, half were given a normal sodium formula and another a low sodium formula. And you can see that over these early weeks of life, blood pressure was reduced among the infants with the low formula. And in an interesting extension study, when they rechecked many of the children at age 15, they noted their blood pressure continued to be lower, trending with the original low sodium assignment, suggesting that this is really important for the development of vasculature early in life. There's also benefits from sodium reduction in older adults. In this trial of non-pharmacologic intervention in the elderly, the TONE trial enrolled about 1,000 participants, ages 60 to 80, with a systolic blood pressure less than 145, diastolic blood pressure less than 85, taking a single antihypertensive medication, or it could be a combo single pill with low dose. And they conducted a factorial design where they had people either do weight loss, sodium reduction, or both over a 3-month period. Then they withdrew their antihypertensive and followed folks for up to 36 months. And they were looking to see if people had high blood pressure requiring reinitiation of therapy or a cardiovascular disease event. And what they found is that the combination of weight reduction and sodium reduction was the best, had the lowest incidence of these outcomes, but then both sodium reduction or weight loss similarly reduced or maintained people free of medication and with lower blood pressure for over the follow-up period. There's great evidence for population-wide replacement, and I was happy to see this slide earlier as well, which focused on sodium education intervention in 2 Portuguese villages. And the really nice thing about this study is that they showed significant differences at 1 year and 2 years, so there's a maintenance of effect over time related to sodium reduction. Okay, now what about more potassium? Right, so we talked about this linear trend for sodium with respect to systolic blood pressure, but potassium in this meta-analysis of 32 trials, similar first author, was not quite as consistent. And you can see that first in this early increase, there was a reduction in systolic blood pressure, but if you increased potassium further, this kind of blood pressure reducing effect was not necessarily maintained, at least not in the same kind of linear fashion. And so why is this the case? There's evidence that sodium or potassium impacts on blood pressure are influenced by ambient sodium. And so in this stratified analysis in this study, the Filipinian colleagues showed that those with low baseline sodium excretion seem to have virtually no effect from potassium on systolic blood pressure, but then those with a modest intake had that initial early reduction from slight increases in potassium that was less pronounced at even greater increases. And then those that benefited the most consistently were individuals with a high ambient sodium level or excretion. And so why would this be the case? Why would those with highest sodium intake benefit the most from potassium consumption? And so part of it has to do with renal, or primary reason is renal handling of both sodium and potassium. So high plasma potassium can cause impacts on cells in the distal collecting tubule that can affect this wink and spank pathways, causing a de-expression of a sodium cotransporter, NCC. And as a result, there can be more sodium and volume flowing through the kidney to the collecting duct. And ultimately, this sodium can be reabsorbed by the ENaC channel, causing, in the setting of higher aldosterone, activation of this ROMK channel, and then subsequently excess wasting of potassium. And so the result of that can be downstream further salt retention. And so you can kind of see that there's not a single direction or pathway, but rather a potential cycle with prolonged or higher exposures to potassium, if, especially if there's not as much sodium in the diet. Nevertheless, there has been good evidence in a number of trials that potassium is effective for blood pressure reduction. This was an early study in the Annals in 1991 that looked at dietary potassium for antihypertensive medication requirements. And so this is a small study of 37 adults where they were fed fruits, vegetables, and beans versus control. And what they found is that those on the diet, about 38% of patients were able to be off of medication over the course of the year, and there was a 50% decrease in medication requirements during the course of the study. This might not be a study we would consider doing today, but demonstrated the power of potassium for hypertension management in those who are treated. This is another really important study to highlight from Fred Brancati and colleagues in 1996 in 74 African American adults. And what they found is that in this population of individuals often thought to be more salt sensitive, that there was increased reduction in blood pressure over time with extended exposure to higher potassium or potassium supplementation. One of the biggest concerns about potassium has been traditionally the effects or potential for hyperkalemia. In this study called CKDK, we looked at 28 adults who had chronic kidney disease and a higher potassium and lower potassium diet. And here you can see the baseline serum potassium level, and this is the high potassium, and the low potassium is a crossover design. And you can see that there is indeed a shift in serum potassium related to higher consumption levels. And if you look at the kind of net increase, it was about 0.5 millimoles per liter, though some individuals experienced as much as a 1 to 1.5 increase. And there were a couple additional cases of hyperkalemia during the study, but I'll note that many of these were mild and did not persist with repeat testing. And there was even one case of hyperkalemia among those assigned to the low potassium phase of the study. And so among the individuals with CKD, this is a real concern that sometimes may not even be related to the diet. Okay, and now what about both sodium and potassium together? So there have been great studies looking at, as was alluded to earlier, the idea that the two of these, reducing sodium while increasing potassium, can be really a potent combination. And in this step wedge cluster randomized trial of 2,000 participants in 6 villages in Peru, Barnaby Ortiz and colleagues demonstrated they used a potassium-enriched salt to replace regular table salt in households. And what they found is an average reduction of about 1 millimeter of mercury of systolic and diastolic blood pressure, which might not seem like a lot, but when translated over time into risk of developing hypertension, there was a 51% reduction of that risk during the course of the study period, suggesting that something very simple but yet quite potent could prevent progression to hypertension. And then one of the biggest studies, and maybe one of the most important of recent years, conducted in 2021 in China, the SAS trial, looked at 600 villages in rural China, 20,000 adults with higher risk of stroke, and they also took the strategy of potassium-enriched salt to replace regular table salt. There was also some education, and they noted significant reductions in stroke, the primary endpoint, MACE, and all-cause mortality, with no effect on safety. And in random sampling at various time points throughout the study, they noted about a net reduction of 3 to 4 millimeters of mercury in systolic blood pressure. And here are the cumulative incidence plots, and you can see the significant reduction in stroke, MACE, death from any cause, and no real increase from risk of hyperkalemia. Interestingly, the study team went back to their data to try to estimate, answer the question, well, what was more important? Was it the potassium or the sodium with respect to the effects on adverse outcomes? And so they used random sampling of 24-hour urine, potassium and sodium. And, the idea or question was raised because when you looked at the 24-hour potassium data, there was the percent increase was greater than the percent reduction in sodium. And now some people say, well, that's because there wasn't enough potassium being consumed at baseline. So of course, even a small increase is going to be a larger percent increase. But nevertheless, it raised this question that maybe potassium was the most important component. And so they used the 24-hour data to back calculate how much replacement actually occurred. And what they found is that it looked like people might have actually been increasing their regular table salt despite the intervention, and that the potassium enriched salt only replaced about 72% of the table salt in the study. And yet, even with that partial replacement likelihood, there were still those beneficial effects observed on stroke, MACE, and premature death. And so I think this suggests not only the real power of potassium-enriched salt to counteract high sodium intake, but it also kind of demonstrates some optimism for a lot of other countries where partial replacement may represent a more likely scenario or be more achievable. I think it's also important to note that both of these micronutrients may have different mechanisms of protection for cardiac injury. This is just, again, going back to the DASH sodium trial, and we measured high sensitivity troponin I and NT-proBNP. And you can see for troponin, sodium didn't seem to have much of an impact on a subclinical cardiac injury, but there was a 14% reduction from the DASH diet, which is higher in potassium, magnesium, calcium, suggesting that that might be a mechanism by which the diet is cardioprotective. But for NT-proBNP, it's a marker of heart strain. Sodium was very strongly linearly related to NT-proBNP, suggesting that sodium may be really important even at the lower levels for preventing unnecessary heart strain. Some practical considerations. It's important to recognize context. I think this was illustrated earlier, but in China, for example, 76% of salt is added during the process of home cooking, which I think is true for a number of other Asian countries. In the United States, 75% of sodium is already in the food when you bring it home from the grocery store or when you go to a fast food restaurant or what have you. And as a result of that, strategies to reduce sodium or introduce potassium may have to differ based on that cultural context. The FDA has taken the approach in the United States of establishing voluntary targets, monitoring the food supply for response, seeing how we're progressing towards those targets, then engaging with stakeholders and trying to be iterative to make progress. But it can be challenging when you're trying to address the food manufacturing side of things. We put together this simple schematic to just try to illustrate some of the evidence for various different strategies to introduce potassium, reduce sodium. And so, you know, at the individual level, there's great evidence for that with potassium enriched salt. But it's important to consider, you know, the role of meal preparation practices and safety concerns with this type of approach. If you're targeting the industry level, trying to get at those kind of processed foods, there's some observational evidence in favor of this. It would require some industry regulation, which can be challenging, have important political implications, and safety still continues to be a concern. Other strategies like potassium supplementation, there's been good evidence for that, but it's important to recognize that supplementation is still a behavioral change, and so just like with medications, it requires adherence, access, and can be associated with costs. Potassium fortification hasn't been talked about as much. That's just simply adding potassium to foods, but it has some of the similar industry regulation and safety concerns. And then when we think a lot about the idea of, of a diet, this is something we would really want people to do. Well, there's a lot of challenges here, right? Healthy foods and groceries can be expensive, requiring some subsidies. There needs to be more public health education around consuming and choosing healthy foods to improve health. I'll point out that with regards to potassium and safety concerns, there have been some really nice modeling work done, and I'll highlight this one by Markland and BMJ, where they looked at the net deaths prevented from a potassium-enriched salt substitution, right? It would be almost 500,000, and then even more non-fatal cardiovascular events, saving about 8 million disability-adjusted life years, while the intervention could introduce about 11,000 deaths related to hyperkalemia. And so clearly a net benefit from this approach, but certainly when we talk about anyone losing life from an intervention or policy, it has to be taken very seriously. I'll point out too, this small trial we did around groceries called DIGA. We are focusing on gout and uric acid, trying to model a DASH diet with groceries. So sodium wasn't really an emphasis, but I'll point out you can really, if you focus on healthy foods, focus on fruits and vegetables, high potassium foods, you can often get sodium as a response or as a result of that, so 2 for 1. And so you can see this was us targeting food groups modeled after DASH. We were able to get very similar micronutrients, and even though sodium wasn't a focus, sodium was naturally reduced in the foods that were provided to the participants. This is another small study we worked on in the community among older adults residing in a subsidized living facility. These adults were on a communal meal plan. And so often we say, you know, and patients were like, oh, well, this is the principles of sodium reduction, increasing your potassium, but it might not be relevant for older adults that rely on others for their meal preparation. So it's important to consider this cultural, pragmatic context. And in this particular case, substituting the meal plan with a low sodium alternative resulted in 11 out of 11 individuals reducing their blood pressure with a pre-post reduction of about 11 millimeters of mercury. And then last, I just want to talk about equity and touch on equity and access. Often those groups with the worst blood pressures, the most delayed screening, may not have access to healthy foods, and this is something that we've increasingly tried to target, focusing on urban food deserts or high food priority areas to ensure that people can access groceries that are both high in potassium and low in sodium, which I think is important for all countries. And so in conclusion, high sodium consumption is a major driver of cardiovascular disease worldwide. Sodium efforts are critical to improve blood pressure and reduce CVD. Potassium is effective at lowering blood pressure in the context of high sodium diet, and potassium-rich salt may be a useful tool to counteract sodium intake. But effective strategies require tailoring to individual practices, communities, and policy factors unique to populations throughout the world. So thank you very much.
Thank you, Dr. Yurachek. Thank you for your great and intellectual lecture. Now, we are open to panel discussion and floor discussion. We invited 3 panels. Professor Sung-Ha Park from Yonsei University, Professor Taehyun from Yonsei University and Professor Yuda Trana from Indonesia. Talk about for this topic freely. After this session, we don't have any further session, so we have endless time. You can talk anything.
Yes, I thank all the four speakers for their wonderful talk. I have a question for Professor Shin. Yeah. I was just wondering, is there really evidence that Asians are more salt sensitive than Caucasians? Because the evidence that is put forth by the literature is that Japanese have more expression of salt sensitivity gene polymorphisms, and they have more nocturnal hypertension and non-dipping. But is there a direct comparison with Caucasians in terms of increased salt sensitivity in Asian population?
I'm afraid there isn't. And in fact, I wanted to propose a study to get a grant to look at that. And one of the experts said, that's a dead story. Don't bother to go there. So we gave up on the idea. But I think from a practical point of view, whether we are salt sensitive or not, it doesn't really matter because it is a salt intake. It just has a slightly differential effect of the impact on blood pressure in the sense that, say, if I take 1 gram of salt, my blood pressure goes up. In Asians, maybe goes up a bit more. In the Caucasians, it goes up a little bit less. So I don't think from a population approach, it is terribly important. And again, I also talked about, who is salt sensitive? How do we know which patient is salt sensitive or not? I suppose the only way to do is load them with salt. If the blood pressure doesn't go up, then they're not terribly salt sensitive. And we know that salt sensitive is only in 30% of the people. The rest of them do not have this problem. So from a practical point of view, yeah. In fact, I have a question to ask other speakers as well. The labeling of salt labeling, it is usually sodium. And I had actually proposed we should label it as salt rather than sodium. And of course, my ministry said, no, everybody is putting sodium and all that. And just recently, I noticed, I don't know when it came in, all the foods in UK, and they are a huge proponent of voluntary salt reduction, is now salt, not sodium. So I'm just wondering whether in Asia, we all should say we will label it as salt and not sodium, because it's going to cause confusion to the public. Salt levels of upper whatever limit you're supposed to take is different from sodium, causes confusion, that's one. And secondly, the potassium, whether potassium should also be mandatory labeling. These are just food for thought for ourselves when we are designing strategies. I don't know what the others think. Maybe Professor Jurassic, should we label it as salt or sodium?
It's an interesting question, and I agree with you. Public health messaging is very important.
Excuse me. Do you want to get the mic?
Back over you, microphone.
I know. So yeah, I completely agree about public health education and being clear with our labeling, because our nutrition facts are often very difficult for people. But one area that's interesting is the FDA just started proving the consideration of potassium chloride as a salt in order to promote adoption in a lot of food manufacturing. So there could be it could be a little bit tricky from that kind of strategy. If we start using salt in a more general fashion. But I agree with what you're saying.
For that, I can ask for Korean policy. In Korea, when you check the labeling of the food, in Korea, we only labeling for the sodium. And in Korean word, it is natrium. I have involved in the regulation of labeling. At that time, we have to choose a familiar term of Korean. In Korea, salt is not familiar. If we use salt, just means natural salt. But in many food, we have natural sodium chloride. If just describe salt, most people can think about it as adding salt, natural salt. So we have to decide to use sodium or natrium. It may depend on the country, different from Western country or other Asian country, is it? How about your country? Would you take a microphone?
I propose to my country to use salt because that's what people know. When you tell them sodium, they have no idea when you say salt. And I think the reason why I think salt would work is 90% of the food we take in terms of sodium is sodium chloride. So it doesn't really matter. A bit of sodium citrate, sodium whatever else hardly matters. So to me, the salt is the way to go because people can relate that you don't take more than 1 teaspoon of salt. That's what we tell them. We don't say 1 teaspoon of sodium. So in that sense, it's practical. And so finally, when they did not agree with me, I said, in that case, put both. I think it's going to cause confusion, of course. So I don't know yet which way we are going. But certainly England has changed, and UK is one of the people who came very early in terms of salt reduction. The other thing I also learned from all these things is, you know how mandatory salt labeling, reduction, reformulation works best? Don't do voluntary, because we called all the soya sauce people, manufacturers in my country together, and of course we gave them the whole story about what salt does and la la la, on and on, and to do voluntary and all that not. And then finally, one of them, after 2 hours of discussion, said, why don't you just tell us how much salt you want us to put and we will all follow? In other words, mandatory, not voluntary. And I think it makes life so much simpler. Just mandate it. Why give a choice? You know what I mean? We're not saying you reduce from 10 to half the amount. Nobody wants to do that. Just gradual, give them a timeline to do it, 10% per year or whatever, and then you reach the maximum level that you want.
Thank you. Okay, next question.
I'd like to ask a question to Professor Jurasek. In general population, the plenty of potassium intake is helpful for cardiovascular disease. However, our patients have been already taking a lot of medication to reduce potassium excretion in urine. So, however, a little but very serious hypokalemia can be occurred sometimes. Do we need check potassium level after the high potassium intake, and also how can we make an education to my patient to enhance potassium intake in that patient?
Those are great questions, and I think, you know, there's not really a simple answer. In some sense, we worry a lot about hyperkalemia, but yet when you think about groceries that have higher levels of potassium, you just really don't hear of a lot of cases of sudden cardiac death, for example, coming from eating maybe too many bananas or something like that. So sometimes I feel like our concerns might be maybe out of proportion with the reality. Dietary sources of potassium, it's really tricky to increase your potassium quite a bit, and a lot of the studies that I've looked at really required very careful titration, sort of metabolic kitchen to construct high potassium diets. In our grocery intervention study, it's been a lot easier to reduce sodium than to actually ensure people are getting the potassium targets that we'd like them to. And part of that is just, you know, at least in the United States, some of the most common sources of potassium are dairy products like potatoes and like fruit juices. So they're not necessarily foods that we want to emphasize as part of a healthy diet. But to your point, you know, and I've been reflecting on this quite a bit. For a number of these individuals that have either medications or conditions causing them to have high potassium, they are often already undergoing some degree of monitoring for their potassium level, and then adjustments can be made for them, or warnings can be given if the potassium level is too high. And so part of me kind of wonders if we were to introduce more potassium-enriched salt formulations into our food supply, those individuals would still be undergoing monitoring and still have the opportunity for the same kinds of interventions that we are applying now. It just would be a different set point, and likely more folks that need that kind of discussion. So I still think the net benefit is worth considering. But I agree, thinking carefully about those with chronic kidney disease, potassium sparing or increasing medications is very important.
Your turn.
Yeah, thank you. Thank you for the all speaker for the wonderful presentation. In Indonesia, we have this study that is more easy to change behavior, like to take the medication regularly. But it's very difficult to change the culture about the salt intake reduction. So I want to know, maybe to all speakers, especially in the situation in Asia with still high prevalence of hypertension, with the population with salt intake, very high salt intake and salt sensitivity, and also with the low education level. So what is maybe the sharing from all the speakers, if have the comprehensive program that may be prioritized to this kind of the population. Maybe need suggestion to all the speakers. Thank you.
Do you have any other comment or answer question? Professor, please.
So I would like to check your question. So your question is, what will be the population-wide program in order to reduce the sodium intake at the population level? Is it correct? So as I earlier said in my presentation, or also the other speakers in their presentations, the most important aspects is to establish upstream intervention measure. I mean, that the intervention, they are more structural component to target the setting where the behavioral changes occur. So sometimes the encouraging the changes in behavioral modification is a kind of the downstream intervention. That is a kind of the inactive approach, rather the upstream intervention, I mean, to making the policy at the population level would be more beneficial in this case, I think.
So if I make a comment, we have to approach in two ways. When you care our patient, we have to approach in individualization, but in general population, we need population-based approach. And in this point, I am very proud because I have involved in the salt intake reduction campaign in Korea. We started that from 2011. The name of Sodium Intake Reduction Campaign Group. It was supported by government. We used newspaper, television, YouTube, and we also Korean FDA made many legislation to reduce salt intake. We also asked the food industry to reduce content of salt, especially ramen. And many bakers, we asked to reduce salt intake, content. After 10 years of our effort, as Professor Sin showed there, when intersalt study in Korea, the salt intake was more than 250 millimole. But nowadays, it reduced to 130, is it? 130 milligram, 30 millimole. Yes, we can reduce in the population level, but individual level, we have to make an effort with an individual approach. Is my comment. Do you have any other comment?
Yeah, this has been such a great discussion, and I completely agree that it's really a multi-prong approach, and I love hearing this progress in Korea. I wish we could do something very similar in the United States, because I do really think there needs to be something at the policy level, even before people are presented with products. Those products are, there's been some regulation on how much excess salt or sodium is contained in those products, and that's conveyed clearly to consumers so that they can make good choices. But then I also think at the individual level, I agree, behavior change is very challenging. Now, it's really important, and many people will say, I don't want to take medications, I'd rather do it by lifestyle, so it's kind of patient-centric in many ways, but it can be challenging to make those adjustments. And one thing we've been finding in our grocery studies is, we deliver groceries to people's homes at their doorstep in a pattern that's consistent with the DASH diet. But there still can be a lot of barriers to actually eating those food. Even though they're free, even though you don't have to go to the store to get them, that can be, while there's many different family members that are eating with us, they might not want to eat those kinds of foods or make those changes. We've had young people who don't know how to cook and for themselves. They don't want to cook for themselves. They'd rather eat out, right? And then sometimes older adults, they have, osteoarthritis. Chopping up vegetables is very difficult for them, and they also don't feel very motivated. They're not that hungry. They're not motivated to eat a lot of food. And so I think trying to break down the individual situations and customize an intervention to change behavior, I think is really critical for long-term maintenance. So, but I think it takes both, right? The policy and the individual.
Thank you for your comment. Do you have any question?
No, I guess I just want to keep comments that I want to congratulate the Korean Society of Hypertension or other society get involved in this reducing salt campaign. Actually, that is really, I think, amazing for us to see, because in the U.S. and large countries, we cannot do that kind of thing at this point. So I want to congratulate. And I want to conclude this session, and I'd like to thank all the speakers and all the panelists as well. Well, we'll see you next tomorrow or this evening.
Yes.
Okay. Thank you, everyone.
And before complete close of this session, we very thankful for the attendees and Professor O, you, Professor Tirana, Professor Chia, Professor Yurachak. Please come to here.
Flag of operation, Yongsuk O. In deepest Yongsuk O. In deepest appreciation for your dedication and contribution to the Korean Society of Hypertension as an invited faculty of Hypertension Seoul 2024. In conjunction with the in the conjunction of 61st scientific meeting of the KSH, November 8, 2024. Professor Stepan Juracek. Stepan Juracek, in deepest appreciation for your dedication and contribution to the Korean Society of Hypertension as an invited faculty of Hypertension Seoul 2024 in conjunction with the 61st scientific meeting of the KSH. Next is Yukchin Sia. In deepest appreciation for your dedication and contribution to the Korean Society of Hypertension as an invited faculty of Hypertension Seoul in 2024. Thank you. Yuda Trana, please. In deepest appreciation for your dedication and contribution to the Korean Society of Hypertension as an invited faculty of Hypertension Seoul 2024 in conjunction with the 61st scientific meeting of the KSH. Thank you.
준비하느라고 수고 많이 했어요.
Love paints the street and inspirations.
So romantic.
Excitement's in the air, it's a playground. Walking light, soulful cities call.
So fantastic. 발길 닿는 곳마다 사랑이 가득하니까. 여기 서울에서 너만의 소울을 느껴봐. Feel so good. 서울 my soul.
전 세계 사망 위험 요인 1위, 매년 1,000만 명을 사망케 하는 고혈압. 정기적인 혈압 측정만으로도 나와 내 가족을 지킬 수 있습니다. 뇌, 심장, 신장, 눈 등 주요 장기에 조용하지만 치명적인 손상을 일으키는 고혈압. 전 세계 고혈압 환자 중 절반은 자기 혈압을 인지하지 못하고 있습니다. 나트륨, 지방, 흡연, 음주를 줄이고 가벼운 운동과 적정 체중을 유지하여 모르는 사이에 건강을 침범하지 못하도록 고혈압을 예방하고 행복을 지킬 수 있습니다. 나와 내 가족을 지키는 방법. 혈압 측정부터 시작합니다.
Love my soul. 서울에 오면 사랑에 푹 빠지게 될 거야. So lovely. So romantic. So fantastic. 발길 닿는 곳마다 사랑이 가득하니까. 여기 서울에서 너만의 소울을 느껴봐. Feel so good. 서울 my soul.
전 세계 사망 위험 요인 1위, 매년 1,000만 명을 사망케 하는 고혈압. 정기적인 혈압 측정만으로도 나와 내 가족을 지킬 수 있습니다. 뇌, 심장, 눈 등 주요 장기에 조용하지만 치명적인 손상을 일으키는 고혈압. 전 세계 고혈압 환자 중 절반은 자기 혈압을 인지하지 못하고 있습니다. 나트륨, 지방, 흡연, 음주를 줄이고 가벼운 운동과 적정 체중을 유지하여 모르는 사이에 건강을 침범하지 못하도록 고혈압을 예방하고 행복을 지킬 수 있습니다. 나와 내 가족을 지키는 방법. 혈압 측정부터 시작합니다.
이게
제가요? 몰라요?
하다 떨어지지만 않았으면 되는데.
영상이 보여주셨으면 좋겠는데.
나도 지금 영상도 영상인데 지금 업로드하는 그것도 안 된다.
왜?
Love my soul. 서울에 오면 사랑에 푹 빠지게 될 거야.
In the heart of the city where
So lovely,
love paints the street and inspirations are
so romantic,
excitement in the air. It's a playground of delight. Soulful cities call.
so fantastic. 발길 닿는 곳마다 사랑이 가득하니까. 여기 서울에서 너만의 소울을 느껴봐.
뇌, 심장, 신장, 눈 등 주요 장기에 조용하지만 치명적인 손상을 일으키는 고혈압. 전 세계 고혈압 환자 중 절반은 자기 혈압을 인지하지 못하고 있습니다. 나트륨, 지방, 흡연, 음주를 줄이고 가벼운 운동과 적정 체중을 유지하여 모르는 사이에 건강을 침범하지 못하도록 고혈압을 예방하고 행복을 지킬 수 있습니다. 나와 내 가족을 지키는 방법. 혈압 측정부터 시작합니다.
Love my soul. 서울에 오면 사랑에 푹 빠지게 될 거야.
In the heart of the city where
So lovely,
love paints the street and inspirations are
so romantic,
excitement in the air. It's a playground of delight. Soulful cities call.
so fantastic. 발길 닿는 곳마다 사랑이 가득하니까. 여기 서울에서 너만의 소울을 느껴봐. Feel so good. 서울, my soul.